So this is it. Neurology and special senses. This is the first page. It's about the embryology. The main thing that they want us to note here is the significance of notochord and nucleus pulposus. So these are the two things they are most likely going to be testing us on with respect to this area. So you just want to know, it's just a very simple logic here. Notochord induces process of neurulation. So the process of the formation of the spinal cord and the likes, everything starts with notochord shaking out. That's all. That's all what they are going to ask. They will just tell us and give us a question that is related to spinal cord development, and now ask that which structure is important in the formation of this, blah blah blah. So the answer will be notochord. So when the notochord is inducing that, what will the notochord itself eventually become? Nucleus pulposus. Question number 2. So that's what it will eventually become. And that's what you just see in the option. So they may write a long story, but the hallmark of the whole story is just to test this notochord. So now there is something you just need to have an idea here, because it's going to be important in the subsequent area. Just what is happening in the process. This is the notochord. It's just going to induce the ectoderm that is here to just become the neural plate. So then the neural plate starts folding. Can you see? Just from the side. And before you know, you have a neural fold. From the neural fold, you also have at the center neural groove. Then the neural fold, the lateral head will now meet and eventually form the neural tube. Can you see? Meeting, then they form the neural tube. Then around the like the peripheral part of it, you see these neural crest cells, and that's all. So what this means, just the way they have drawn it here, this neural tube will develop into the brain and the spinal cord. So, why don't we just say central nervous system? Okay, because it's centrally located. Yes, call it central nervous system. So this neural tube will develop into the central nervous system. Then the neural crest cell is peripherally located. You say yes, that's when we develop into peripheral nervous system. Shaking out. So they can now give us all manner of cells that are related to peripheral nervous system. You just pick and just say neural crest cell, neural crest cell. Where is this one coming from? Neural crest cell. Where is that one coming from? Neural crest cell. Shaking out. That's what they are going to test there. We have this alar plate and the basal plate. The alar plate, they also call it the dorsal plate. So which is for the sensory, because anytime you draw your spinal cord, this is what you usually draw. You draw something like this. So something like this. This is what we most of the time draw. So this dorsal part is actually for sensory, while this ventral part is actually for motor. So what is going to help in the proper development of this alar plate? So you say the bone morphogenetic protein, BMP. What about the ventral plate? You call it sonic hedgehog, and that's all. So, and I look for a way to put it for us so that at least you can play around with those words, but I doubt it if they are going to test it with you, but just want to note it too. And that is, I call this alar plate ASB, the basal plate BMS. I think Dr. Precious, I think they used to call themselves BMS, BUTH medical student, or what they used to call themselves there. So sorry, but I think that may make sense to her anyway. Just BMS, you can also attach something, anything that you wish to it. The BMS is basal plate. M here is the motor, and S is the protein that is important in its proper development. SHH, sonic hedgehog. Then ASB is alar plate. S is the sensory. The B is the bone morphogenetic protein. Just want to write it down once or twice. You're already okay with that. You leave it. And that's all about this place. Then we come to what we call the regionalization of the neural tube. So we have what we call the primary vesicles. Primary because they are the first vesicles. Secondary vesicles because this one emerged from the primary vesicles. Then we talk about the derivative you can get from them. The three primary vesicles that you don't want to forget, they are this prosencephalon. The second one is the mesencephalon. The third one is the rhombencephalon. Well, the name may come from the way they look. This rhombencephalon look like rhomboid. Let us call it rhombencephalon. Then this is pro. Pro means like something primary. So, and that's that. So, prosencephalon, mesencephalon, rhombencephalon. I don't want to joke with this area because I'm going to show you how they test this area. The prosencephalon is for forebrain. At least all of us know forebrain. The mesencephalon is for midbrain. The rhombencephalon is for hindbrain. You now notice that the prosencephalon we divide into two. The rhombencephalon we also divide into two. However, the mesencephalon does not divide. Okay, so what does the prosencephalon divide to? Telencephalon and diencephalon. The mesencephalon continue as mesencephalon. The rhombencephalon will now divide into metencephalon and myelencephalon. Okay, let us look for how we are going to note this. The telencephalon is the first one we'll be having, followed by the diencephalon. Then you come to this midbrain and the hindbrain. You have mes, you have met, you have myen. You are likely to get confused in the exam with them. So the way you arrange them is with, all of them start with letter M. If you arrange them alphabetically, you are going to have something like S before T, then T before you get to Y. So it's going to be mesencephalon, metencephalon, myelencephalon. That's all. And don't forget that the last two, met and myen, they come from hindbrain. And the first two, tel and dien, they come from the prosencephalon, which is for the forebrain. The mes will continue as the mes, which is for the midbrain. What are the structures that come from each of them? The telencephalon will give you cerebral hemisphere, basal ganglia. The diencephalon will give you thalamus, hypothalamus, retina. All right. The mesencephalon will give you the midbrain. And apart from the midbrain, we also talk about, okay, I'm going to talk about the vesicles in them, cavities in them. Then what of the metencephalon, pons and cerebellum, myelencephalon, medulla. Now let's look at it critically. I look at how are we going to remember the structure that come from each of them. We know what we call TBC. We use it in the theater where after surgery to actually paint the surrounding of the upsides. TBC. So we've been using it in cardio too. We are bringing it here. So this T is the telencephalon. The B is the basal ganglia. The C is the cerebral hemisphere. So I already know if I thought they give me a lesion in the basal ganglia, then I say what is the embryological origin of the structure that is affected in this patient? A, diencephalon, B, telencephalon. You just look at it, TBC, telencephalon. Okay, basal ganglia, that is telencephalon. You just choose the answer, you go. So you need to rehearse this, practice it on paper. You will get used to it. So diencephalon. So that's this D. So this is THR. In one way, we all know about, let me change it to DHTR for you. Let me change it. DHTR for you. So at least it looks like dihydrofolate reductase. It's an enzyme you are all used to. So you can call it, this still look like F. So dihydrofolate reductase is an enzyme that everyone knows. Why don't you bring it here? So we can just call that D dienkevalon, H hypothalamus, T thalamus, R retina. So that's for the dien. The mesenkevalon will continue to be the midbrain. The metenkevalon we now, if I ask all of us that we should arrange the brainstem, everyone will be like, we have the midbrain, we have the pons, and we have the medulla. That's how everyone will arrange it. So, if I now say, where are you going to see cerebellum? Everyone, most people will be, don't let me say everyone, will be like, you see it around the pons, then the upper part of the medulla. That's how most people will look at it. So you can now say that, okay, since mesenkevalon continue to form the midbrain, okay, for the metenkevalon is going to form the pons and the cerebellum, while the myenkevalon is going to form the medulla. Shikena. And that is just all. So they can now give you any lesion here and just say there is a lesion in the midbrain. What's the embryologic origin of it or something? What's the primary, from which primary, what's the name of the secondary vesicle that develop into the affected structure? You just look at it, which structure are you talking about? If it's thalamus, you just quickly be like, I remember Festus was writing DHTR or something like that. Okay, that's dienkevalon. Oh, they give you a lesion in the cerebral hemisphere. I remember that guy writing something like TBC, because that's the only one with C. There is no any other one, okay, except the cerebellum, which is down. So that one will be telenkevalon. And that's how you practice around these guys. They can give any of them and just say, where is it? From which secondary vesicle is the affected structure coming from? So the last thing we'll talk about here is actually the cavity. The cavity here, you must note it very well. In fact, they give more regard to cavity compared to these walls that develop from them. So the from the prosenkevalon, you develop, we're going to look at them together. Prosenkevalon, you develop the lateral ventricles. Can you see the lateral ventricle? This is one, this is also one. And you also develop what we call the third ventricle. Why don't we have second? Because the two lateral ventricles are actually pictured as first and second, but they don't call them first and second ventricle. Which one are you going to call first? Which one will you call the second? So just call them two lateral ventricles. So this is the one, this is the second, then this is the third ventricle. Now, I want you to note something here. There is an opening between the lateral ventricle, the two lateral ventricle, and the third ventricle. So you call it, where is the opening located? You say between two ventricles. Okay, which name would you have given it? I'm very sure if you were to be in the shoe of the writer, you will have called it interventricular. Interventricular, because it's actually between two ventricles. Of what? Of Moreau. And that's all. But are they going to be asking me to be putting foramina of Moreau? I mean, Moreau there. They don't really care about all those big words. Interventricular foramina, Shikena. So it's actually between two ventricles, just one opening, this opening. That's what you will eventually have there. And that's all about the process. So what about the midbrain? The the cavity you have there is what we call cerebral aqueduct. I'm very sure someone will have been adding of Sylvius to it, but they don't care whether you remember that it's of Sylvius or it's of Sylvester. No, they don't care. So cerebral aqueduct is cerebral aqueduct. That's that about the midbrain. What about the rhombenkevalon, the hindbrain? Here you have fourth ventricles, and we also have some foramina there, Luschka and the Magendie, but we're going to look at it later. Now, what I want you to picture here is this. They might tell you that this patient has hydrocephalus, and the lateral ventricle, the two lateral ventricles are dilated. The third ventricle is also dilated, but there is no dilatation at the fourth ventricle. Where is the lesion? That's the question. For the two lateral ventricles to dilate and the third ventricle also to dilate, but there is nothing in the fourth ventricle, it shows that this cerebral aqueduct is stenosed. It's narrowed. So the CSF is not flowing through it. It's not flowing through it. And that's why you have the proximal cavities dilating. And that's all. So you don't need to sit down for hours before you master this. You just picture it and you go. They can frame the question anyhow they like. They might tell you that it's just only one of the lateral ventricles that is dilated. If it's one, then definitely this interventricular foramina, one of them is actually stenosed. It's closed. So the CSF that is produced within cannot flow out. And that's all. If it's the two of them alone, they say are dilated, but the third ventricle is not dilated, you will also be thinking towards interventricular foramina that is affected. That's where the lesion is shaken. Do you get it? So that's how you'll be reasoning this one out. We are still going to look at it. You need to understand the logic there. Yeah. Then you come down to the neural tubes. They love to ask a lot of questions here, and I'm going to try to show you the simplified way of looking at it. Everyone here knows about neural tube defects. There is no one that will be.
Sorry, Dr. Festus, you've skipped one.
Oh, sorry. Thank you so much. Yeah, the thing was down. So, thank you. So we have this central and peripheral nervous system origin, and this is very important. Okay, what do we have here? We wrote something the other time. This is what we wrote. That this is the neural tube, or I showed you. Then I now show you the neural crest cell peripherally. Can you see? So these are the neural crest cell. So we are going to say that all these neural crest cells, they develop into peripheral nervous system. And I don't think this should be a big deal because they are actually peripherally located. Why this neural tube is going to develop into the central nervous system. Now, both central and peripheral, they have what we call neurons. God is wonderful. We have what we call the neurons, and those neurons, they are protected by what we call the neuroglia cells. Or you just call them glia cells. So, with respect to the central nervous system, you have central nervous system neuron. You also have central nervous system glia cell. With respect to peripheral nervous system, you have peripheral nervous system neurons. You also have peripheral nervous system glia cell. And that's just the two things that you must picture in your head. So anything related to peripheral nervous system and a neuron and the glia cell, they all come from the neural crest cell. And that's all. So what are these glia cell, Schwann cell, satellite cell? What's about the neuron? Anything related to that neuron? Dorsal root ganglia, the autonomic ganglia, all those ganglia stuff, because they actually cells that extend their tentacles, their axon, forming the nerves. So they all come from neural crest cell. For the neural tube, central nervous system neuron, those neurons you see in the spinal cord, within the brain, they all come from the neural tube. You don't need anyone to tell you. That's what is within the brain or spinal cord, neural tube. You see neuroepithelia in the neural tube. Then the glial cells there too, the supporting cells, we call them supporting cells. They are also going to come from the neural tube, shaking. So everything about CNS, neural tube, everything about the, what do you call it? The peripheral nervous system, neural crest cell. Now that you understand that, what are the glial cells you have in the central nervous system? You see them, astrocytes start with A, oligodendrocytes start with O, ependymal cells start with He. So this is what you have there. They all start with vowel letters. The astrocyte, when you mention the cell, you will see that it starts with vowel letters. So those are the ones you see. They are central nervous system glial cells. So He, ependymal cell, oligodendrocyte, they are all central nervous system glial cells. So if I mention a name for you now, you just look at it and be like, what is it starting with? You say that, oh, it's starting with a vowel letter. You just say neural 2, it's central nervous system. Okay, what about the peripheral nervous system? They mention something like Schwann cell, satellite cell. Those are the peripheral. Now, the last set of cell that you will see in any of them is what we call the microglia cell, which are the macrophages that you see in the nervous systems. So whether the central, the peripheral, anywhere, you see the microglia cells. So they come from mesoderm. They will ask you this. They already know you've mastered the concept here. They will now link it to microglia cell for you. Where is it coming from? So your ability to remember that microglia cell comes from mesoderm will help you out in that question. Shaking it. And that's all. So the other details you can easily extrapolate them. I wrote something here. Embryologic derivative of ectoderm, the same ectoderm that we are developing all manner of stuff from. We have what we call the surface ectoderm. We have what we call the neural tube. We have what we call the neural crest. You already mastered the tube. You've already mastered the crest. You know what comes from there. What about the surface ectoderm? We have so many structures that come from them, but they are not expecting you to cram them all. They always love to test one or two of them. And those one or two, they are the one you always see them testing every time. And which one is that? Anterior pituitary. Because in the brain, you have what we call anterior pituitary tumor. Do you get it? So they will just show you a diagram that the patient is having maybe a tumor of anterior pituitary and just ask you that what's the embryologic origin of this stuff. You already know that this anterior pituitary, your ability to remember that this is from surface ectoderm will help you out in that question. Shaking. What about the sweat mammary gland? They won't ask you. What about the salivary gland? They won't ask you. What about the nasal and oral epithelial lining? They won't ask you. What about the olfactory epithelium? They won't ask you. What about the inner ear sensory organ? Will never ask you. What about the lens and cornea? They won't ask you. But something like this surface, ectoderm, anterior pituitary, this is the question you should expect. Very easy and straightforward. Now, the last point I'm going to make is how they can connect this to all the other, most especially the neural crest cell, to all the places where you've ever met neural crest cell in your study. They can connect the neural crest cell to to CVS. So immediately I mentioned CVS, those that have been following, they will remember the importance of neural crest cell, most especially in the development of the heart. They can connect the neural crest cell to the adrenal medulla. They can connect the neural crest cell to the skin, which important structure develop from neural crest cell in the skin, melanocytes. They can connect it. If you can remember those few structures that can be linked to the neural crest cell, that is awesome. You are prepared for it. With respect to this page, you are also okay. Let me just show you one or two questions, just that so that you have an idea of the way the question will come. A 22-year-old man comes to the office due to occasional dull headache that awaken him from sleep. The patient has no associated neurologic deficit. There is no history of migraine in the family. His temperature is 37.2, blood pressure is 140/80, pulse is 60, and respirations are 12 per minute. On physical examination, there are several 3 to 5 centimeter flat pigmented spots on his trunk. You now see that there are also multiple sub-centimeter soft-fleshy cutaneous tumor located on his trunk and neck. The predominant cell forming these tumors most likely originated from which of the following structure? We've not done what do we call it? Neurofibromatosis. We are going to do it, but they are just trying to describe neurofibromas for you on the skin. So all those ones too, they come from, because they are on the skin, peripherally located, they are related to the peripheral nerves. So you link them to neural crest cell, Shikena. No issue, no headache. So that's that. Let me show you another one. See this question. This is a patient. Let me just show you the picture and we move. They show you something like this in exam. We are still going to do all of them later, But they just show you something like this. This is just the picture they are showing you. Immediately you see this, you just realize that something is wrong with the pituitary. That's all. What are you seeing in the pituitary is enlarged, and you can see some calcification around it. Immediately you see this, you just know that pituitary is what they are making reference to here. Now let us go back to the question. They now tell you that in the question related to it, they tell you which they can repeat for you too. They tell you that they just say that this patient lesion most likely originated from which of the following embryologic layer? The answer will be surface ectoderm. That's the one they are most likely going to ask you. Do you get it? Others, they don't really bother. You are going to see so many questions related to that in your word. Okay, that's that. We must come to the neural tube defect. All of you know neural tube, but I want to show you a concept here that you'll be using to think. The first thing is this week of development. That is when they can actually have the insults. So failure of neural tube to close completely by week 4. Is it the same week 4 we always talk about? Yes. The same week 4 we related to that? Yes. The same week 4, just week 4, week 4, week 4. And it's most of the time, what you will see is that it's associated with maternal folate deficiency during pregnancy. This association is what they will test. And there are few drugs they always love to test, and they will just put them in the option for you. Folate deficiency is the greatest risk factor you want to note, and medication that impair folate metabolism. Example is valproate, are associated with an increased risk. What are the inhibitor of this dihydrofolate reductase? The drug that can inhibit it, methotrexate. The same methotrexate you know, yes, trimethoprim, tramterine, sulfasalazine. Out of all of them, the one they are likely to put in question for you with respect to this inhibitor of the hydrofolate deficiency is the methotrexate. Methotrexate. It's not that maybe they can't ask you may even see 1 or 2 questions on the others, but methotrexate, never forget it. What about the favorable inhibition of folate metabolism? Can you see this drug? Carbamazepine, phenytoin, valproate. Never forget these 3 guys. You can still have some others, but these are the commonly tested ones. They will just put them, most especially this guy called valproate. They like it like anything. Then carbamazepine, phenytoin, never forget them. So they will just put them, which of the following is the likely risk factor for the neural tube defect you are seeing in this patient. Just check through the option, bring any of these guys out. PCV, phenytoin, carbamazepine, valproate. You can use that if you wish. Okay, that's about what can cause it. What about the diagnosis? There is one thing you will see in the question that we give it out for you, that this patient is actually having a neural tube defect, and I will need to break it down for you. We have what we call the closed neural tube defect, and we have what we call the open neural tube defect. Okay, if it is actually opened, now please get this, if it is opened, you have some parameters you make reference to. One of them is this alpha fetoprotein. Another one is what we call acetylcholinesterase. These are the 2 things you make reference to. Now, this is the pregnant woman. Think about it. This is the pregnant woman. This is the tummy. This is the uterus, rather. Or let me call this amniotic sac. So the baby is here. This is the baby. The baby is now having open neural tube defect. Let us put it on the brain. It's opened. It can be anywhere. It can be at the spinal cord or the brain. It shall open. Now, you can either take sample from this amniotic fluid, because the neural tube is opened. Acetylcholinesterase will escape into the amniotic fluid. So when you see acetylcholinesterase is elevated in the amniotic fluid alone, it gives it out and be like, oh, this thing is opened. So you already know it's so, because acetylcholinesterase is related to all these neuron acetylcholine breakdown and the likes. So it's related to neurotransmitter. Do you have neurotransmitter on the skin? Do we have it on? So no. So it's likely the neural tube is exposed, and that is why the acetylcholinesterase is escaping into the amniotic fluid. So when they tell you that acetylcholinesterase is high in the amniotic fluid, just know that more neural tube is exposed, it's opened. Another thing is AFP, which can also be high there. So you come to but how many pregnant women are they going to be talking about that you are choking and you are bringing out the amniotic fluid? You rather go to maternal serum. With respect to maternal serum, do we have um, what do we call it? Neural tube in the maternal serum? No. So what you are likely to see there is just likely going to be related to AFP alone. So that's what you are most likely going to see in the maternal, just elevated AFP, and that's all. So that's what we have with respect to that. What about the closed one? Everything will be normal. The AFP itself, it will be normal. The acetylcholinesterase, it will be normal, because everything is still closed, is not exposed, despite the fact that the patient is having neural tube defect. So when they tell you this patient has neural tube defect, but the AFP is normal, just know you are dealing with closed one. But if they say this patient has the neural tube, the baby is having neural tube defect, and the AFP is elevated, just know you are dealing with open, shaking up. That's all. It just give you headacheless solution. Now, how are we now going to be looking at those neural tubes? Let us divide them. First off, did you just mention that it can be related to the head or brain? You say yes. It can also be related to the spinal cord. I say yes. Okay. The ones that are related to the spinal cord, let us call them spinal dysrhythmism. The ones that are related to the head of the baby, let us call them cranial dysrhythmism. It's just that one is going to be related to the upper part of the neural tube, while the spinal one will be related to the lower part of the neural tube. Okay, now let us pick them one by one. You know, I told you, I already mentioned that it can be closed, it can be open. Please, I want you to listen. If it's closed, you call that spinal bifida occulta. Now, when they are going to describe it for you to make that diagnosis of spinal bifida occulta, don't forget that AFP will be normal, everything will be normal. They will just tell you that the baby is born, but they are noting something on the back of that baby. And these are the things you will see at the back. Either the question makes reference to the tuft of hair or skin dimple. Tuft of hair around that region or skin dimple. That is just what nail it for you. You just say that this is spinal bifida occulta. Those two things alone. No issue. No, not too much stuff. These two things, are you seeing here there? You say yes. Everything is closed, and you are seeing here around that region, or you are seeing the question talks about skin dimple around that region. The answer is spinal bifida occulta. Okay, what about the opened one? Definitely, we are going to have elevated AFP. Okay, now come here. So we have what we call Meninges. Definitely, you have heard about Meninges before. It's just the Meninges are just the covering of the brain, then of the spinal cord. That's what you have, the Meninges. Just cover them. So we may have that Meninges alone herniating out. You will just see a bump. There will not be dimple. There will not be tuft of hair. But you just see a bump, but you are still seeing skin. You still cover it. Do you get it? You are still going to see skin covering it. So you call this Meninges. That is what is herniating through it. All right. Okay, so Meninges is just going to herniate, no neural tube. No neural tissue. Just going to herniate through a bony defect. I will still talk about this bony defect for you. Then you come to what we call myelomeningocele. Two structures that are herniating here. Myelo, which is the neural tissue, then meningocele, which is the meninges. Two of them are herniating. So two of them, you just see them herniate. You see a bump, and 2 of them are herniating there. So that is myelomeningocele. What of myeloschisis? Myeloschisis, they are actually, you just see the skin is just going to be opened. The neural tube also there, the neural tissue is also open, meninges is open, everything is open. So you are likely to see it without any you are likely to see something like unfused neural tissue without skin or meninges covering. That just exposed, everything is just exposed at the back. You call that myeloschisis. So they can just test this meningocele, myeloschisis for you, myelomeningocele. Out of these 3, they love to ask about myelomeningocele a lot. Why myelomeningocele? Myelomeningocele is associated with a condition that it's that condition they will ask you. And that is what we call Chiari-2 malformation. That's the question they will ask you. Chiari-2. They will give you the diagnosis. They are now going to test this Chiari-2 malformation. We are going to do Chiari malformation soon. But in summary, what is in Chiari-2 malformation is just this downward displacement of the hindbrain that can obstruct the flow. So you just start seeing herniation there. That's what you see there, herniation. And what is herniating? The hindbrain can herniate downward, and that's all. So it might actually just display downward. So that's Chiari-2. I will show you how you make a diagnosis of Chiari-1 and Chiari-2. So you don't want to forget this. So for you, as I just mentioned it, you just want to palm it like that and be like, okay, myelomeningocele is associated with Chiari-2. No wonder 2 structures are herniating. The neural tissue, the meninges, they are herniating. The 2 structure is also associated with Chiari-2. 2. Don't go and mix it up. All right. So that's it about these ones. Don't forget how you make your diagnosis of spinal bifida occulta, then myelomeningocele. They love these guys so much. All right. Let's come to the cranial dysrhabism. This one is quite peculiar. The head is not just there or it's just deformed. You call that anencephaly. They can give you all manner of stuff. So it's opened. So you already know what will happen there. Okay. There is a way you will make the diagnosis of anencephaly in question. And that is all what you look for when you know that this is about neural tube. You will see the history of polyhydramnios in that question. Why will these ones present with polyhydramnios? You say the head, you have all manner of centers there that should actually be developed, that should help with swallowing. You say yes. What is producing amniotic fluid? We say the kidney. You say okay. What is supposed to swallow them? You say the baby is supposed to swallow the amniotic fluid. During that course of swallowing, it will also help in the maturation of the lung. You say yes. But this patient that the head is not developed, they don't have good swallowing reflex. They don't have it. So because that swallowing reflex is not there, they can swallow. That's why you see polyhydramnios in question. You will know that this is a neural tube defect question. You will just see polyhydramnios. Either they tell you like that or they say that the cervicofundal height is bigger than the gestational age. And like I'll just put it somehow. You just know that this is polyhydramnios. A neural tube defect is diagnosed. Which of the following is the likely neural tube defect you will see in the patient? The answer is anencephaly. Shaking up. All by seeing picture related to polyhydramnios. That's all. So that's everything about this. Now there is one more thing that they didn't mention that I want to let you see. We only talk about all this structure herniating. The meninges, the neural tissue, and the meninges, blah, blah, blah. There is something that is common to all of them all, and that is the defect on the brain, on the vertebrae. Is that one also related to neural tube defect? He said, no. There is something that should form bone that is not forming bone here. He said, what are they? He said, mesodermal cells. Mesodermal cells, they do not occupy this region. For all you care, that might just be the question they will ask you. That how come you are having a bony defect here? The bony defect you are seeing here is as a result of what? Mesodermal cells not filling this region. It's a defect in mesodermal cell movement and multiplication there. So that is for the bone. We are not talking about this other stuff highlighting. So you can see the way they intertwine. So look out for whatsoever they are testing there in the question. So let me just show you one or two questions, then we leave this area. I have quite a number of questions. You see something like this. A 35-year-old woman, gravida 2 para 0, is seen in the clinic for an early anatomy ultrasound at 18 weeks after she was noted to have an elevated alpha-fetoprotein. On prenatal screening, ultrasound show a complex cystic lesion overlying the lumbosacral spine, ventriculomegaly, and hindbrain herniation. What do you think they are trying to describe here? Who can make a guess? There is hindbrain herniation. I just mentioned it. It starts with carry something. Carry.
Carrier malformation.
Okay, so something carry 2. Okay, so these abnormalities are most likely due to failure of which of the following processes. Immediately you see that, you just know that, okay, this is related to the primary neurulation, which is actually the neural tube development into all those brain and different kind of things. Shikena. Okay, neural tube defect is related to it. How do you know? You can also see alpha-fetoprotein is there, so don't forget, so that we don't waste time. See, a 38-year-old woman comes to the emergency department due to severe abdominal pain, delivers a stillborn neonate who is missing a large portion of the scalp and skull, partially exposing the brain, which is also only partially formed. The patient did not know she was pregnant and had no prenatal care. Medical history is significant for bipolar disorder and chronic hypertension. A few of the patient reveal pressure and tangential speech, just bipolar. And she stated that she takes certain prescription medication when she remembers but cannot identify which one. It's if used during pregnancy, which of the following substance most likely contributed to this? Which drug are they likely to be making reference to? Is valproate.
Sodium valproate.
Sodium valproate. So that's all. Just make that, pick that, and you go. Did we mention anything like lithium? No. In neural tube? No. Please don't go and mix it up. Valproate. See this one. This is about the week that the just see a newborn is being evaluated in the nursery. The patient was born at 10 via the spontaneous vaginal delivery. A cystic lesion is noted overlying the lumbosacral spine region. The remainder of the physical examination is remarkable. Ultrasound imaging confirmed a neural tube defect. The mother had no prenatal care, and further discussion revealed that she took a medication known to be teratogenic during pregnancy. Exposure of the medication most likely occur during which of the following week? Week 4. Okay. They are going to be that specific. They won't be giving just week 4. Okay. See this one. You can go just read the question, go through them. You let me see anyone that. Okay, look at this one. A 28-year-old woman at 20-week gestation comes to the office for her first prenatal appointment. An ultrasound is performed during which the fetus is found to have a congenital defect and no cardiac activity. Due to the pregnancy loss, the patient undergo an induction of labor. After delivery, gross pathology of the fetus is shown. Sorry, I don't have it. Likely they are just showing one cystic mass or something, or the head is not formed very well. Okay, likely based on this answer, likely we are dealing with maybe a mass at the back. Okay, these findings are most likely due to impairment of which of the following embryologic process. The answer is rostral neuropore, just neural tube closure. So that one is opened. So but the picture will show you that it is open. You will see it. It's not something you will be guessing. You will know that it's opened. Okay, sorry I don't have that picture. Sometimes I just forget to just pick the picture. So just use the information. Let me read this because I'm seeing as a series here. A 35-year-old woman, gravida 2 para 1, comes to the office for a routine prenatal visit. Her first child was born with a hydrocephalus of the first and the second toe. The patient has no significant medical condition and takes no medication except for a multivitamin. Examination shows clear lung and normal S1, S2. The abdomen is soft and not tender. Uterine size, fetal movement, and fetal cardiac activity are all within normal limits. The patient undergoes an amniocentesis at 18 weeks, and amniotic fluid analysis showing increased level of acetylcholinesterase. Immediately you see that, you know that there is open neural tube defect here. The patient amniocentesis result most likely suggest which of the following processes. So, most likely suggests failure of which of the following processes: fusion of the edge of the neural plate, shaking, which may be cranial or what, or the cranial or what, spinal. That's all. So don't forget. So once you see acetylcholinesterase, it just tell you that this is open, and that's just the concept there. So let them say the question. Now, I love this question. Let's look at it. A 4-day-old girl is seen in the clinic for follow-up after discharge from the newborn nursery. She was born at 38-week gestation via complicated vaginal delivery. On examination, the patient is well appearing and is moving all extremities. Tone and reflexes are normal, Doki. A deep sacral pit is noted with a hair tuft over the midline lumbosacral region. What is the diagnosis there?
Spinal bifida
Spinal bifida occulta. Okay, the remainder of the examination is normal. A spinal ultrasound is obtained and revealed a low-lying conus medullaris at L5 with a thickened phylum terminale. We'll look at all those ones. Failure of which of the following embryology process is most likely associated with this patient condition? Don't forget that in spinal bifida occulta, nothing is hymatic, but there is a defect there. And that defect, you see it in the vertebral arc. So you talk about vertebral arc fusion. So if they don't mention vertebral arc fusion, they may make reference to mesoderma or mesenchymal cells or something like that. Let me see if I thought. Let's see some. Okay, so something like that. So look at this question so that we don't waste time. A 29-year-old primary gravid woman at 18-week gestation comes to the physician for her first prenatal visit. Now tell you she works as a paralegal and lives with her husband. Her current pregnancy was unexpected and she did not take any prenatal medication or supplement. Physical examination shows a uterus 2 cm hinge. Let us meet our marks above the umbilicus. What? Okay, this is 18-week gestation. And the thing, when they do this, if it's of under height, they are getting 20. What is 1 inch in centimeter? What is 1 inch in centimeter? Dr. Miriam. Just check.
Okay.
So just
2.5 centimeters is 1 inch.
Lovely. So these 2 inches now, what do you think that is? That's like 5 centimeters. So this is 18-week gestation. Around the umbilicus, we usually call it 20-week gestation. Do you agree with me? Around the
Yes.
umbilicus. Is that not?
Yes.
Yeah. So
Yes.
if it's now 2 inches above the umbilicus, it shows that this patient is now at 25 weeks. It's like 25 week gestation. That's how it's looking. 18 weeks to 25. There is a long, big disparity there. So you start suspecting something like polyhydramnios. Okay, you now say the concentration of alpha-fetoprotein in the maternal serum and concentration of both alpha-fetoprotein and acetylcholinesterase in the amniotic fluid are elevated, telling me that this is open neural tube defect. You now say ultrasonography of the uterus show an increased amniotic fluid follow, polyhydramnios. The fetus most likely has which of the following condition? Anencephaly, shaking up. And that is the concept you will take into the exam with the neural tube. If they give you 10 questions, you answer all of them. Let's stop there. All right. Then we come down to the brain malformation. The first point you want to note here is that this is a malformation. They will give you and ask you, what is this, that, that. This is a malformation. Okay. When we get into the repro, we'll be looking deep into that. So we have 2 conditions here. Holoprosencephaly, lysencephaly. Holo means 1. Prosencephaly, you already know that. So all the division you are supposed to have in the prosencephaly, they do not occur. Let us revise them. The prosencephaly is supposed to divide into telencephaly and diencephaly. What are the structures that will come from telencephaly?
TBC.
Cerebral what?
Cerebral
Hemisphere. Okay, what are the structures that will come from diencephaly?
Thalamus, hypothalamus, and the retina.
Hypothalamus and retina.
Now, shaking her. So it shows that we will see something related to the eye. We will see something related to thalamus. We may see something related to cerebral hemisphere, then basal ganglia. Most especially the structure that appear to. So these all structures, they are not going to divide. And that's just the only thing you just need someone to tell you. That's just the only thing that will give it out for you and be like, this is holoprosencephaly. They will give you all these cerebral hemisphere, because they are not dividing. The cerebral hemisphere will appear as one. They are going to appear as one. That's one thing. Then the ventricle that is in them too is also going to appear as one. And you call that ventricle monoventricle. One, instead of having two lateral ventricles, now have one. Immediately you start seeing the structure that should be two, they are appearing as one. You just make a diagnosis, and they are related to this prosencephalon. You just make a diagnosis of holoprosencephalon. I do not need to know the features. All I need to do is to remember that holo means one. Prosencephalon is supposed to divide, and I'm seeing the lack of division in the question. Holoprosencephalon. That's all. Okay, so that's what we have there. So that's just what we help you out in making the diagnosis. The USMLE will not stop at the level of diagnosis for you. Okay, before I talk about the other thing, I used to say something that the structures that should appear two, they appear as one, and the structure that should appear as one, they start appearing as two. Is that not paradoxical? Well, you are supposed to, what is going on? Those that should appear like two, they start appearing as one. Those that should appear as one, they start appearing as two. For example, now retina, which is for the eye, should be appearing as two. They start talking about the fact that the distance between the two eyes is now very narrow. You call that hypothalamusism. Can you see? The eyes may be too close like this. Very, very close. And in severe case, the eyes will appear one, diffused. This is the eye. You call that cyclops. Just be like, you just see the question talking about this, the eye is just one eye that the patient is having. Wow. This eye is supposed to be two. How come it's one? You start suspecting holoprosencephaly. Then you check again. They do the brain MRI or the CT, and they are telling you that the ventricles are also one. The lateral ventricles are also one. Lateral ventricles are supposed to be two. They are also one. You say yes. Wow. Start suspecting. Where are they all coming from? Prosencephalon. Likely I'm having holoprosencephalon. Shaking up. They may now go and add cleft lip. Lip is supposed to be one. One upper lip, one lower lip. They may start talking about cleft. They now start dividing. Cleft palate. Palate is also supposed to be one upper palate. So you now start seeing something like what? Division, cleft palate. Do you get it? And that's what you see in the patient. Okay, that's that about the feature. So you don't need to sit down and cram any of these features. You just need to picture this, your TBC and DHTR, and that will just help. You can write as many as you like. In fact, when you read it, you already know everything there. And you don't need to put so much of these features there. Monoventricle will definitely be in the question. Monoventricle. Fused basal ganglia will definitely be there. Cyclops or hypothalamusism may also be there and the likes. Now, the next question they will ask you after you make the diagnosis, in case they just ask you what's the diagnosis, the next question is, what is the likely mutation responsible for this? Be expecting that. The likely mutation is just that sonic hedgehog mutation, shaking up. SHH, sonic hedgehog. Those two structures, they start hugging themselves. They now start appearing as one. You can look at it like that if you wish. Then they will also ask, there are two conditions, two syndromes that are related to it. You never dare not forget those two syndromes. You dare not. And that first one is Patau syndrome, trisomy 13. And the second one is the Fita-Acol syndrome. Those are the two syndromes they can test. They might just be like, in this patient, what kind of trisomy are you likely to see here? Just a trisomy 13. Just pick it. Or they just test Fita-Acol syndrome. Now, what about the complication? Is there any risk this patient is likely to have. You say yes. What is that? Pituitary dysfunction. They might just want to be lenient with you and just put pituitary dysfunction in the question, or they specifically ask you which one. A, diabetes mellitus. B, diabetes insipidus. And the answer is diabetes insipidus. There are some questions you will see that is just diabetes insipidus, you just test, and that's all. Okay, so that's all about the holoprosencephaly. So you don't need to sit down and say you are cramming anything here. The last one, second one, is the lissencephaly. Now, the first important point you don't want to forget here is that what is causing it? Failure of neuronal migration. You need to pick your pencil, paper there. As I say it, just write it or underline it in your book. Hit your head there and be like Festus, don't forget this. Failure of neuronal migration. So you will now see them describe something for you and tell you that, yeah, this patient is having this, is having that. They will put all manner of features there. And after that, they notice that the brain appears smoother than expected. You are supposed to have what you call the gyri, the sulci, gyri, sulci, gyri, sulci, gyri, sulci. The brain will now appear like this. Gyri, sulci, gyri. So it looks smoother than expected. All those gyri are not there. As such, they are there, but they are not many. Just like one. Can you see this one? See the way it appears. So that's what you call loss of gyri. So or you say lack of gyri and the sulci. So when you see this, the brain appearing smoother, you start thinking towards lissencephaly, or lissencephaly, failure of neuronal migration, shikina. This most of the time, between these two, it's more than 90% probability that you'll be tested. But if I thought they are going to test this brain malformation, you are likely to be tested on holoprosencephaly compared to listen. So in case you now see it, you won't say, Festus did not tell us that they will test it too. You were saying that holoprosencephaly is what they will test. The probability that you will be tested on listen is lower. So they love this holoprosencephaly very well. See this question. A 32-year-old woman gravida 1 para 0 at 35 with gestation come to the emergency department due to absent fetal movement for the past 24 hours. Okay, the patient has had no prenatal care, fetal ultrasound confirmed an intrauterine fetal demise. Autopsy examination of the fetus revealing complete separation of the cerebral hemisphere. They do not separate completely with a single ventricle. So they now show us a image. Let me show you the image. So this is the picture they are showing you. They show something like this. You just see this single ventricle in the question. Immediately you see, can you see it? They are not well separated. It's just a single ventricle. Big, we call this monoventricle. So the diagnosis here is just holoprosencephaly. Are you still there with me, or you are sleeping?
Right here.
I hope you are getting it.
Yes.
Okay. So that's that. So now say which of the following is most closely associated with this fetal condition. So what are those things you are looking for in question? Patau, right? So if Patau is not there, which other syndrome are you looking for?
Fetal alcohol.
Okay, now.
From
So this one too, they describe it. A fetal heartbeat is undetectable and she delivered a stillborn boy vaginally. Examination of the stillborn shows several dysmorphic features, including closely set eyes and an elongated nasal structure, proboscis. Then a fetal autopsy revealed a few cerebral hemisphere with an absent forebrain, fissures, and a single intracranial ventricle. Just start suspecting holoprosencephaly. So it now tell you that, okay, this patient autopsy finding are most indicative which of the following types of congenital anomalies. So just remember, just realize that we are still going to look at the others later. So I think this is about let us see, a male newborn delivered at 32, gestation of a 41-year-old woman died shortly after birth. The mother did not receive prenatal care and constantly consumed alcohol during her pregnancy. At autopsy, examination shows microcephaly and eye in the midline. What do you call that? An eye.
Cyclopia.
Cyclopia.
Cyclopia or cyclops. So anyhow you want to look at it. So, and a single basal ganglion, then failure of which of the following processes is most likely the cause of this patient substance. So cleavage of the forebrain. Prosencephalon did not divide. And that's all. So you can see that that's just how the question will come. Just rehearse around this. Mention the sonic edge mutation to yourself, patao, fitaco, then the midline structure. You don't need to sit down and start cramming the midline structure. You can easily think them out and never forget the diabetes insipidus. Then we come down to posterior fossa malformation. Another important point here, first thing you want to note here is that this is also malformation. So they will just ask you, what do you think is malformation? Is malformation. Okay, we have what we call the KRE1, we have KRE2, then we have Dandy-Walker's malformation. So I just want you to relax and pick it. KRE1, you only have one structure herniating through the foramen magnum. KRE2, we have two structures herniating through the foramen magnum. Dandy-Walker, we have something working in the posterior, in the posterior fossa. That's all. That's how I look at it. Dandy-Walker, something is working in the posterior fossa. KRE2, two structures are herniating. KRE1, one structure is herniating. So which structure is herniating in KRE1? Just a tonsil, cerebellar tonsil. And that's all. So you want to note this cerebellar tonsil. That's just how we put it. There is a downward displacement of cerebellar tonsil alone through the foramen magnum. And usually, the patient do not usually have any symptoms. If at all there will be any symptoms, it manifests. They manifest that symptoms around that dot heel. And there is a condition they will ask you that is related to this KRE1. They call it Syringomyelia. Syringomyelia. There is just one typical way they will paint the scenario of Syringomyelia for you. I will tell you soon. Syringomyelia. That's all. What they will ask you that this patient is having a nation of this, or they describe a patient that is having this Syringomyelia, and they just tell you that, okay, which of the following is likely to be found in this patient or something like that. We'll be thinking towards KRE1 malformation, which is the displacement of just the tonsil, cerebellar tonsil. What about the KRE2? You have displacement of two structures, cerebellum and the medulla. Two of them are displaced downward. So if two of them are displaced downward through what you call unyielding foramen magnum, so what you are going to have there is that there will be a collapse. There will be a collapse of the what do you call it? There will be a collapse of the neural canal, or you just say central canal. So this is the canal where the CSF is supposed to flow through. Do you get it? This small canal, then you have the other structure around it. Because of that, they are going through this small unyielding, because it's bone, unyielding structure, orifice. All those, this hole where the CSF is flowing through, everything will just collapse. And by the time it collapses, it's going to close up. When it close up, there will be accumulation of CSF proximally in the other ventricles. In the other cavities, the CSF will not be able to flow downward. So you call that, because there is a cut off, or there is disruption of communication along that CSF flow pathway. You call that non-communicating hydrocephalus. None, because something just cut it off. So they are no more communicating, that is flowing through. It's just like a road. This is a road, and that road is linked to another road like this. Something now happened. This place is blocked. Something just block it. You say these two roads are no longer communicating. This is non-communicating hydrocephalus. All the traffic coming here, they start accumulating backward. So there will now be dilation of all those cavities and the likes. So that's just by the way, just for you to note where the non-communicating hydrocephalus is coming from. But never forget these two structures, cerebellum and medulla, and that's all. Which association did we mention before that you have with KRE2? You just remember Myelination. So association you have with KRE1, Syringomyelia. Association you have with KRE2, Myelination. Practice this over and over again. That's the question they will ask. Okay, how will the patient present? We say this one is asymptomatic. You say yes. But this one, which symptoms are you going to have? You say, Festus, did you just say that cerebellum we are innate? We say yes. Did you also say that cerebellum is also innating? We say yes. Then in the cerebellum we are innate, then medulla we are innate. Now say yes. Okay. What do you have within the medulla? We say you have respiratory centers and all manner of centers there. So this patient, because of pressure you are going to have, the patient will have on the medulla, the patient will have all manner of respiratory distress. So you have so many things, stridor, this, that, because cerebellum is also innating, the patient will present with all manner of weakness and all manner of imbalances, or balance or gait abnormality. You may see them. All right, so that's just what but you don't need to cram all this one. Just want to have an idea of what is innating. You can extrapolate your way from there. You don't need to say them the exact way they've put them, but you will just know that since medulla is involved, there will be something related to cardiorespiratory center. Then since cerebellum is also involved, there will be something related to the tone, to the gait and all manner of stuff. And that's all. So what of dandy walker? What you have here is agenesis of cerebellar femmis. What is supposed to develop into cerebellar femmis is not there. So agenesis, it doesn't develop at all. But how are you going to make the diagnosis? You are not likely to make that diagnosis just by reading the history. They love to give the diagram. You will just see the cerebellar, see the way it is here, the way it's upturning here, this cerebellum, the way it's upturning here, and you now see CSF. This is all CSF. You just say, is this cerebellum working in the midst of CSF? Why is it upturning? It's just like you have an erosion. You now have like someone within that is in that erosion. The thing is actually carrying the person. So that's how the cerebellum look like. The cerebellum is just like being swept to one side by this large CSF that you see here. You just say that, okay, this is dandy walker malformation. If they will give you, this is the same picture. They won't give another picture. It's just the same picture. And some of you will just say that they brought out the picture from the first stage. So something is just like walking within the stuff. Okay, what is causing it? Agenesis of cerebellar femmis. So we are going to look at the cerebellar femmis later. It's just the midline portion of the cerebellum. It's not there. We are going to look at it. Just relax. So they just have this cystic enlargement of the fourth ventricle that fill the enlarged posterior fossa, and it can compress on the the central canal, and the next thing is that CSF cannot flow. They also have not communicating hydrocephalus and the likes. So let me just show you how you can bring all these three together in question. Then you make your diagnosis. Okay. So these are the questions. So I just want you to see the way they paint the scenario for you, and that's all. So the explanation is the same thing. A 21-year-old woman, pay attention to the story. You will see the clincher, you are just okay. Okay, a 21-year-old woman comes to the office due to a long history of episodic headache, dizziness, and gait imbalance. Now say the headache are located in the occipital region, are characterized as dull and last for several hours. Physical examination revealed gait ataxia but no focal weakness or sensory loss. MRI of the brain shows a low-lying cerebellar tonsil extending below the plane of the foramen magnum into the vertebral canal. So what do you think is low-lying here? What is hynating here in this patient?
The cerebellar tonsil.
So if at all that's the only structure that's hynating, what's the diagnosis here?
Anarchial.
Carry one above
Carry one,
one.
just one structure, carry one. There is no any other thing. And you are like, but you say that this patient will be asymptomatic. This is an adult, 21-year-old. Okay. Look at this one. So the answer will be congenital malformation. That's the which of the following is the most likely cause? Congenital malformation, and the main diagnosis is KRE1. So this one too, can you see the way? That's just how they are very simple question. Neuro is very easy. Very, very easy. Very simple question they will be asking you. A 2-year-old boy recently immigrated to the United States with his family is brought to you for irritability and excessive crying. The mother's pregnancy was uneventful, but the patient was delivered via the cesarean section due to obstructed labor. Now say his mother report that he has developed more slowly than his brother in ability to lift his head, crawl, and walk. She has also noticed that the patient head is larger than other children of the same age. His weight is at the 60th percentile, height is at 50th percentile, and head circumference is at 95th percentile. This kind of the head is shown in the image below. So sorry. Let me check it. Do I have the... Okay. I hope this is the image anyway. Let me show you something here. This should be it. This should be it. So very simple stuff. Don't even start cramming anything. So that's just the image there. Very young boy, a young patient, and you are just seeing something here. And you are like, what is this? What is this? You just check the other regions. So you just check this is the brain. This is the bone. You can see the bone. And you can see the brain. You can now see something within it. This is likely to be the CSF. Do you get it? So you just have this excessive CSF accumulation in the posterior fossa. You start thinking towards what? Something like maybe we are dealing with Dandy Walker. Dandy Walker. So something like that. So I don't know if that's the picture anyway, but I think it should be it. So let's continue the question just to show you how they all are. So if that is it, so that's it anyway, definitely, likely. So CT scan of the head is shown to you, which of the following is the most likely diagnosis. Just say Dandy Walker. So you don't need too much story. And what am I seeing? Is this brain this? They will definitely give you the CT. And once you see that this first one or that one they gave you, or even from the story alone, you already know that this is Dandy Walker. Just pick it and go. See this one. A 2-year-old boy is brought to you because of progressive headache, dizziness, and recurrent episode of vomiting for 3 weeks. Forget about the story. Let us search for the clincher that will give it out. Think plainly. He has a history of surgical removal of sac-like protuberance on his lower back. Soon after birth, sac-like. Now, the neurologic examination shows ataxia. What? Fundoscopy shows bilateral optic disc swelling, which is a sign of like raised ICP. Now say an MRI of the brain is now given to you. I will check for it. Which of the following is the most likely diagnosis? Until proven otherwise, Gary, what is this?
Carry
Two.
two.
Carry two.
Okay, I thought I had Gary 3. Gary
Carry two.
Okay,
Carry
so don't let us forget. There's no 3. So it's 2. And which was the name of the structure they removed from the back?
Myelination.
Meninges.
Just note it like that. That's how they will give you. Pick your answer and go. And that's all. So let's leave this area. Let's come to Syringomyelia. You don't need story here. I bet it with you. No story. No story. These guys have a typical... What happened in Syringomyelia is that... Um, okay. coming. See this central canal. You just realize that the thing is just expanding, 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 and expanding. And now form what you call like a big cavity that you have CSF accumulating there. All right. As it's expanding, it will be compressing on the nearby structures. What are the nearby structures is going to compress on? You are expecting me to list them for you. You don't need them. Any structure is going to compress on, but there is a typical way of presenting that. That is how it will appear in the question. We call it cape-like presentation. This patient will just be complaining of symptoms, most especially of loss of pain and temperature. Spinal thalamic tract, they are the most affected tract that you have there. So the patient will just be complaining of pain and temperature, loss of pain and temperature sensation around this region. Cape is like this region like this. The hand, the upper chest, the upper limb, and the upper chest. And that's just the region you will be seeing in the question. Majority of the question that will be given to you, the one that will be given to you is going to be that simple and just come with that cape-like. So when you see cape-like presentation, okay, this patient has this loss of pain and temperature on the two upper limb and also the upper chest. Now say, what is the diagnosis? Just check for Syringomyelia. It cannot be any other thing. Syringomyelia. Pick it and go. All right. So that is how they present. But if at all I want to stretch you a bit, this syringe can also expand and compress on any other structure. It can expand and compress on this lateral horn. You see, you call this lateral horn. This is also lateral horn. It can expand and compress on the lateral horn. That's where you have your autonomic nervous system coming from. It can compress on them and this patient start having autonomic nervous system abnormality. It can it can expand and compress on the posterior or dorsal column. And this patient just start having abnormality with proprioception, with vibration, with all manner of stuff. And just that expansion. But the commonest presentation they will give you is the loss of pain and temperature in this cape-like manner. And that's all you need. Is there any other para information you want to note? Don't forget that it's associated with KRE1. Okay, we've established that. Another point you want to know is that most sometimes they have spine deformity. Which spine deformity are they likely to have? You don't need anyone to tell you. They can put any spine deformity there. If they like, they can put scoliosis. If they like, they can put kyphosis. If they like, they can put all manner of spine deformity. Let them put it. Spine deformity is spine deformity. And that's it. Then sometimes you can see history of trauma, that this patient had an accident, then after a while the patient just developed this Syringomyelia, this cape-like loss of pain and temperature. Okay, now let us see the few questions how they come. I just want you to see the pattern with which they set the question. A 16-year-old boy is evaluated for difficulty walking. Now see, on physical examination, he has thoracic scoliosis and multiple small scars on his hand. When asked about this, the boy replied, I frequently burn my hand by accident because I can't feel the heat. Two of them, yes, his hands. What? There is loss of pain and temperature on those ovary. Neurology examination review 1 plus biceps reflex, 3 plus patellar reflex. How come bicep reflex? This is hyporeflexia. The normal reflex should be 2 plus. 2 plus, when we get there, you see how I will look at it for you. You don't need any number. The only number you need for the reflex is 2. There's nothing like 1, 3, 4 is like this, 5. No. We only need 2, number 2. Anything less than 2 is low. Anything greater than 2 is high. Shikena. So they give you something like 1 plus for the bicep, 3 plus for the patella. Patella is higher. The bicep is hyporeflexia. All right. As well as decreased muscle strength in the bilateral upper and lower extremity. So they now tell you that his hand muscle are atrophic and position and vibration senses on the feet are also impaired. Which of the following is the most likely cause of this patient problem? The answer is going to be syringomyelia. Don't doubt it. That cape-like distribution, and how come you are seeing other tracts there? Because the thing has expanded and is now impinging on other area. If they take the history very well, they may be seeing autonomic dysfunction. If they take the history very well, they may be seeing anterior horn dysfunction, which I think is there. If they take the history very well, they may be seeing dorsal column involvement, and that's just syringomyelia. But the first one you will see in that patient is this spinothalamic. This crossing spinothalamic tract, chicken. So,
Dr. Festus, please, the thing you explained about level that you were talking about, one is upper and one is lower. Please, can you explain that? I didn't process it very well.
Upper, which one is upper?
That you were talking about the patella and...
No, that is, one is upper limb. Patella is for lower limb. The biceps is for upper limb.
Yes, you now related it to a particular concept.
That's about the reflex. Don't worry, I will still establish it back. It's
okay.
about the reflex. I will establish it later.
Okay.
So don't worry, it's just number 2. I will what you need, I will give it to you. Okay, so that's all about this one. That's all you will be looking for in your question. Okay, so let's just solve one more question, then you see. A 62-year-old woman with type 2 DM comes to the physician because of a 1-year history of progressively worsening paresthesia in her upper limb. She has accidentally burned her fingers on hot dishes several times. She was involved in a motor vehicle accident. You can see history of trauma here 3 years ago. Neurology examination shows absent temperature sensation with normal fine touch sensation. Fine touch sensation. Wow, that's very wholesome. Now say over the upper extremity and chest. Without treatment, the patient is at risk of developing which of the following. Now, definitely this patient is having syringomyelia. And I just told you that if syringomyelia should continue, if this syringe should continue to expand, it can start impinging on the nearby structures. The nearest structure to it that you are likely to have is something like this autonomic, this lateral arm. It can impinge on the lateral arm, and the patient just start having Unna syndrome. Lateral arm, shikena. Unna syndrome, autonomic. So, just for you to have an idea of the way, just expand it. You can expand it into anywhere. This is the closest area to it. The other column, the posterior column, they are here, and so before that one is going to be that much. It might take a while, but it doesn't mean it can affect it. Do you get it? So when you check through the options, you just check for something related to this lateral. That's another concept that I just want to note. So you just see something related to Unna syndrome. And one of the things you will see in Unna syndrome is what ptosis. So dropping of the eyelid. If you check the option, you don't see dropping of the eyelid there. It might just be anhidrosis that they are going to put in the. Just Unna syndrome is Unna syndrome. The components. So what are the components again? Ptosis, meiosis, anhidrosis. So just check for those guys in the option and you pick it. It's just telling you that syringe is impinging on the lateral arm. That's all. Chikena. If they like, they can go and relate it to the back, to the posterior column. If you check the lateral arm in question is not there, it might just be the posterior column they are trying to check for. It can be any of the surrounding structure. So don't limit it to, and you don't need to now start. So now sit down and start cramming them. Don't cram anything. By the time we are done with neuro, you have all the information already. All right, let's leave that. You come to the tongue. The tongue is powerful. Very simple concept here that you can be playing around with. The first one is just, in fact, the commonest thing they love to put in question that people have suggested is just about the innervation for the taste, for the sensation. Okay. Now, I brought out something here. We call it 1975. When the tongue of someone caught wire. It was in prison. 1975. Just for you to put 1975. Pick your pen, pick your pencil, pick a paper, and just write 1975. So you can divide the tongue into 3 regions. The first one is anterior 2/3. The second one is the posterior 1/3. Then you have this extreme posterior. Extreme posterior. Okay, that's where you see this. Okay, if you now write your 1975, this one here is for cranial nerve 10, then you have cranial nerve 9, cranial nerve 7, cranial nerve 5. Extreme posterior, the cranial nerve you see there is cranial nerve 10. For the posterior, you see cranial nerve 9. For this anterior 2/3, at least 2 is coming there, coming out of what we are saying there. You see cranial nerve 7 and 5. Those are the 2 cranial nerve for the anterior 2/3. Lovely. So this is Act 1, Act 3, and 4. Okay. So that's for the cranial nerve. All right. So what they can do is to now test the cranial nerve in relation to taste for you. See the way we wrote it. So you can just draw something like this for yourself. Just very simple diagram. Tongue. And you just divide it like this. Anterior 2/3, and just put it like this. Then you just put taste and sensation. So this is going to be 10. You can draw it there. Just play around it. 9, 7, and 5. That's all. That's all. So if the question talks about there is loss of taste in the anterior 2/3, which cranial nerve is that? It's a cranial nerve 7. There is loss of pain at the anterior 2/3, which cranial nerve is that? It's a cranial nerve 5. There is loss of taste and pain or sensation at the posterior 1/3, blah blah blah, which cranial nerve is that? It's a cranial nerve 9. There is loss of taste and pain at the extreme posterior, which cranial nerve is that? It's a cranial nerve 10, 90, 75. All you need is just to draw this once or twice. You are already done with it. So when and just put your T here, just put T and S. Always rehearse with this when you see the question. Just draw it, because that is what your brain will draw for you when you get into the exam. And just be like, just close your eyes. The picture will just come and just be like T, S, 10, 9, 7, 5. So you just relate it. Taste for this side, sensation for this side. Okay, so that is that about the innervation on the tongue that you want to note, just for the taste and sensation. We didn't talk about the muscle. Which nerve now supply all the muscles of the majority of the muscle? Okay, muscles of the tongue. We have 2 cranial nerves. One is cranial nerve 12, hypoglossal nerve. The other one is vagus nerve, cranial nerve 10. Those are the 2 nerves that supply the muscle. We are not talking about taste or sensation here. We are talking about the muscle that move the tongue. But majority of those muscles are supplied by cranial nerve 12. Majority of all of them. Okay, let us look at their name, because they will put their name in the option for you if I thought they give you a question on it. The first one is ioglossus. Okay, let me call it, let me give it another name. Ioglossus. Permit me to just give it something. Just io or heel. Permit me to just say it like that, just to paint a scenario for you. So this one is just going to retract, take the tongue in. I don't want you to confuse it with this genuglossus. This one, get it out. Get it out. Genu, take the tongue out. Ioglossus, take the tongue in. Genuglossus, take the tongue out. I used to explain this styloglossus in a way. When we were young, we want to leave the house. When our parents don't want us to leave the house, we usually leave in style. Most especially when we wanted to go and play football. You will see us just living in style along the wall of the building. You just see us you want to throw yourself into into uh, the main field of the house. Everyone will be seeing you. Just be going through the walls. Let me assume that this is the house. You will see yourself moving around the wall like this, small, 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 to get to the corner, and you run. So styloglossus draw sides of tongue upward. It's just going to elevate the side. That's what will happen. So like you are it's a styloglossus deal with. Just like elevate this side, like you are living through the side or something like that. So let me give you a diagram. This is the tongue. They now say which muscle will take the tongue in. You say ioglossus, glossus. Which one will get it out? Get out. Genioglossus. It might sound like get in, but get out. Genioglossus. Because that O is there, so get out. Genioglossus. Which one will elevate the side? Styloglossus. When it elevates the side, there will now be a formation of trough. So you already know all those three powerful muscles. And those three muscles, they are supplied by cranial nerve 12. And that's all. There is now a place where king used to sit at the palace. You will see them sit at the back. That's where you will see them. Palatoglossus. See it at the back. So at the back, that's where they will be. In the palace, the king sit at the back. You cannot see a king at the front while the others will be behind. What if they shoot the king from behind? The king will sit down at the back. Others, all the community members, they will be at the front and be looking at him. That's the proper way or face the king in a way. All right, that's how you can look at it. So that's one. Palatoglossus is at the back, elevate the posterior tongue during swallowing, and is related to cranial nerve 10. That is vagus nerve. So you just need to get a pen and a paper. Just write these two cranial nerve and put those muscles there. Get in. In, higher glossus, in, retract, protrude, that is get out, genio. Okay, that is genio. Then style, lift the side, style in style, and that one will form a trough. They will ask them, just say that what's the nerve that supply this. So if they tell you that the patient cannot protrude the tongue, the patient cannot retract the tongue, the patient cannot lift the side of the tongue, which cranial nerve is affected? Hypoglossal nerve. If they tell you that the patient cannot elevate the posterior tongue during swallowing, now say which cranial nerve is affected, you say cranial nerve 10, shaking. Which branch of cranial nerve 5 do you want to note here? It's just the third branch, which is also called the mandibular branch. Most of the branches of the fifth cranial nerve that you will see us making reference to is actually the third. So sometimes when you find yourself in exam and you don't even know which branch of cranial nerve 5 you need to deal with respect to that question. If you don't know it, please just pick third branch and go. Because you have more clinical conditions that are related to third branch of the cranial nerve 5 compared to first and second. We also have few, which I'm going to tell you about them, but you have more with third branch. Do you get it? So you just want to, if you find yourself you don't even know which one to pick, please just pick the third and leave the rest. And that's all you want to do here. All right. Any questions so far? If you want to pronounce palatoglossus, you can call it palatenglosus, cranial nerve 10, if you wish. All right. Any questions so far? Do you get the tongue development? Do you get it very well?
Yes.
Yes.
Other people, do you get it? I just need your response. Do you get it?
Yes.
Yes.
Yes, we do.
So that's that. So go and practice questions on that. You will never regret it. Let's come to this anatomy and physiology. We don't need Serena story here. We just need a way of reasoning that when we get into question and we start analyzing the question, we'll be like, no, this is what is going on here. That's all you need. We have neuron. Let me ask you, where do you think astrocyte is coming from? What's the origin of astrocyte? Where is it coming from?
Neural tube.
Tube, neuroepithelium. Ependymal cells, where do you think it's coming from?
Neuroepithelium.
Of the neural tube. Never forget. Oligodendrocyte too, also related to the central nervous system. What of Schwann cell? Peripheral nervous system.
Neural crest.
Neural crest cell. And that's it. So we already have an idea of where those cells come from. So this, all the neurons, this is just neuron, general neuron, whether it's in the central or the peripheral. Neuron is neuron. Now, they always want you to note these few things about the structure. It's more complex than this, but just these few points under it, and you see the way we'll be using it. The cell body and the dendrite. This is actually the way neuron appear. This is the cell body. These are the dendrites. On top of it, then you have this axon. Do you get it? So that's one is now going to have all this synaptic knob. Okay, they just want you to know that this dendrite and this cell body, it contain one important structure. Probably you've not been noting it down. That structure, you call it nisu granule. That name is huge. Can you simplify it? Okay, rough endoplasmic reticulum. This is where you see rough endoplasmic reticulum. If I mention rough endoplasmic reticulum, what is it important for? All of you will shout protein synthesis. Keep naming all manner of proteins. So this is where you see them. You can never see that rough endoplasmic reticulum in the axon. And that is where USMLE will hide for you. They now have what we call nasal staining. So when you stain this neuron, well, this is with nasal stain, this is how you are going to see it. You just see something related to this cell body, and that's all. You will not see anything like axon. That tells you that you do not have nothing to stain in the axon. So this is just how it's going to appear. So they can talk about nasal staining and just say that how come axon does not appear on the stuff? And the answer will just be very simple. This thing, it lacks rough endoplasmic reticulum. There is no stuff there. All you want to remember here is just rough endoplasmic reticulum. What about the marker that we'll be using for neuron? If we see this marker, they tell you that this marker is here. You just be like, this is likely to be from neuron. Neurofilament protein, synaptophysin. You can put them in question. Occasionally, they hardly ask this one, but they can put it in question for you. But if I thought you see, I don't think you should give you a day. Neurofilament, synaptophysin. What about the astrocyte? The thing about the astrocyte is that I call astrocyte the mother glial cell. Mother. That's the name I call it. Mother cell. The mom, the mother. What you will do as a mom, think about it for the astrocyte. You are like, really? Yes. This astrocyte will give physical support to the neuron. When the neuron is damaged, astrocyte will come to meet the neuron and be like, don't worry, I will repair you. When the astrocyte when the neuron shit for his body in the name of excess neurotransmitter, astrocyte will come and pack them away. Astrocyte form a barrier around the neuron and be like, nothing will happen to you, my son. That is what you call component of blood-brain barrier. When the astrocyte is also going with neuron, what the mothers will do for their babies to put food inside their bag and be like, okay, in case my baby is hungry, I will give him something. I don't do that. My wife will continue to do that all the time. Be like, let me get water for this boy. let me get food in case, okay, let me also put biscuits here, let me, in case you want. Whereas guys don't care. That's why I call it mother. What mothers, typical mothers will do, just bring it into science and just be like, it will repair if at all is damaged. It will remove excess sheet in the name of excess neurotransmitter. It can form a barrier around the neuron so that neuron is not damaged by all manner of stuff. Then you can also serve a glycogen fuel reserve buffer. So in case energy is finished on the neuron, astrocyte can give some, release some, what do you call it, glucose. And that's all. And if anything should happen to your child, the guys don't really do much. We don't react much. If someone should beat the child anyhow, you come and see the way mothers will react in real life. You already see the wig is already off. That one is off and they start reacting. I call that reactive gliosis. When the neuron is damaged or there is an injury to that neuron they are guiding with all their life, they will be the one to react. You call it reactive gliosis. Where is that gliosis coming from? We say astrocyte is a glia cell. They will be the ones to react. Just see them throwing tantrum and start saying all manner of stuff. And that's what you have there. When they tell you that, when astrocyte is in a place, they give a signal that I'm here. And which signal do they give? You call it glia fibrillary acid protein will be positive. So when you read that beautiful question and they tell you that there is a GFAP or GFAP is positive here, just know they are talking about astrocyte, shaking up. Now, I just put this thing here. What happened if at all? I'm going to talk about it later. Don't let me disturb you. So this is the microglia. These are the other, what do you call it? The macrophages in the central nervous systems and the likes. So the CNS. So what you have here is that anytime there is an injury, they will come in and help out, just like macrophages. They are derived from the mesoderm, and that's okay. So let me show you one or two questions on neuron and also on astrocyte so far. You just see a 31-year-old female with a new onset generalized tonic-clonic seizure. They will definitely give you the story. Don't think much about the story, or else you will lose your balance. Tonic-clonic seizure, just say yes, as an intracranial mass detected on the head CT. Biopsy of the mass revealed neoplastic cell that stain positive for synaptophysin and negative for glia fibrillary acid protein. What they are just telling you here is that this patient is having a tumor that is related to neuron, but in case you are thinking about astrocyte, no, it's not the one. These neoplastic cells most likely originate from the same precursor tissue as which of the following? Neuron, synaptophysin, neurofibrillary protein. Okay. So that's what we have there. Okay. So see this one, astrocyte, on the astrocyte. Okay, I think I have quite a number of questions on this one. So look at this. A 33-year-old man is brought to the emergency department 20 minutes after he fell from the roof of his house. On arrival, he is unresponsive to fever and painful stimuli. His pulse is 72, blood pressure is this, and a CT scan of the head is showing a fracture of the anterior cranial fossa and 1 centimeter laceration in the left anterior orbital gyrus. If this patient survives, which of the following will ultimately be the most common cell type at the injured region? The answer is astrocyte. The same thing we talk about. So just look at it that way, just be like, it's the same astrocyte. Astrocyte will still be the one. All those other cells, they don't do up to what astrocyte will do. So this is just a case where you have hyperammonemia. A patient that is having hyperammonemia will tend to have diffuse astrocyte swelling. In any condition, you just want to note that and move on. So don't forget the markers you are going to see in astrocyte, this GFAP, glia fibrillary acid protein, the markers you are going to see in the neuron, synaptophysin, and the neurofilament. Please don't forget those two. think neurofilament protein. Don't forget those and the synaptophysin. Don't forget those two. Think about them. Write them out so that you don't forget them. So when they paint the scenario for you on the microglia, it's just going to be related to macrophages, definitely. So a 56-year-old man dies in the hospital due to aspiration-related complication. The patient was admitted 5 days ago with right-sided weakness, sensory loss, blah, blah, blah. CT scan reveal an area of hypodensity. Okay, histology finding after staining for lipid has shown the cells most intensely. So we are going to do this later. Don't worry yourself now. What about the ependymal cells? All of us here, we've heard about ependyma before. Ependyma, they help to produce CSF. They help to produce CSF. So they are ciliated simple columnar glial cells lining the ventricles and central canal of spinal cord. So what they do is that apical surface are covered with cilia, which circulate the CSF, they beat it so that the CSF can move, and microvilli, which help the CSF absorption when they need to absorb. So we have a specialized form of ependymal cells. You call them choroid plexus, and they are the one that produce the CSF. Shikina, it's all about CSF. CSF production, choroid plexus, CSF movement, the other ependymal cells that are not specialized. That's all. Where are they coming from? Neuroectodermal cells or neuroepithelial cell of the neural tube. So they give you this kind of question. Something like this. A previously healthy 16-year-old boy is evaluated for progressive headache and blood fissure that started several months ago. The headache are more severe upon waking up in the morning and are often accompanied by nausea and vomiting. Raise ICP, definitely. It takes no medication and does not use tobacco, alcohol, or illicit drug. Physical examination is notable for bilateral papillary edema. Raise ICP, definitely. MRI of the brain is shown to you. They gave you an image. Now say that this patient brain lesion most likely originated from which of the following cells. So maybe by the time you see it, you'll be able to see something related to all the ventricles dilating and the likes. You can't see any lesion there. They don't talk about obstruction anywhere. Likely it's just due to overproduction of CSF by the, so you start thinking towards something like ependymal cells. Just about CSF. So that's that. What about the myelin? Everyone knows myelin, but I want you to pay attention here. Myelin. God is wonderful. God is good. This is neuron for you. This is neuron. Cell body. Dendrite. Axon. I'll just represent it with the line. Cell body. Dendrite. Axon. I'm just representing it with a line. What God did is that it wrapped this axon with a particular insulating material. You call that a myelin sheet. So some neurons are just myelinated like this. Can you see the way they are? So they are just myelinated like this. Permit me to just show you. They are just myelinated like this. Okay. Some are not myelinated. Okay. So what happened? Where will USMLE hide here for you? And I just wanted to get the concept because you can easily reason them out. What happened is that this axon normally has some attributes. This axon has what we call this axon has what we call very, very high membrane resistance. Okay. Where is the resistance coming from? What do we mean by resistance? Resistance is just that difficulty in a way to the flow of maybe potential that they experience, or current, let me put it that way. So the thing is this one that is myelinated, we notice that place you don't have myelin there, the resistance there has fallen. This area you don't have myelin, the resistance there is very low. Because the resistance there is very low, it will be easy for transmission of current through them, that area. Okay. So this place that is wrapped like this, they have very high resistance. So if they talk about sodium channels concentration, the sodium channel concentration will be very high in this region that you don't have myelin. You call those region node of Ranvier. Sodium channels are very high there. So when a current, maybe some sodium need to move in, just rushing through that area, because the resistance there is low. Very well. Okay. Now, if current now want to pass, what happens is that the current will come, will move from one node of Ranvier, just little will pass through the other, little current, but they usually move from one node of Ranvier to another node of Ranvier, to another node of Ranvier, to another node of Ranvier. You call that sortatory conduction. Another name you can give it is jumping conduction. So what it means is that if you set up a current electron here, and you put electron here too, that two of them should run. This one that is running on this unmyelinated neuron will take a longer time to reach this place, the end. This one that is running on myelinated neuron, because you now have jumping movement, jumping conduction, they will end up reaching the destination in the shortest possible time. And that will bring you to the two terms they will be testing in question. One of them is time constant. The other one is what you call the space constant. What do they mean? If you ask these two electrons to move to cover the same distance, how much time will it take the unmyelinated? How much time will it take the myelinated? Don't forget what I said, the same distance. This unmyelinated will take a longer time to cover the same distance, while the myelinated will take the shorter time to cover the same distance as the unmyelinated. You call that there is a reduced time constant in the myelinated neuron. Okay, let us assume that we give two of them now instead of the same distance. Let's just give them the same time. We give this one 10 seconds to move. We also give this one 10 seconds to move. In 10 seconds, it might just be just from here, just permit me to use that unit, from here to here, that this electron will have moved, while this one has moved through times 20 of this axon. So this one will have, within that same 10 seconds, this one covered this distance, short distance. Within the same 10 seconds, this one has covered a very long distance. We say that myelinated neuron, they have increased length, distance, space, constant. Because they can cover longer time within the same time, longer distance within that same time that is that same time you are correlating the unmyelinated neuron with. They will cover longer because they are jumping. They just jump through and they will have covered a lot of distance. You say they are having increased space constant. Why this one is having reduced space constant? Within that same time, this one wouldn't have covered much distance. So this is reduced space or length or distance constant. While for the myelinated, you say there is a increased space constant. So if the question asks you that this is an unmyelinated neuron, what will happen when you myelinate the neuron? Which of the following will change? just check for something related to space constant and time constant. All right, so never
So,
forget.
Dr. Festus, so the time constant is reduced in myelinated neurons.
You can easily reason it out based on
The
that
rate
explanation.
constant increase. Okay.
Do you get it? So don't you must understand why it's reducing. You just need to fix one variable. The two variable here is the length and time. If I make the length the same thing for them or the distance the same thing for them, how much time will it take each of them to cover this same length? This one that is myelinated will take a shorter time to cover it because this one is jumping, while this one will take a longer time. So you see the time constant here is reduced, while the time constant with respect to unmyelinated neuron is increased. Let us make the time constant and see what is going to be the length the electron will cover while moving through each of these neurons. If I fix the time, then in a very fixed, that short time that I'm using, I'm measuring the length that will be covered. This one will cover a longer length. We cover the longer distance compared to this unmyelinated neuron. So you now say that the unmyelinated neuron has a short space or length constant, while the myelinated neuron has a high space or length constant, because in that same time, this one will have traveled a longer distance. Shekena. Okay, that's good. Is there any information I need to give you here again? What myelinates the neurons in the central nervous system? What myelinates the neuron in the peripheral nervous system? In the central nervous system, what myelinates the neuron there is the what? The oligodendrocyte. In the peripheral nervous system, what myelinates the neuron there is the Schwann cell. Do you get time constant and the length constant, everyone?
Yes.
Yes.
Yes, I get. So I don't get the capacitance.
Did I mention anything on that capacitance? So how come you say you didn't get it when I didn't even say anything about it? Eh? Okay, let me just say
I'm
one
looking at
point.
it.
Let me make a point under the capacitance. The capacitance is telling you about, it's just like opposite of resistance. I don't want you to think about this with respect to, this is not about node of Ramphia. This is about that place that is myelinated here. This myelinated region, that's where you make reference to the capacitance and the resistance. So this region that is myelinated here, the capacitance is low. The ability to accommodate electron is low. So if electron want to pass through them, it won't want to pass through them because the capacity to accommodate, to allow electron to pass through them is low. It won't pass through them. Another name for reduced capacitance is increased resistance. So resistance here, you say is high. Electron does not want to pass through that region that is myelinated. Do you get it? So they will rather want to pass through this node of Ramphia. Do you get it? So that's where the reduced membrane capacitance is coming from and increased membrane resistance is coming from. It's about this region specifically that is myelinated. So electron will not want to pass through them because the resistance is high or the capacitance is low. The electron will now want to pass through this node of Ramphia where the capacitance is very high and the resistance at that node of Ramphia is very low. So you just see them jumping through all those regions of low resistance. Shikena.
Thank you.
Do
I
you get it?
understand. Yes.
It's all right. Okay. So that's what you have with respect to this. So revise your what is myelinating neuron in the CNS, what is myelinating neuron in the PNS. There is a point I need to make here. They love it so much. It's about the cranial nerves. Cranial nerve 1 and 2. Please always try to separate them from cranial nerve 3 to 12. So what happened here is that cranial nerve 1 and 2, more specifically cranial nerve 2, they regard it as sorry, they regard it as part of the central nervous system. While the other cranial nerve, they put them under the peripheral nervous system. So when you are talking about the cell that will myelinate them, you talk about the oligodendrocyte for the cranial nerve 2 and 1, but 2 more specifically, then cranial nerve 3 to 12 for the myelinated by the Schwann cells. All right. So let me just show you 1 or 2 questions. Then we leave.
Dr. Festo, sorry, what did you say about 1 and 2? You said they are part of CNS.
They are part of central nervous system.
1 and 2, okay.
More specifically, 2.
2.
Yeah. Okay, just for you to note that anyway. So please don't forget, they are more likely to test that. So when we get to pathology that are related to central nervous system, you will see us talking about optic neuritis. Optic. You are like, why are you talking about optic neuritis? But you do not mention anything about the other cranial nerves. You are now going to remember that I specifically say that cranial nerve 2 is part of central nervous system. The others, so in multiple sclerosis, we are not going to talk about all these cranial nerves, cranial nerve 3, 4, but we are going to specifically bring in 1 cranial nerve, and that's cranial nerve 2. All because cranial nerve 2 is part of central nervous system. When we get to another condition called progressive multifocal leukoencephalopathy 2, you can also make reference to those cranial nerves. Okay, that's that. Let's look at the Schwann cell. Sorry, I wanted to show you 1 or 2 questions. Okay, I just want to show you 1. You can easily answer them by yourself when you are solving questions. Let us mute all our mics. A 26-year-old woman is brought to the emergency department due to acute onset diplopia. Medical history is significant for episode of blurry vision involving her right eye that occurred 6 months and 2 years ago. This episode were associated with deficit in color vision and pain made worse with eye movement. The patient recovered the majority of her visual acuity after a few months in both cases. On neurologic examination, she has a visual acuity of 20/20/20/40. Now say mild right optic disc atrophy and a relative apparent pupillary defect in the right eye. Don't overthink about this question. That majority of your questions, we are going to end up, when we do the eye, we are going to be making all those diagnoses. You will see how you make them. So don't even bother yourself about any diagnosis for now, because this is this preliminary stage. So the thing is that you don't really need to make the diagnosis for some questions before you solve them. So now let us see the question, where the question is going. There is a slowed, impaired adduction of the left eye with right lateral gaze. You just notice that the left eye, if you go to the right, you want to shift the 2 eyes, you want to look to your right, the left eye is not really moving the way it should move. Convergence testing show normal adduction in both eyes. That's for the convergence. Now say the remainder of the neurologic examination is unremarkable. This patient diplopia is most likely caused by which of the following mechanism? So what you are likely to be dealing with is just the nerve that is supposed to supply what we call the medial rectus. Okay, so let me show you the eye. This is the eye. This is the right eye. This is the left eye. So these are the eyeball. This is the medial rectus for the right eye. This is the nose. Where is the nose? This is the nose. Okay, this is the mouth. This is the medial rectus. This is the lateral rectus. This is the superior rectus, inferior rectus. Permit me to put my inferior oblique here, because this is where it's going to move the eyeball to. And permit me to put my superior oblique here. This is because this is where it's going to move the eyeball to. So if you come to the left eye, this will be the medial rectus, lateral rectus, superior rectus, inferior rectus. This is where the inferior oblique will move the eyeball to. This is where the superior oblique will move the eyeball to. So this question is now telling us that there is slowed and impaired adduction of the left eye with right lateral gaze. If you ask this patient to now look to the right, you put your finger here or a pole here, you now say, "Oh, look to the right." You expect this eyeball to be moved by this lateral rectus, right lateral rectus, and this left medial rectus. You should move the eyeballs to this direction, towards this direction, towards this star. You should look towards this star. So you are supposed to use these two muscles. This is one. You're also supposed to use this. We just noticed that there is a slowed and impaired adduction of the left eye. So this one is not really moving the way it should. So which nerve is supplying this medial rectus? You are going to get to a place where I will be talking about LR6. All of us know this. XO4. AO3. AO3. Okay. Since this is just horizontal motion, we don't know what will happen with vertical motion. We don't know. So this is lateral rectus for the right eye, medial rectus. Lateral rectus for the right eye is supposed to be supplied by cranial nerve 6. The medial rectus for the left eye is supposed to be supplied by cranial nerve 3. So if this medial rectus is not moving, this one is not moving very well, likely the cranial nerve 3, this patient is likely having cranial nerve 3 palsy. They now tell you that convergence test shows normal adduction in both eyes. That is, you are not using the lateral rectus here. They just bring an object here and they are moving them closer to the patient and different kind of thing. So they showed like normal, there is a normal response there because you are not moving laterally here. There is no issue because with respect to the convergence test, you are likely to be using something like this superior oblique. Do you get it? There, in one way or the other. So everything is normal. Okay, so now say the remainder of the neurologic examination is unremarkable. The patient diplopia, likely caused by which of the following mechanism? Since we are suspecting cranial nerve 3 palsy, or because the medial rectus is not moving very well. So what is like, but it's not that maybe it's not moving at all. It's not moving very well. The movement is slow. You start talking or thinking towards the myelination problem. Slow. It's just slow. It's not maybe it's not occurring. It's just slow. Likely the cranial nerve 3 was actually demyelinated. If the answer is going to be impaired neuromuscular transmission, likely you are not going to see any movement at all. If it's loss of Hazen, you are not going to see any this thing at all. Muscle fiber inflammation and necrosis, the movement might not be there, and you are also likely to see other things that will accompany the the presentation. Then nerve compression. Nerve compression might not even move at all, but after a while, it's going to pick up again. Do you get it? That is what we call the neuroprasia. So reduced auditory conduction is a very, very good point that you can consider. It doesn't mean that others cannot cause it in a way, but they are also likely to come with other stuff. So it's likely you are just dealing with reduced auditory conduction from demyelination, shaking up. So you can see that there is a movement, but the movement is slow. That's just what I want to bring out here because I won't have the opportunity of bringing it out again. Look at this question. A 23-year-old woman is referred to a neurologist due to recent onset diplopia and ataxia. Okay, where was the diplopia in that first question coming from? This eye is moving faster than the second eye. Right eye is moving faster than the second eye. Because the fission must be aligned, this one will be picking the fission at, in fact, because of that malalignment of the fission, because this one is doing very well, this one is very slow. The patient is going to be seeing double fission, and that is where the diplopia is coming from. If you ask this patient to look up and the superior rectus for the right eye is doing well, but the superior rectus for the left eye is also having issue, the patient is going to be having diplopia anytime the patient wants to look vertically, because the muscles that are affected are vertical in in orientation, or because this one will have gotten up here while this one is still here. Can you see that? If you look at the pupil for the right eye will be at this level, the pupil for the left eye will be at this level. Malalignment. So they are going to be picking the image at different angle. The patient will start seeing double vision. All right, that's just by the way. We may look at it better later so that you will understand the question. Okay, so she has not had similar symptoms before. However, about a year ago, she experienced numbness and paresthesia involving her left leg that have since resolved. After a comprehensive neurologic examination, the physician ordered MRI of the brain, which revealed several areas of T2 hyperintensity consistent with a zonal demyelination. So we now say a diagnosis of multiple sclerosis is made. Which of the following neuronal property is most likely to decrease as a result of demyelination? Just look at it. You can look at, they love to test you on length constant and time constant. The others you can ignore them, so you don't start putting all manner of jargons in your head. These are the two they love to test you on. You can put all manner of stuff there, they are not going to test you on them. So with respect to demyelination, master your length constant and time constant very well. So when you see it, you already know where the question is going to. So that when you see those options and see other things there, just ignore them. It's likely to be on length constant and time constant. You just look at it, you are like, this is demyelination. If you are demyelinating it, it shows that in a specific time, the distance that will be covered will now be smaller compared to what it should be. And it's going to take longer time to cover a specific distance. So the length time constant is going to be higher with demyelination, while the length constant is going to be smaller with demyelination. Therefore, the one that will decrease is the length constant. Shikena. Pick your answer and just ignore the rest. These are the ones they will be testing you on, these two. All those threshold and the like, they won't do that. So look at this one. Which of the following changes in neuronal properties the most likely explanation for the improvement in a neurologic examination? A 56-year-old woman is admitted to the hospital for progressive bilateral lower extremity weakness and absence of deep tendon reflexes. Cerebrospinal fluid analysis show an elevated protein concentration and a normal cell count. As a temperature with plasmapheresis is initiated. Treatment with plasmapheresis is initiated, after which our symptoms start to improve. 4 weeks after our initial presentation, physical examination shows normal muscle strength in the bilateral lower extremity and 2+ deep tendon reflex. Which of the following changes in neuronal property is the most likely explanation for the improvement in her neurological examination? This is actually related to peripheral nervous system because you are dealing with peripheral nerves here in one way or the other. So that's what you are dealing, likely related to peripheral nervous system. It might be Guillain-Barré that you are trying to make reference to here. So, but in her, it's also related to demyelination problem. Okay, so there is a demyelination problem here. So it now asks you that with the plasmapheresis, there is eventually an improvement. So what is likely to improve in all these stuff? So there will now be increase in the length constant. Within a short period of time, the transmission you are going to be getting will be covering a longer distance because there is now improved myelination. Shakena. Do you get it? So if I thought you want to relate it to all those capacitance, and you can go and do that, but most of your question will be related to length constant and the time constant. All right. So when we get to multiple sclerosis, we're also going to be talking about those two terms very, very well. Now, Schwann cell, this is the one you see in peripheral nervous system that myelinate their neurons, and they myelinate just one neuron. Each Schwann cell will myelinate one peripheral nervous system is up. That's what it does, 1 to 1. Whereas oligodendrocytes, we call them oligo because one can myelinate up to 30 neurons. That's for the central nervous system. One oligodendrocyte can myelinate so many. So that's why they call them oligodendrocytes. Like not more than one, but not so many. All right. So that may help, at least just to be able to go around with the name. It doesn't mean that's where the name is coming from, but just for you to move around with it. Okay. There is a marker for the Schwann cell you don't want to forget at all, and that is S100. When you see it, it may point your attention towards this Schwann cell. Oligodendrocyte has a particular pattern. You call it fried egg appearance histologically. Fried egg appearance histologically. But it doesn't mean that you should put it at the back of your mind. The question will be quite specific, testing oligodendrocyte. No issue. But if I thought they are testing that, they make reference to it, just know that, okay, it's oligodendrocyte they are talking about. Let me show you how they set question in on Schwann cell. An intracranial mass is removed from a 33-year-old patient. The mass is composed of cells that have elongated wavy nuclei. You don't even know what they are talking about. Still relax. Biphasic pattern of growth is identified consisting of area of dense cellularity interspersed with less dense mesoid. The cell show diffuse S100 immunoreactivity. And they are now asking you about these tumors. Immediately you see S100, just know this is related to Schwann cell. Definitely this is schwannoma, Shikena. You don't even know. You don't even remember, but just remember that Schwann cell, S100, that's what you see there. You just bring it out and just pick your answer and go. Look at the oligodendrocyte. You have quite a number of questions, and most of them are related to multiple sclerosis. So multiple sclerosis is a high yield area that we're going to dig deep into, and I will show you how you'll be making the diagnosis. So just relax. Just know that most of the questions here will be related to multiple sclerosis. Okay. All right, let's leave that. Let me give you 20-minute break. Go for your break, and let's meet in the next 20 minutes. Is that okay by everyone?
Yes, thank you.
Yes.
Yeah.
Thank you.
Yes, thank you.
Yeah. Probably maybe you've even been sleeping yourself. So now so what we did before, please go through them very well. Simplify it for yourself. Revise those important things we talked about. Revise over and over again, and that's all. This is neuron action potential. Neuron action potential that you have. This is the action potential. You can pick a sheet of paper and just sketch it. Just not that you want to sketch it in exam, but so that you'll be able to remember what each area stands for. This level 1, this area they label 1 is actually resting potential. Then this area they label 2 is actually where the action potential is being generated, depolarization. Then area 3 is repolarization, while 4 is hyperpolarization. So you just want to know where is the resting, where is the depolarization, where is the repolarization, where is the hyperpolarization. They may ask you that at level 1, at level 1, which of the ion, or which of the channels rather, has the highest permeability or higher permeability. I want you to study something here. Most of the stages you will see here, the summary is that potassium is having the higher permeability. Potassium channel is having higher permeability, except during depolarization. All the places, the permeability to potassium is higher, except during depolarization. That is when the permeability for sodium is higher than that of potassium, Shikena. So when you see question about the permeability, which one has this one has just pick potassium, except the question is related to what do you call it? This depolarization phase. So they may draw the diagram for you and just label this area 2 as X, and just be like, which of the channel has the higher permeability around this hex. So you just say, since that is related to depolarization, so you just say that is going to be sodium. So that's what you need to note down with respect to this. Do you get the so that's just how you are going to be looking at this area very well. So then another important point you want to note down is about the toxin. I've explained it before. With respect to the toxin, in a very simple way that I explained it, I will re-explain it again. You have this channel. This is the channel. We call this sodium channel, actually. So with respect to this sodium channel, we have two toxins that will keep the sodium channel open. We say there, you will just imagine one molecule is pulling it on this area, this side, another one is pulling it on this side, just to keep it open. You say these toxins, they are busy opening the sodium channel. So what are these two toxins that are busy opening the sodium channel? You call them batrachotoxin and ciguatoxin. So ciguatoxin, just note it very well because that's the one they now test more commonly. Batracho, but if you can note the two, it will help you to recollect them very well. Just busy opening the sodium channel. What about the other toxin? That one sits at the entrance. That one sits at the entrance of sodium. They will just sit here. You call them ST. So sodium will not be able to go in. So they are blocking the entrance. You say this one bind to sodium channel and inhibit sodium influx. So you won't see any action potential in this one because sodium will not even go in the first place. And they are the SASIC toxin and tetrodotoxin. So if you can use that, that will help you. If it doesn't make sense to you, please use anything that makes sense to you. So that's the second important point. First point, note this diagram very well. Second point, note the toxin. Third point is about what I will just mention something now. We call it demyelination. So a nerve conduction study. Just see them talk about something about nerve conduction study where they measure the amplitude. This amplitude is just how tall this action potential is. Velocity. If they show another action potential here like this, another one here like this. So if they are very close to themselves, the velocity is very high. If they are very wide apart, the velocity is very slow. The latency of an electrical impulse.
Sorry, Dr. Festus, can you take that again?
So they give you action potential. This is the action potential, another action
Okay.
potential, another action potential. They now give you another one like this, action potential, another action potential. This one shows that the frequency is quite high.
Okay.
This one, the frequency is low.
So,
Do
okay.
you get it? So velocity will be low here. The frequency is high, velocity will be high. So that's just how you, then you can also look at the amplitude. So amplitude is how tall they are, how tall they are, how tall those action potential are. Now let us look at how they will be framing question on the tallness and the frequency. Okay, we have this one will bring us to this demyelination and axonal neuropathy. So if you are demyelinating, do you get it? You take the myelin sheet, you are removing them, maybe by one pathology or the other. The thing is that one will result into demyelinating neuropathy. Then you are going to have this kind of picture where the velocity will be reduced. Are you with me? Because it's just the myelin sheet you are removing. So velocity is going to be reduced here. Do you get it? Velocity will be reduced in demyelination. But let us talk about, you know that the pathology here is only related to myelin sheets. And when the myelin sheet is there, it increases the velocity. So when you remove the myelin, the velocity will drop. So this is the kind of picture you will see. The one lower, this is the one you will see. The amplitude may still be the same thing, but the velocity will just reduce like this. So if the question is, if the pathology is related to the axon itself, this is the axon. It's not the myelin, it's just the axon that is affected. The amplitude will reduce. So they will always give you a reference. They will now tell you that they give you another picture that is either showing increased frequency or reduced frequency, or reduce or increase amplitude. Something we shall be changing. If you notice that the amplitude, how tall those potential are, is actually what is changing. Be thinking towards the axon. You say this patient is having a zonal neuropathy. If what is changing is the frequency with which they are coming, you say the patient is having demyelinating neuropathy, Shikena. That's all on this action potential, and you are done. Revise this over and over again, then you are okay. So what are the conditions where you can talk about a zonal neuropathy? Like diabetes mellitus, toxin damaging the axon itself, hypothyroidism, vitamin B12 deficiency,
Vasculitis.
vasculitis. Let us meet our mind. So vasculitis. So that's what you will have. So you just see reduction in the signal amplitude. You just give it out for you. But if the amplitude is not reducing, so you are likely to, and the frequency is just increasing, you are likely to be dealing with demyelinating neuropathy. But if both of them are changing, you are likely dealing with something that affects both the myelin sheath and the axon, Shikena. Okay, let me show you one or two questions just for you to have an idea of how the question comes. They give you this kind of picture. Just give you something like this. And the question they ask you is that the membrane is most permeable to potassium at which of the following points? Which point do you think is most permeable to potassium? Anyone?
E.
You wanted to say point D.
D.
Mhm.
D. So this is how the permeability to potassium is. Just see it's higher, then it's come like this again. Do you get it? So it's highest around this point D, because that's when the potassium channel is completely opening and the likes. So that's just one way of testing you. Let me show you another picture. I'm coming. Sorry, I need to search for the question. And okay, I want to, the same picture, is it still there? The same picture. So, but here the question. A 34-year-old man comes to the emergency department complaining of weakness, dizziness, paresthesia involving his face and extremities. He has never had symptoms like this before. 2 hours earlier, he ate fish at a new Japanese restaurant. Neurological examination shows a reduced muscle strength and decreased tendon reflexes. Which of the following parts of the action potential curve is most likely impaired in this patient? They are just talking about those toxins. Which area will you be thinking about?
The sodium.
B.
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 What did you call the
B.
answer?
Purple.
B. B.
B.
Sodium channel.
Do you all agree with B, everyone?
Yeah.
Yeah. So
Yes.
so
No, I don't agree. Please, I
Dr.
was sleeping.
Sylvester, what do you think should be the answer?
They said B now. I was sleeping, so I agree with them.
Dr. Sylvester, God forgive you your sins and shortcomings. Because that's actually shortcoming. That's like demyelination manifestation. You know, when you are coming in late, you are sleeping when you are supposed to be awake. Dr. Sylvester, God forgive you. All right. So let me show you another picture before we see. Okay, I think I have another one. Okay. So they give you something like this in the exam. I want you to have an idea of the question. Let me read the question to you. They now tell you here that a 38-year-old woman is being evaluated for intermittent tingling and numbness of the left hand for the past several months. Her symptoms predominantly involve the fourth and fifth digits and are often brought on by driving a car. Physical examination shows no abnormality. An electrodiagnosis study is performed during which a nerve stimulator is placed on the left fifth digit, and a surface recorder is placed over the ulnar nerve above the elbow. I want you to get what they are doing. They put where? Where did they put the nerve stimulator? I want you to be demonstrating on your finger. They put the nerve stimulator where?
On the 5th.
On the left fifth digit. Then they now put a surface recorder where? Over the ulnar nerve above where? The elbow. So you can imagine it, where they are stimulating, where they are now putting a recorder. So they are stimulating, are you seeing the graph? You already understand what the graph is testing. So if they stimulate it, they want to see how long does the stuff take to get to where the thing is going to be recording, something like that. Electrical stimulus is applied and the graph obtained is shown to you. Results from the asymptomatic contralateral extremity are also shown. Which of the following is primarily affected in that patient? So this is the abnormal one. I think it's the left one, right?
Yes.
So this is the abnormal one, and this is the normal one. So what do you notice?
Reduced velocity.
Reduced velocity.
So you can
Normal,
see the distance between
normal
the new one
amplitude.
and the one that has been here. So you can see that the distance is very wide, while here is very shorter. So this one is abnormal, this one is normal. So you start thinking towards reduced frequency, reduced velocity. So where do you think is the primary abnormality here?
The demyelination.
So demyelination. So which cell
The
is
myelin sheath.
so which cell is supposed to myelinate that ulnar nerve?
Schwann
Schwann
cell.
cell.
One
You
cell.
just check for the Schwann cell in the option and pick it. And how come we are not thinking about a zonal neuropathy here? Because we check the amplitude and it's
Amplitude is normal.
so you don't. That's just the only thing they are going to be giving you diagram on. You just look at it, think about it, and pick your answer, and that's all. Another thing they are going to be giving you questions on is about I'm coming. So something related to all this electrode potential or something like that, or potential with respect to each of the ion. So they just give you something like this. Let me see the diagram too, if it makes sense. Okay. So I'm going to, okay, let me first of all solve another one that maybe does not require a diagram for you, so that I don't keep going back and forth. You see this kind of question. A researcher is investigating a new anti-seizure drug that binds to and activates GABA A receptor in the central nervous system. During the experiment, she isolates a nerve and uses a microelectrode to measure its membrane potential under the physiology condition. The resting membrane potential of the nerve is found to be minus 70, definitely. And this is GABA they are using. Do you get it? GABA. So which of the following membrane potential will most likely be recorded from this neuron following exposure to this GABA, this new drug that will increase or activate the GABA receptor? One thing about the GABA receptor is that they are modified or chloride channel. They are like chloride channel. So they will cause hyperpolarization. So this is the resting membrane potential. The thing will go lower than that. So you'll be getting something like minus 75, minus 80, minus something like that. At least it's going to be lower than 70. That's what this thing will do. That is hyperpolarization. Do you get my point, everybody?
Yeah.
Yeah, so because they are stimulating the GABA, more chloride, which is a negative charge ion, will go into the cell, that neuron, and make it to be more negatively charged. The answer will now be minus 75, shaken up. So it's not that maybe you need to sit down and start. So if they tell you that this is a neuron that is stimulating, so if this neuron is stimulating, sodium will go in and the membrane potential is going to become more positive. Do you get it? Okay, let me show you another question. Let's go through this one. So this is this. You need to pick out your pen and paper and analyze this in a way. So let us first of all look at it. A researcher has studied how the membrane potential of a postsynaptic neuron changes in response to neurotransmitter stimulation. Baseline measurement determined that the resting membrane potential is generated by a high membrane permeability for a particular ion. When neurotransmitter stimulation begins, ligand-gated ion channel open, black arrow, I will show you the diagram soon, and increase the membrane permeability for a different ion, causing a change in membrane potential. This triggered the delayed opening of voltage-gated ion channel, red arrow, which increased the membrane permeability for a second type of ion. The result of the experiment are shown in the diagram Festus will show you. They now tell you that the equilibrium potential of different ions under the physiologic conditions are given like this. Sodium is plus 60, potassium is minus 90, chloride is 75, then calcium is 125. Which of the following options will best explain the changes in these neurons membrane potential during the experiment? Okay, let me project the stuff for you. I want you to pay attention to it. It's quite easy. Wow. You need to give me 1 minute. All right. So this is the picture they are giving you. Just be looking at that picture. I just want you to have an idea of what is going on. So you can pick your pen and write the membrane, this thing I listed before down. So the one for the sodium is plus 60 millivolts. The one for the potassium is minus 90 millivolts. The one for the chloride is minus 75 millivolts. The one for the calcium is plus 125 millivolts. They are now asking you that which of the following option will best explain the changes in this patient neurons membrane potential during the experiment. Which channel do you think is going to be permeable during the resting membrane potential? They say resting membrane permeability. Which channel are you going to be looking at?
Potassium.
Potassium.
You're looking at the most negative there. So that one is going to be potassium. Do you get it? Don't forget that is the one that is determining is having the higher permeability throughout except during depolarization. Then I ask you again that ligand-gated ion channel permeability. When the ligand binds to it, which channel is going to open? Who remembers?
Sodium channel.
Sodium.
So, and what is the potential of sodium, everyone?
Minus plus 60.
Plus 60.
Plus
So that's the one that's going to first of all open. If at all any other one is going to open. They now say voltage gated ion channel, voltage gated ion channel permeability. The one we first of all talked about was ligand gated. When the you have a ligand, which may be anything, might be whatsoever thing that is binding to it, maybe any neurotransmitter. Do you get it? But when there is depolarization, there will be another particular what do you call it, channel that is going to eventually open, that its own opening is paired on the voltage of that particular neuron. So there are two of them like that that will appear like that. One of them is the chloride. Chloride channel do not just open. Do you get it? It does not just open. The chloride channel opening and that of calcium, they are actually dependent on the voltage of the membrane. That's why you call them voltage gated ion channel. They are not opening like the others. So let me come to the diagram and illustrate something to you. So here now you'll be talking about potassium. Here you'll be talking about sodium. Then here you are going to be talking about something like either chloride or calcium. So how are you going to know which one you are going to choose? All you need to check is this membrane potential coming down or going up? Since chloride is a negatively charged, if chloride channel is open and negative charge is entering, it will be reducing the potential. It shows that it is the chloride channel that opened there. If it is calcium, when it opens, the membrane potential will be going up like this. Do you get it? It shows that it is the calcium. I don't know if you understand me, everybody.
Yes.
Lovely.
So, sorry, Dr. Festus. So, with this now, so the question was it on the voltage? So, their opening depends on the change in the voltage
You
of.
get it. It's actually about the change in the voltage. So if
Okay.
they give you another graph now, you just realize that the thing is going up, it's becoming more positive. Definitely is a positive channel that open like calcium. Since this one is coming down, it's now becoming more negative, then definitely this is a negative channel, like that of
Okay.
chloride.
Okay. Could it also be because of potassium channel?
Yeah, it could also be. Definitely. But the question is asking us about the what do we call it? Um, it could also be, let me just put it that way. It could also be potassium also could be there. It could also be potassium. Do you
Okay.
get it? So if you check the options, let me
It depends
project the
on the
Is
options.
potassium voltage gated?
So it depends on the question and the option, the option.
Potassium is also voltage gated.
Okay.
We call it voltage gated potassium channel. All right. So just
Sorry, Steve. That means just to get it right, calcium, chloride, and potassium are voltage gated,
yeah,
while
voltage
sodium is
gated.
ligand
Ligand.
gated.
It doesn't mean that
Okay.
sodium also is not having any voltage, but this is a peculiar question. Do you get it? It's just more like when a particular ligand, neurotransmitter binds to it, you expect depolarization. And that is
Yeah.
actually what you are seeing here. And which ion, which channel we need to open for depolarization to occur? The same ion you'll be talking about shouting is still going to be sodium channel. That's all. Do you get it? So if, let me assume that
Yeah.
the graph they are drawing for you in your exam is coming downward. Do you get it? And they now ask you
Yeah.
that which channel is opening here, you'll be thinking towards something like chloride channel. Do you get it? So if it's
Yeah.
going up, you are thinking towards something like sodium. If it's coming down, you are thinking towards something like chloride. Just like the question we solved the other time. Do you get it? Where the GABA is the neurotransmitter in question. And if the GABA is binding to it, chloride channel will be the one that will open, shaking up. I just see the membrane potential just coming down. So the membrane will become hyperpolarized so that for another neurotransmitter to actually raise it up, it's going to take a while. So transmission will not be occurring. Do you get it? Then by the time it rises up to a particular level, you now start having other voltage-gated channel opening. So it can be chloride, it can be calcium, it can be potassium, it can be anything. So this one can be potassium, because when the potassium channel open, the potassium flows out. Do you get it? So it removes positive charge, which is equivalent to chloride coming in. It's just like I'm removing positive charge, I'm bringing in negative charge. It's still the same thing. We are just saying them in different ways. So whereas calcium, one thing about calcium is that calcium will want to flow into the cell. So do you get it? So if the calcium is flowing into the cell, calcium will raise the membrane potential. So it will be becoming more positive. So, and this graph is showing that the thing is dropping. It's either we are dealing with potassium or we are dealing with chloride. Any of the two should be the correct answer.
Yeah, Chief, sorry, I get the stage, the where the red arrow is on the chloride potassium in stage 3. But that stage 1, or rather phase 1, where you talked about the chloride, that's where I'm still having the confusion.
Okay, stage 1 as well.
The phase 1, you said something like when there's influx of chloride ion,
Are you talking about this place? Do you where this black arrow is?
No, not the black arrow. Yes, the black arrow. Yeah.
This one in this diagram
Yeah.
now you are looking at
Yes,
it.
yes.
So I was just illustrating for you that it depends on the ion that the the channel that the neurotransmitter is opening. They didn't mention any channel for you here, but the membrane potential is speaking follow of the channel that opens. So is any of these two that you always talk about with respect to those channels? So when the channel open with the ligand, it's either it's opening sodium or it's opening chloride. If it's opening chloride, chloride will flood into the neuron and the neuron is going to become more negative because chloride is a negative charge. So you will see the graph will be going downward like this. Do you get it? Compared to it going
Okay.
up. So because sodium is a positive charge, by the time sodium channel open, more sodium are coming into the cell, positive charge flooding into the cell, the membrane potential will be rising like this. Sodium and chloride, that's how they are going to be. So chloride will be coming down, sodium will be going up. So you are likely to see this kind of lower picture here in GABA. GABA is opening chloride channel. Do you get it?
Yeah.
So
Thank you.
so that's about that page. Let's move on so that we don't waste time there. I hope you are getting it, everybody.
Yes.
Okay. Other people are not talking. Maybe they are not even with us. So that's
Yes.
yeah, okay. Just get it and rehearse around those stuff. These are the sensory receptors. Don't really give yourself too much headache here, but you just need 1 or 2 points here. They hardly test this area. It doesn't mean they can't test it, they hardly. So this is not one of the IED area. So we have what we call, there is a way they label those neurons. I just want to give you an idea about them. You can practice around them, that's fine. If you can't, please you can drop it if it's huge for you. You can't because of sensory receptor failed neuro, so it's not possible. Okay, we have what we call A. You will see letter A, you will see letter C. A means alpha. A talks about the fact that what do we call it? The neuron is actually myelinated. That's what it means. So when you see letter A, it talks about the fact that it is myelinated. That's the meaning. A means it's myelinated. Anywhere you see A, this is myelinated. So when you now see them talk about alpha or delta, alpha talks about how big they are. If alpha is large, delta is small. Do you get it? So letter C is unmyelinated, letter A is myelinated. So when they give you something like A delta, it means that this is myelinated and this is small. If they give you maybe A alpha, it means it is myelinated and it's large nerve or neuron, anyhow you want to look at it. So that's that. Now, I divided this into 3 categories: the free nerve endings, the Meissner corpuscle, the Pacina corpuscle, the Merkel, then the Rovine. Don't give yourself too much headache. So just pick the few things I will say and move on. The free nerve ending, what they mediate, what they sense is just pain and temperature. No wonder they are free nerve ending. If someone touches you, you feel it. If I put what do you call it? Maybe hot metal on your skin, you will feel it. What is feeling it is just the free nerve ending, and that's all. So they are numerous in skin, so very, very numerous there. So something like the nerve that carry this pain and temperature sensation, they are going to be having this receptor type, free nerve ending receptor. So what about the one for the posterior column? You see something like pressure, vibration, and touch, Messner, Pacinian, then Meckel. So these are the ones that are related to posterior column, pressure. I call them PVT, pressure, vibration, and touch. You can look at them like that if you wish. So just for you to have an idea. Now, there is something about this rovini. This rovini is related to joint angle change or stretching. So it's just the one that senses something related to joint. So joint is enough for you to give it out for you in question. I'll be like, this is rovini corpuscle. While the pressure, vibration, and touch is related to either Messner, Pacinian, then Meckel. That's really okay. All right. If you look at this Messner, Pacinian, and Meckel, all of them are large and they are myelinated. Do you get it? They are large and they are myelinated. While if you look at this free nerve ending, they are unmyelinated. What is the significance? Clinical significance. The clinical significance is that if you want to like maybe block you want to block them, sorry, if you want to block them maybe with a particular drug, so the pain and temperature, you can easily quickly block them because one, they are not, some of them, they are just small, they are not really that big in a way. You can see they are just A delta C. They are small nerves. So when you give them, the question we just talk about the fact that they want to do an operation, they give maybe they infiltrate or they give they've given the anesthesia. The patient is not likely to feel any pain and temperature, but the patient will still be feeling that you are holding the leg. The patient will still be feeling vibration. If you, for example, in orthopedics now that we use all those big machines to do one procedure or the other, the patient will be feeling the vibration despite the fact that there is no pain, but the patient will not, despite the fact that there is no pain, the patient will still be feeling the vibration, touch, and pressure. When you touch the patient will know you are touching. But if at all you put a needle, the patient should not feel the pain. If you are using diatemy, the patient should not feel the temperature, should not feel anything. So that is what is causing it, because these neurons, they are blocked later. The reason why they are blocked later is because they are large. So they do not get easily blocked by all those, what do you call it? Maybe spinal anesthesia and different kind of thing. They don't get easily blocked. Whereas those ones that are small ones, they get easily blocked. Do you get the idea? So don't forget that alpha, delta is talking about their size. A and C talks about their myelination. So if you are seeing alpha talks about the fact that they are large, while the delta talks about the fact that they are small. So most of those nerves here, they are small nerves. So when you are doing the anesthesia, they are going to be easily blocked because they are small. So the patient will not feel the pain and temperature, but after when they just quickly give the spinal anesthesia, the patient shouldn't feel any pain and temperature. The anesthetics will just be like, you can start the operation. However, the patient, if you touch it, you say, do you feel someone touching? You say yes. They still feel. After the pain and temperature is lost, after a while, the pressure, vibration, and touch also will be lost. Shaken. Do you
Okay.
get my explanation, everybody?
Okay, so it's because they still feel not pain, but because of the delayed blocking of the vibration and temperature senses.
I don't get your point.
No, you said that there's a delay, that when they don't feel pain, but they still feel somebody's holding them because of the delayed blocking of the vibratory senses.
No, it's because these nerves that mediate this pressure, when you are mounting pressure on them, you are using machine on them, you are touching them. Those are the sensations. Do you get it?
Oh,
So they can still feel those stuff because the nerves that carry this information, they are large.
and large
They don't
and
get easily blocked compared to the
yes.
small neurons.
Okay,
Do
I
you get it,
understand.
everybody?
Yes, thank
So
you.
when they give you question on it, you just think about
Yes.
it. You don't need to sit down and overthink it. No issue. And that's all here. We come down to the peripheral nerves. With respect to the peripheral nerves, we talk about the way the nerves appear, the way they arrange themselves, the neuron. You first of all gather them together, then put endoneuron, then you start bringing all these stuff together and start just wrapping them and just eventually forming one nerve fiber or bundle, anyhow you want to look at it. So these are the covering. You have the endoneurium, perineurium, epineurium. Out of these three neurium, I want you to note endoneurium very well because it is the one that is affected in Guillain-Barré syndrome. Do you get it? It is the one that is affected in Guillain-Barré syndrome. Don't forget this. When we get to Guillain-Barré, we are also going to talk about it in a way. I think that's okay. If at all you see any question on perineuron when you are practicing for questions, you can go through it. I won't really solve question on this because it's just related to Guillain-Barré. We'll be solving it later. Now, this is another ball game entirely, and I want you to pay attention here. It's very easy to understand it without cramming anything. We have two conditions here. We have what we call ischemic injury. It's related to central nervous system when we'll be talking about stroke, blah, 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 and the like. We also have what we call nerve transection when we'll be talking. We usually make reference to peripheral nervous system. It doesn't mean you can have nerve and neuron transection of neuron or fiber, neuronal fiber in the central nervous system. You can also have it. Do you get it? Like in Brown-Sequard syndrome. But what we have here is just when you have an injury, when the neurons suffer an injury, what will be some changes you are going to see. You are going to take that neuron and divide it into three sections. And I want you to flow with this division. The first section is, this is where the injury is. This is the site of the injury. And that's how you are going to be studying all your questions. This is the site of the injury. So this is about the peripheral nerve now I want to look at. This is the site of the injury. They just get a knife and cut it. Where most of the proteins that you see in the axon, they are actually produced in the cell body. So it's like you are cutting this distal fragment, you are cutting it away from the source of life. So this one will undergo what you call degeneration. And they give it a special name, Wallerian degeneration. Don't ask me where Wallerian is coming from. If it's that bad for you, just link it to Wale. Maybe the person that got the name is just Wale, just for Wallerian degeneration. If you like, if it doesn't make sense to you, just leave it. Wallerian degeneration, or just say degeneration. They just degenerate because you are cutting them away from life. Now, since they are going to be degenerating, what will happen is that microglia cell will now come. They will now start digesting the myelin sheath and the axon. They will swallow majority of myelin sheath. They will swallow majority of the axon. Someone wants to say that, so what now happened to the astrocyte? This is not central nervous system. We are not talking about astrocyte here. So you are going to be making reference to something like microglia cells. You won't talk about anything like astrocyte. So they will just come, start releasing all manner of digestive enzyme on the neuron, and they just start swallowing them. So they may talk about the fact that they do histology on the nerve. They now see a particular neuron that has a lot of fat in it. The answer is, they see a particular cell that has a lot of fat or lipid in it. The answer is microglia cell. That's the cell, because that microglia cell has swallowed majority of the myelin sheath and is now becoming pregnant with lipid. It's becoming lipid laden. That's what the microglia cell has become. So you might just want to pay attention to that in question. Do you get my point under the Wallerian degeneration, everyone?
Yes.
One person got it, others, I don't understand. Are you tired? Do we close it today and continue tomorrow?
No.
Okay, because you may have all the days. You are the one. I am available, so you can have all the days to yourself, but you need to interact so that we'll know whether you are getting it or you are not.
We got it.
Doctor,
Thank
We
you.
are getting it.
all right. So that's about the Wallerian degeneration. So never forget your microglia, infiltration. You just come in and just digest the myelin and digest the axon. Now, what happened to these two other parts? The way God did it is that if I thought there is an injury, there is movement away from that injury. And that's all you need to know. They move away. The neuron will retract. Everything retract away from injury peripherally. If we are talking about peripheral nerve, they retract away. Everything retract away. It's just like a reflex. So with this small fragment of this axon that is left here, you will be talking about a zonal retraction. We're like, wow, that's lovely. Let us look at the cell body. Everything within the cell body is going to look like they are moving away from the site of damage. So all of them will now start moving towards the periphery. And that's the concept. So what you are going to check in the option will just be something like displacement of nucleus towards the periphery, dispersion of the nisu substance. Do you get it? Dispersion of the nisu substance and or nisu bodies towards the periphery. You can see all of them too. They are leaving this region and moving towards the periphery. Everything is moving towards the periphery. The nucleolus can also become enlarged. Why is the nucleolus becoming enlarged? Even though they are moving away from the site of injury, they are also trying to produce some protein to help with one or two repair. Shikena. Do you get it? They are trying to produce. So the nucleolus is the site for production of the ribosome. Do you get it? Or ribosomal RNA. So that's where the nucleolus, that's one of the functions of the nucleolus. So it shows if the nucleolus is becoming enlarged, it shows that it's like upregulating its production in one way or the other, just to help with the repair, just to attempt repair. Then how come you are dispersing the nasogranule? See, you now remember that Festus mentioned that nasal substance, they are rough endoplasmic reticulum. How come you need to disperse them? It's just like you are dispersing them like, okay, what do we call it? You are dispersing them like you are like, oh yeah, that basket that contains all the ingredients we are going to use to produce protein. Can you bring the basket out and empty it so that we'll see which ingredient do we have? You can look at that dispersion like that. So you talk about dispersion of the nasal substance, swelling of the nucleolus. These are the things you will just put in the option for you. You can easily reason them out just to help and increase the protein synthesis. Shikena. That's all what they want you to note. So that's all about this area. This thing you call it chromatolysis. This is chromatolysis. This is under reaction. This is Wallerian degeneration. What about the ischemic injury? Let me assume that this neuron is actually in the central nervous system. What characterizes it if you have an injury on it? What you have is the nucleus will shrink, the cell body will shrink. Instead of all of them swelling like this, they will shrink. Then you also have loss of majority of the nisu substances, which are rough endoplasmic reticulum. You are not like rough endoplasmic reticulum, they actually appear bluish in a way. They appear bluish. So if majority of them are dissolved or they disintegrate, it's like opposite of whatsoever we are talking about in chromatolysis. If they disintegrate, that bluish color or coloration is going to be lost. The cell body will now appear red. It's going to appear eosinophilic. And that cell body appearing red because the nisu substances are lost, you call that red neuron. So that is the origin of that term called the red neuron. So the nisu substance, everything is lost. Rough endoplasmic reticulum is lost. And if it's lost, the neuron will now appear reddish because the bluish coloration of the neuron, of the cell body is as a result of the nisu substance. So because they are not there again, they now appear red. So that's the difference. So when you see them describing red neuron, just know it's related to CNS and you are talking about ischemic injury. When you see them talk about the nucleolus becoming enlarged and this one becoming, the cell body is swelling up and this and that, they are just likely talking about peripheral nerve transection. All right, let me just show you one or two questions just for you to put them together in a way. Another name for this nerve transection is a zonal reaction. Another name for what do you call it? Ischemic injury is acute neuronal injury. Just for you to have an idea of what's going on. All right. See this question. They talk about anterior horn cell of the spinal cord of an experimental animal demonstrate a cell body rounding, peripheral displacement of the nuclei, and dispersion of the nisu substance to the periphery. The finding described most likely indicate a zonal reaction. Shikena. That's a zonal reaction, or is just related to something like nerve transection. So they give you this question. A 28-year-old woman comes to the office due to pain at the previous surgery site. The patient underwent cesarean delivery a year ago and had no issues with wound healing. However, over the past 2 months, she has had intermittent sharp and burning pain at the incision site. Physical examination revealed a well-healed low transfer scar. There is a small knot palpable at the left end of the scar, light touch of which elicits severe pain. Cutaneous sensory nerve injury and abnormal axonal regeneration are suspected. And I say, which of the following ion is most likely upregulated? If you now need to touch it and the patient is now having exaggerated response or feeling or sensation, so it shows that something like sodium, because when you touch it, you are like trying to stimulate the receptor. So when you are stimulating the receptor, let me assume that you just expect a response on the grade of 1 to 10, something that you can put on 2, and you now start seeing something like 9/10. So it shows that like there is excessive depolarization compared to the normal. Which ion is responsible for depolarization in the neuron? Sodium. So the answer will be sodium. Shaken up. Okay, let me come to this one. They tell you here that a researcher is studying neuronal changes in various physiologic and pathologic states. Microscopic examination of neural tissue obtained from experimental animal revealed neurons with shrunken nuclei and eosinophilic cytoplasm, lacking nisogranule. They become eosinophilic, which is red, because the nisogranule are no more there. They've been lost. They've been degenerated. So they become reddish in color. You call that red neuron. Now say, which of the following is the most likely cause of this finding? You start thinking towards something like neuronal injury, neuron in the CNS, and the like. So the answer will be something like irreversible ischemic injury in the CNS. So that's what you have. So I just want you to master this. I'm still going to talk about this again over and over again till it's going to stick. So just for you to have an idea, when we get to stroke, I will still mention this ischemic injury again.
Okay, Dr. First, should I wait till then if I ask my question? Because I think that concept of red neuron is not so clear to me.
Okay, the concept of red neuron is quite straightforward, so don't overthink it. The nisogranule should make the neuron to become blue. If in this ischemic injury, majority of them are lost, they are broken down. So you don't have nisogranule again. The neuron will now appear red instead of blue. Do you get it? That's just the red neuron. Chicken.
Okay, that's just it. Okay.
All right. So you come down to the neurotransmitter. With respect to this neurotransmitter, I don't expect you to cram anything here. Don't cram anything. You just need a concept that when you read the question about the neurotransmitter, that will tell you that this is where the neurotransmitter is produced from. That's all you need from me here. These are the neurotransmitters. All of you know about acetylcholine. There is no one here that has never heard about dopamine, GABA, or norepinephrine and serotonin before. So how are you going to do it so that when you get into an exam, it's not going to appear that you start mixing them up? And we are going to practice it now. You are going to be using the letter that is closer to the first letter in the word of some of them. Like acetylcholine, letter A. It should be something where the acetylcholine is starting with letter A. I won't explain this twice. It's starting with letter A. Where this acetylcholine is produced from will be related to a letter around A, B, C. You can be thinking towards something like B. So that is will help you. Come to norepinephrine, letter L. K, L, M, L. The letter that will be around it will also be, that the letter that will start where it is produced from is also going to be related to a letter around N. Do you get it? Norepinephrine is N, the letter will be around N. Serotonin is starting with S. Where it's produced from is the letter that will start that, the name of where it's produced from will also be closer to that letter S. So now look at it. Acetylcholine, basal nucleus of Meninges. A, B. Non-epinephrine, locus coeruleus. Just look at it and be like, non-epinephrine is letter N. Which letter is closer to it? You will say, okay, letter L, locus coeruleus. Serotonin, letter S. Okay, I will be thinking towards something like R, Rave nucleus, something like that. It will help you in the next 4-5 weeks. You will still be able to remember all of them. We now have something. We have something in Ibadan, in Nigeria. Is it even in Ibadan? We call it Dove TV anyway. I don't where? Some people will know Dove TV. So Dove TV, is it anywhere it is? Dove. Okay, Dove is related to Redeem now. Am I wrong?
No, no.
No, you are not.
Okay, so you shouldn't forget it. So Dove. So you can use Dove, just Doves, to note this. Doves, you just want to remember Doves and Gano. The dose, D here is dopamine, the V and E is just ventral tegmentum, then this S is the substantia nigra pars compacta, Shekina. What about the GABA? Use Gano. GABA, Gano. We have something we call Ganon. We book called Ganon. So Gano, I call it Gano. So GABA, GA is Gano, GABA, the NU is the nucleus accumbens. So I already know where all the neurotransmitter they are likely to test me on emerge from. So if they tell me, give me a question that maybe there is a damage to the basal nucleus of Meninges, which of the following neurotransmitter is likely to reduce in quantity, I'll be thinking towards something like acetylcholine. If they give me a question that's related to ventral tegmentum or substantia nigra pars compacta, and it is damaged, I'll be thinking towards something like dopamine. Nucleus accumbens, we think towards GABA. Locus coeruleus, we think towards non-epinephrine. Nerve nucleus, we think towards serotonin. All right. So that's that about that. In Alzheimer's disease, we have some disease condition that just one neurotransmitter you see that is associated with them. Okay, one of them is low, the other one is high. So you've all heard about Alzheimer's disease before. I wanted to say neurocognitive disorder, but it's all right. At least you understand me when I make some mistake in pronouncing some stuff. So I'm saying opposite of what I want to say sometimes. So Alzheimer's disease, so it's starting with A. The neurotransmitter that is reduced in it is also starting with A. You just call it A, acetylcholine. I don't need anyone to repeat this for me. So when you read the question, just be like, they will just give you Alzheimer's disease. We are also still going to look at it later. Just ask you this question, that which of these, the following neurotransmitter is likely reduced in this patient? The answer will just be acetylcholine. We've all watched, or majority of people have watched Skilled Game. Is it Skilled or Skilled? Dr. Penne, what's the name of that game?
Squid.
Can you spell it for me?
SQUID.
UID. Okay, that is Skilled, right? So this is, you can call it Skilled if that one makes sense to you. All we need there is just letter D and this schizo. So schizophrenia, they behave abnormally. So what you have there is elevated level of dopamine. So the dopamine level is very high in them. That's why one of the drugs you give them is a dopamine antagonist. So just to bring down all those excessive things, the manifestation they have. So that is just the skill. These are just one neurotransmitter. That's all. So if you can just note these two, that's very okay for you. The others, I will show you how you'll be making the diagnosis, and in a very simple way, Huntington disease, Parkinson's disease. When you see them in question, they won't give you a headache. All right. Let us do one small exercise before we look at one or two questions. I will just ask you to tell me where the thing is produced from. Acetylcholine is produced from where?
Basal nucleus of Meninges.
Is of man.
Serotonin is produced from where?
Raphael nucleus.
Raphael nucleus.
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 GABA is produced from where?
Nucleus
Nucleus
accumbens.
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 Dopamine is produced from where?
Accumbens.
Ventral
Ventral
tegmentum
Nagra.
and substantia nigra compacta.
Okay. Which one is remaining? Which neurotransmitter is remaining?
Leucocellulose for
Leucocellulose.
norepinephrine.
Norepinephrine, where is it produced from?
Leucocellulose.
Leucocellulose.
I think so. If I thought you see any other one that's remaining, go and rehearse it. So that's just how you rehearse this one, and you are done with it. Rehearse it, pick a sheet of paper, write it down, use that logic. Don't go and be cramming the other stuff. I'll be like, what will I say in anxiety? What will I say in Huntington disease? Don't give yourself all those headaches. So even though we may see one or two questions on them now, this is not the right time to solve them. So see this question, just for you to have an idea of the way the question will be coming. A 29-year-old woman comes to the office for treatment of anxiety that has worsened over the past years. She finds herself worrying all the time and fear that she may not complete her graduate study in time to meet the requirement for her degree. The patient is also worried about her son's health and anxiously obsesses about him all the time. She says, my anxiety just comes out of the blue, one way or the other. I'm anxious all the time. The patient has no history of medical problem. Physical examination is unremarkable. Blood counts, complete blood counts, chemistry panel, TSH, B12 level are normal. An anxiety disorder is diagnosed and fluoxetine is prescribed. The patient's anxiety begins to improve over the next 4 to 6 weeks. The physician explained the medication inhibit the reuptake of a neurotransmitter released by a specific set of neurons. So the one thing about all these drugs is that when we do them, you will have an idea of what they produce. So don't be worried. Now, this is not the right time to start worrying which drug is fluoxetine, but this is an SSRI. Do you get it? So SSRI. So this SSRI is going to inhibit the reuptake of what do you call it? Serotonin. So if it's inhibiting the reuptake, so it shows that the level of serotonin will rise. But that's not even what they are even asking you. They just want to link the drug to the neurotransmitter they want to ask you about. They just say that the physician explained the medication inhibit the reuptake of a neurotransmitter released by a specific set of neurons. These neurons are most likely part of which of the following structure? So which neurotransmitter are we talking about here? Serotonin. Where is serotonin produced from?
Raphael nucleus.
That's all. Just pick your Raphael nucleus and leave. So you can see that the question is not difficult. Probably maybe because you don't know the logic to it. You start overthinking about them. And you think you need to sit down with each of them and cram what is produced on each of them. You don't need to. If you are solving this question in your what do you call it? U-word. You may be tempted to start cramming what is produced from this one, what is produced from that one. And these are the things that make USMLE complex for you. What is produced in locus cellulose, anyone?
Norepinephrine.
What is produced in basal nucleus of Meninges?
Acetylcholine.
Okay, now. So we've rehearsed those ones very well. Okay, I think, okay, that's red nucleus anyway. So we'll be looking at them. So just for you to have an idea of another one entirely. Okay. Look at this one. Let me see if this is the right time. I'm coming. Okay, yeah, this is good. Okay, a 75-year-old man is brought to the emergency department after he was found unresponsive at home. The patient has a history of poorly controlled hypertension, blood pressure is 240, 120, and pulse is 104. He has extensor posturing and pinpoint pupil. CT scan of the head without contrast reveal an acute pontine hemorrhage with associated mass effect. The patient died several hours later. Autopsy revealed disruption of all pigmented neurons in the posterior rostral pons at the level of the pons. All right. these neurons normally produce which of the following?
No,
The
epinephrine. Sorry.
okay, okay, it's all right. We've not really gone through it where you are going to see all those. Well, it's all right. Let me just move this till we do the brainstem. I will show you. So you can easily link them just for you to have an idea of the way they ask the question. Let me see if this question makes sense. Because some of them you need to have an idea of what you see. I will show you all those ones. Just be relaxed. Um, when you solve this stuff here, it will make sense to you. When we do all those escitalopram and the likes, all those um, drugs. Okay. I think the justice is done to this. So the only thing that is left is just for us to start linking them to one region or the other, and I will show you everything. Just relax. So this is about the meninges here. What is it about this meninges that you want to note for your exam? Not too much. You all know about, you've all heard about this thing before. The dura mater, the arachnoid, and the pia mater. Okay, between the dura and the arachnoid, you have what you call subarachnoid and subdural space. Between arachnoid and the pia, you have what you call subarachnoid space. Do you get it? Then above the dura, you have what you call the epidural space. All right. So those are the two spaces we have. So just for you to have an idea about them, this is it again. The dura mater. This is the dura. This is the arachnoid. And this is the pia mater. So pia is the innermost one. Above it, we call this epidural space. This is subdural space. Subdural space. This is subarachnoid space below the arachnoid. There is nothing like subpia, in case you are saying that in your mind. So there is no subpia space. You don't have it because it's quite adherent to the surface of the brain. So these are just the spaces you know, and I'm very sure you have all heard about them before. Now, the first question you want to answer is that where are they derived from? The dura comes from mesoderm. While the arachnoid and the pia, they come from neural cell, chicken. So just rehearse this over and over. Dura, mesoderm, because it's closer to the bone. You can look at it like that. It's closer to the bone, mesoderm. Arachnoid and pia, they are closer to the brain, neural cell. That may help you, at least, just in a way. But don't forget that these are meninges. They are not the brain substance. At least, neural cell is related to nervous system. So you already have an idea that, okay, this is how it should be. At least for you to differentiate between mesoderm and neural cell. And that's all about this one. There is a particular epidural. There is a particular hematoma. We call it epidural hematoma. So when you see them talk about epidural hematoma or blood accumulating in this epidural space, I just want you to use this opportunity to note the artery that is affected. The artery that is affected, you call it middle meningeal artery. Never forget this. So this is just the second thing you want to note on this page. Middle meningeal artery. Middle meningeal artery. So that middle meningeal, if it's affected, the patient will have epidural hematoma, shikena. Look at that and move. So that when they give you epidural, we are going to get there. When they give you already, your brain has already mastered something about it, middle meningeal artery. What about the blood-brain barrier? And I want you to pay attention to this area very well. Blood-brain barrier is formed just to prevent some abnormal substances entering into the brain. We don't want you. Please, let's mount a barrier here. You say, thank you, Mr. Brain. That will be awesome. Okay, that's good. What are we going to put together to form this barrier? First one is the tight junction between the non-fenestrated, that the cells do not even have any hole at all. They are not fenestrated. Nothing can pass through them. Non-fenestrated capillary endothelial cell. Can you see them? They are non-fenestrated. Then we now come again and put them on a basement membrane. We arrange them on a mat or on a bed. We call that basement membrane. You now bring what we call the pericytes. They are not here, but they are just another set of cells that you see them around. They extend and form and extend around the perimeter of the barrier that is being formed, pericyte. Then you have another you have this astrocyte. You call it astrocyte foot processes. These are the astrocyte foot processes. They will come and extend, and that's just how the barrier is formed. So nothing can pass through this one. We now have some areas that boycott this barrier. They do not have them. We are like, which name do we call them? You say they are circumventing. Permit me to use that word. I hope that I'm still talking science anyway. They circumvent the formation of blood-brain barrier. Okay. That's just for some. I just want to guide you. It doesn't mean that that's where the name is coming from. So permit me to just do it the way that, just to pass the information across to you. They circumvent it. They don't have the blood-brain barrier in them. And those regions, they call them circumventricular organs. They are actually around the ventricles. But you can also look at them that they are circumventing the formation of the blood-brain barrier. That's just what you want to note here. That what are those structures that lack the proper development of the blood-brain barrier? I call them SOAP. Do you get it? SOAP, S-O-A-P. You just need to rehearse it, say it 1 or 2 or 3 times. SOAP. These ones, they don't have the blood-brain barrier. S here is what you call the subphonical organ. The O is this OVLT. OVLT is this organum fasculosum lamina terminalis. If the name will remove your front teeth, just call it OVLT and move on. What about the A? Area postrema. And I think that's the AAP, definitely. And or the DP may be related to the pituitary, but I think that's just what I did there, just to put them together. So you have this area postrema, which is the A. You have the OVLT. You also have the what else? Subphonical organ and the like. So I put them here. Some of them are sensory, some of them are secretory. The one that is secretory is the medial eminence of hypothalamus. But if you can remember this SOAP or any of them that you can remember, that's very okay. Never forget these two: area postrema and OVLT. Never forget two of them. So what is their significance? How come they do not have this blood-brain barrier? Do you get it?
So, sorry, Dr. Besti, what is S?
Subphonical organ is here.
Subphonical
organ. So O
Okay.
is OVLT. So how come this area do not have it? And what's the significance of them not having it? The significance of them not having it is that anytime, most of the time, for example, the area postrema, it can sense if at all there is any abnormal or one strange substance entering into the body. Once it gets to the brain, it can stimulate that area postrema, and the patient just starts vomiting. The patient will just start vomiting. It may be after chemotherapy, it may be after anything. The patient will just start vomiting. So you want to note that. That's just one of the significance. They do not have blood-brain barrier that can prevent substances to. God is wonderful. It's just that we need an area that will be sensing that abnormal things are entering into the body so that the body can easily eliminate them. And that's all. That's just an idea I want you to have. Area postrema, they will just link it to vomiting. They can also link it to anything, just something related to vomiting, area postrema. Then OVLT, they can link it to osmolar receptors. Do you get it? Okay, we have these two. Osmolar receptor, they just sense the osmolality in the blood. And if I told the patient needs to drink water, they will be the one to tell the patient, start drinking water. If the patient does not need to drink water, the patient will not. So something just need to sense all these stuff. Then the area postrema is related to vomiting. Just note these two areas very well. They will just paint a scenario, link it to vomiting. You will start thinking towards the area postrema. They lack the blood-brain barrier. Don't forget, they lack the blood-brain barrier. All right, let me read what I put here for you. Circumventricular organ, vascular brain structures around the ventricles. They do not have blood-brain barrier. Some are sensory, some are secretory. The one that are sensory, they are the subphonical organ, OVLT, area postrema. The one that is secretory is the pituitary. We can use posterior pituitary gland that is secreting oxytocin, ADH, and different kind of things. Then pineal gland, they all start with P. You can use that one if you wish for the P. So pituitary, posterior pituitary, pineal gland, secreting melatonin. Those area they do not have. Let us mute our mic, please, so that I can think straight. So those areas they do not have the what do you call it, blood-brain barrier. So just note that. That's all. Write your SOAP down. Talk about the subphonical, the OVLT, area postrema, the pituitary, the posterior pituitary, the pineal gland. You can just put them and just put what they produce at their front. It's just 1 or 2 minute exercise just to give yourself, so that when you see it in question, you'll be able to deal with them. Now, there is a way you can disrupt the blood-brain barrier. Now, how can you disrupt it? You can disrupt it through what do you call it? Or in a condition like stroke. You can also disrupt it when you give a patient hyperosmolar agent like mannitol. You can disrupt the blood-brain barrier in them. So the thing is that when you just give them this hyperosmolar stuff, you disrupt the blood-brain barrier, and the net result you just start seeing is the medication that shouldn't naturally be finding their way into the brain, they start finding their way into the brain and all manner of stuff and the likes. Now, let me give you an instance. We talk about a patient that just had head injury, and the patient comes, you've already ruled out all manner of maybe bleeding and the likes. So you just want to decompress. What they used to do before is to give them mannitol. So the mannitol will remove, just to remove most of those fluid within the brain parenchyma in the name of cerebral edema, bring them into the vessel. We also add furosemide to it to remove them from the vessel, bring them into the kidney, and kidney will eliminate them out of the body. So mannitol and furosemide. After you've given that, so in one way or the other, it will disrupt the blood-brain barrier. You now give the patient dexamethasone. So when you give the patient dexamethasone will be able to enter and penetrate into the nook and cranny of the CNS and now reduce all manner of inflammatory reaction, whether related to trauma or infection, and bring everything down. So the patient will now should feel better. But that's just one side to it. The mannitol can also have its own adverse effect in one way. What if the patient is bleeding and the vessel is just bleeding mannitol into a particular space, and that mannitol within that space that is accumulating blood starts drawing fluid to itself, and before you know, the condition start becoming worse. So that's why people are already moving away using the mannitol. In case maybe you are doing round and they don't talk about it again, or you mention it, you can give them that point why people don't really use it again. I think they've already struck it out in one way or the other. Okay, that's just about that. So that's what you want to rehearse very well about this blood-brain barrier. Let me just show you 1 or 2 questions. You can use that and see if I thought it will answer any question you may have. See this question. A 68-year-old man with a history of Parkinson's disease. Okay, he is hospitalized for pneumonia and sepsis. The patient is treated with intravenous fluid and antibiotic. Okay, this is a patient that is having Parkinson's disease and is having pneumonia and sepsis. He is also started on an infusion of IV dopamine in Parkinson's disease. So the thing about them is that they usually have this reduced level of dopamine. But this patient is having a pneumonia and sepsis, where the patient is having maybe hypotension, that they now need to give dopamine, intravenous dopamine. How come that intravenous dopamine they are giving is not treating the same, it's not treating the Parkinson's disease the patient has been having right from the beginning? Since it's dopamine that is low in this patient Parkinson's disease, as they are giving the patient intravenous dopamine, it should be going to the brain too now, and should be making the Parkinson to improve. Although the manifestation of Parkinson's disease are attributed to dopaminergic neurodegeneration in the substantia nigra, IV dopamine does not improve this patient Parkinson's symptoms. Which of the following cell structure account for this lack of responsiveness? You start thinking towards blood-brain barrier, the tight junction you have there, shaking up. So, see another question. A study was conducted to determine the utility of adjunctive therapy in bacterial meningitis. Patients with acute bacterial meningitis whose cerebrospinal fluid analysis is showing gram-positive diplococci were divided into 2 groups. And okay, the first group was given systemic antibiotic only. And the second group was given dexamethasone followed by systemic antibiotic. So compared to the control group, patients in this experimental group developed fewer neurologic sequelae and had a lower risk of death. That's the experimental one, the one that is using both dexamethasone and antibiotic. So they discovered that those one using antibiotic and dexamethasone, they do better. They don't really die. The experimental patient most likely benefited from the use of this drug due to which of the following. Now, what happened is that because we are talking about meningitis, they produce all manner of cytokine. Those cytokine, and in one way or the other, they have a way of affecting the blood-brain barrier and also preventing the proper effect, or the effect that you are supposed to see with respect to those the antibiotic you are giving. So what the dexamethasone will now do is that because of the meningitis already, so the blood-brain barrier is already disrupted. The dexamethasone will go there, lower all those inflammatory, first of all, even lower them. So all those inflammatory cytokines that are there, is will bring them down. Then the antibiotic will now attack the organism, compared to you giving the patient antibiotic alone. So the effect will not really be as magnified as you are going to see in a drug that will enter into the CNS. Cytokines, they've already disrupted the blood-brain barrier. They've already disrupted it in one way or the other. So the dexamethasone will enter, bring down the inflammatory reaction. Antibiotic you are giving will now take its time and work very well. Whereas antibiotic alone might not really be able to work that much. That's why we'll be tackling the organism. Then the effects might take longer than expected, because the cytokines will still be there, even though the production will be reducing. But with dexamethasone, it's going to bring down the cytokine immediately, and that's all. So that's just a way by which they can test the blood-brain barrier with you, most especially with respect to the steroid, antibiotic, and all manner of stuff and cytokine. Okay, that's that.
Professor, I have a question to this too. What is your explanation is right, but I'm thinking with all those cytokines disrupting the blood-brain barrier, don't you think that with that disruption, it causes an increase permeability to maybe antibiotics and any other any other substances to the brain with the disruption of the BBB by the inflammatory cells and cytokines?
In fact, what is going on there is this: you have disruption of what do you call blood-brain barrier. You also have the inflammatory reactions going on, and the organism also producing the inflammatory reaction that is going on in the brain. Now, let me use this opportunity before I talk more about that. They can talk about a patient that is having meningitis, and this patient now take a particular drug. You are likely to have increase in that particular drug, of that particular drug in the brain, because those cytokines that are produced in a patient having meningitis, they disrupt the blood-brain barrier. So any drug you give systemically can easily find their way into the brain, and the patient may have more adverse effect than what the patient is actually supposed to have. But in this one, the question is actually pegged on the significance of the dexamethasone with respect to the antibiotic. With significance of this dexamethasone together with the antibiotic. So the dexamethasone will lower the inflammatory reaction. Antibiotic is just coming and just dealing with those organisms. Do you get it? So the effect is going to be more magnified compared to you just giving antibiotic alone, which is actually what some people do. Those cytokines, they can disrupt all manner of stuff in the brain. Those cytokines, they are actually very bad. They can push the patient to developing all manner of conditions like SIADH, syndrome of inappropriate ADH secretion, and the patient will just start becoming, the condition will start becoming worse and the likes. The dexamethasone is going to bring down all those cytokines, then the antibiotic will go, because antibiotic does not target the cytokine. So the antibiotic you are giving will now go and target the organism. All right. So that is what actually explains the reason why you are giving two of them together. Maybe by the time you are solving more questions, you can add more to it. Okay, so that's that about the blood-brain barrier. Think about it like that. This is formatting center. The way you will be looking at formatting center, you don't want to forget, I already mentioned one area about it, area postrema. This vomiting center is coordinated by what you call nucleus tractus solitarius. Tractus solitarius. Rehearse it, write it down, say it out. Nucleus tractus, we call it NTS. Where is it located in the medulla? Now, this nucleus tractus solitarius receive input from all manner of areas. What are they? You don't need someone to tell you. You can easily predict them. If you eat a poison, how come you vomit? How come someone eat a poison in the food, having food poison? How come the person is vomiting? Because there is an input from GIT to the nucleus tractus solitarius. So GIT is there. If a patient is having like maybe head injury and the like, how come the patient can also start vomiting? There is an input from CNS. The same thing for the vestibular system. When some people have maybe ear infection and all manner of stuff, or something is happening to their inner ear and different kind of thing, they may just start having all manner of vomiting. So that is vestibular. You can also link it to that vestibular system. Then chemoreceptor trigger zone. You call it CTZ, chemoreceptor trigger zone. So where you see in the area postrema can also give an input into that nucleus tractus solitarius. So that's actually where the inputs are coming from. You can think about the hair, you can think about the GI, you can think about the brain, you can think about the area postrema, chemoreceptor, which is related to the chemotherapy. So now those are the places that send input to the nucleus tractus solitarius. You just want to remind yourself nucleus tractus solitarius, nucleus tractus solitarius, nucleus tractus solitarius in the medulla. Now, we now have all manner of receptors that are related to this vomiting. And that is actually where majority of your questions will come from. You call them HMNSD. So I call them HMNSD. So it may make sense to you, it might not make sense to you. But all you need to do is to react there, and you can't escape this. You need to practice on them. HMNSD. Okay, what is it? These are the receptor. H is histamine 1, muscarinic 1, neurokinin 1. Then SD is just talking about the serotonin and dopamine receptor. Now, what they will do is to portray a clinical condition and tell you that which receptor will receive the information. They can give you the motion sickness and now link it to, so motion sickness. So this one is going to be something like H1, M1. At least you are seeing hem there. Never forget your M1, motion sickness. And when we were doing pharmacology, I told you a drug you use to treat the motion sickness. Who remember?
Scopolamine.
Scopolamine. Okay, scopolamine. So that's when we target the M1. Do you get it? So you can now see other histamine 1 receptor blocker and different kind of thing that will just block the receptor so that the patient will not be having the motion sickness and the likes. So that is that about this H1 and M1 for motion sickness. What about the hyperemesis gravidarum? You don't need someone to preach to you the receptor that mediates the hyperemesis gravidarum. Hyperemesis starts with H, then you'll be talking about H1. Shikena. So these are straightforward unless you just want to be attaching stuff to them. Pick your pen, pick your paper, write HMNSD. You can call it anything you like. H, as you write the H there, just write hyperemesis gravidarum. M, you can write the motion sickness there. Then NSD that are left, put chemotherapy on them. Shikena. It's very easy, no headache, no too much stuff here. You just write it like this. You just write something like this. This is what I'm saying. H M N S D. So these are actually one. All of them are 1, 1. This one, except this SD. So you just come and just be like H, hyperemesis gravidarum. That's the receptor for H1. M, motion sickness. That's where you use it. You block it in motion sickness. NSD, that is for chemotherapy induced vomiting, Shikena. So if they give you a question that this patient is having motion sickness, which receptor are you likely to block? The answer will be the muscarinic. Do you get it? So if the question is related to something like hyperemesis gravidarum, which receptor do you think is mediating it? You talk about H1 receptor. That's all. So we are done. Do you get vomiting center, everyone? Hey.
Yes. Thank you.
Okay. Are you sure you are getting it, or you are just sleeping and saying that let us shall tell him yes so he can move on? Dr. Sylvester.
We get it.
I'm here. Oh, I'm here.
Okay, okay, that's good. All right. Okay, let me show you one or two questions here. Okay, let me just show you. So later I will be differentiating this NKSD. Okay, let me just quickly tell you something about it. You know, this NSD, NK, neurokinin 1, and SD, they are related for chemotherapy. Now, this receptor mediates the immediate vomiting after chemotherapy. You are giving this patient chemotherapy and the patient is vomiting right in your front. S and D. Serotonin receptor, dopamine receptor, shikena. They are the one mediating that. But this patient get home, like 1 week after the chemotherapy, the patient now start having this intractable vomiting. Then you start thinking towards neurokinin receptor mediating it. So these last two, they are for immediate. This one is for delayed. Just for you to have an idea about how you play around them. So let me show you one or two questions just for you to see. And I have a lot of questions here. 2 weeks after starting chemotherapy, someone wanted to say
Yeah, sorry, Dr. Festus. You said the NK is for the immediate, isn't it?
NK is for delayed, S and D is for immediate.
Thank you.
Okay, you're welcome. Okay, so you can imagine it, you can just peg it on a patient, a hypothetical patient or imagined patient. Be like, I gave this patient this chemotherapy, just start vomiting. Which drug do I want to block? Which receptor do I want to block? I want to give something that will block serotonin and dopamine. Do you get it? Okay, few days after the patient is vomiting, I want to block the neurokinin. All right, this is 2 weeks after starting chemotherapy with a topocyte. A 66-year-old man with small cell lung cancer comes to the physician because of persistent nausea and vomiting. His symptoms improve significantly after the administration of metoclopramide. Now say that, okay, which is actually related to dopamine. The patient's symptoms were most likely due to effect of chemotherapy on which of the following structure. All what they are testing here is just related to which area of the brain receive information from, like chemotherapy that chemotherapy can affect, and that's area postrema, and that's all. That's all what they are testing here. So just for you to have an idea. Okay, see this one. A 63-year-old man with inoperable esophageal carcinoma undergo palliative chemotherapy. He now tell you that 4 hours after his first infusion of carboplatin and paclitaxel, he developed nausea and 3 episodes of vomiting and dry heaving. They now tell you that this adverse effect is caused by stimulation of brain region on the floor of the fourth ventricle, which is area postrema. Chemotherapeutic drugs are able to stimulate this region because of absence of a cell junction that is composed of which of the following? Tight junction. What forms the tight junction? Claudine and occludin. Tight, occlude it, tightly. Tight junction is, the junction is occluded. So you see something like occludin and claudine there. So you can use that if you wish. So it's just tight junction. It's just telling you all those areas that lack the blood-brain barrier. Shikena. So see this 62-year-old woman is evaluated for refractory nausea and vomiting. She was recently diagnosed with ovarian cancer and underwent total hysterectomy with bilateral salpingo-oophorectomy and perfect lymph node dissection. The patient was started on highly emetogenic adjuvant chemotherapy. Despite taking ondansetron, which is related to serotonin, the clock, she continued to have nausea and vomiting after blocking the serotonin receptor. So this patient still continue to have vomiting. So which receptor are you less free to block? Now she has no abdominal pain or constipation. Vital signs are normal. Examination shows a well-healed abdominal scar. There is no tenderness or abnormal masses. Bowel sound are normal. Additional therapy blocking which of the following receptor will most likely be helpful in this case. That's when you now start thinking towards neurokinin, NK receptor. So serotonin, these are the ones you first of all give immediate, or for immediate vomiting. But when you are now talking about later or these drugs that fail, you can now start thinking towards your neurokinin receptor blocker. Okay, so a 52-year-old woman comes to the office due to 2 weeks of constant back pain. She also had several months of non-productive cough, anorexia, and unintentional weight loss. The patient has a 40-pack year smoking history. Physical examination shows diffuse muscle wasting, left lung crackles and vertebral tenderness. Imaging reveal a left lung mass and lytic lesion in the vertebrae. Further evaluation confirmed metastasis non-small cell lung cancer. Treatment with cisplatin-based chemotherapy is begun, and the patient is also started on neurokinin-1 receptor antagonist. The later medication is most likely to improve which of the following in this patient. You start thinking towards chemotherapy-induced nausea, shaking. So NSD, just for you to rehearse around them, so that when you see them in question, you are not, you don't know too much about them. They just have an idea and be like, okay, something chemotherapy induced vomiting, I start thinking towards something like NSD. If it's actually for immediate, I start thinking towards something like S&D. Later one, I start thinking towards neurokinin. Shikena. So if anyhow they put them, you just quickly put your reasoning around those points, and you will get your answer. You just know that this is what the answer is likely to be, and you will likely get the question right. And that's all. Then we come down to sleep physiology for those that are sleeping there. So this is the physiology of the sleep you have been having. Sleep and sleep well. So when you now understand the sleep physiology, you will know the stage you have been when we were talking, so that you'll be able to know whether the stuff is staying or it's not even going to stay at all. All right, this is sleep physiology. You don't need to know much about the sleep, and we are going to look at it in a layman way. Let us look at it in such a way that you can easily reason it out and be like, this is what I feel this patient is going to have, because that is what will eventually matter inside the examination hall. Okay, sleep physiology, sleep cycle is regulated by circadian rhythm. Everyone knows that. You sleep at night, except for someone like Dr. Kenneth that sleep during the day and wake up at night. Majority of people, I think that is how you guys sleep now. You just sleep, you sleep during the day and wake up through the night. That's good anyway. So, but it's just a circadian rhythm. All of us know that you sleep at night, you wake up during the day. And why is that also? I will tell us very soon. Because his circadian rhythm is controlled by the nocturnal release of this ACTH, prolactin, melatonin, norepinephrine. You don't want to forget this guy called norepinephrine and melatonin. So we have what we call the suprachiasmatic nucleus of the hypothalamus. So that is what drives the sleep physiology. That's what drives the circadian rhythm that you observe with respect to sleep. Never forget the suprachiasmatic nucleus. That is it. It's going to release the norepinephrine. The norepinephrine will now go to the pineal gland and stimulate the pineal gland. Pineal gland will now release what you call the melatonin. So the high level of melatonin is now what will make us to start falling asleep. So what can make this suprachiasmatic nucleus to start releasing the norepinephrine? One of them is actually the darkness. When you put yourself in dark, the suprachiasmatic nucleus will be stimulated, and that will start releasing the norepinephrine. The pineal gland will be stimulated, and melatonin level will start rising. So when you switch off the light, so some people will not be able to sleep as such, because the stimulation of suprachiasmatic nucleus is actually going to reduce. There are two stages of sleep you want to remember for the purpose of USMLE exam. One of them is non-REM, the other one is REM. Non-REM means rapid eye movement. You think it's a big time. It's not a big time. It just shows that the eyes is rapidly moving. When you open the eyelid and you observe the eye, you'll be seeing it just jumping to and fro, to and fro. That is the rapid eye movement you see. And that is actually what they use to divide the sleep into REM and non-REM. So if you are sleeping and I open your eyes, I see the eye moving fast. I say this is REM sleep. You are in your REM sleep. If I check and I discover that the eye is not moving, I say this is non-REM sleep, no rapid eye movement in your sleep. That one just give me one or two information. We are going to see it now. Now, these are the stages of sleep. But before we sleep, some things first of all occur. At least I'm talking now, you are listening. Okay, before I say that, what do they want you to master with respect to this sleep here? They actually want you to master the EEG waveform. In which one do you see beta wave? In which one do you see alpha? And these are not things you want to cram. Okay, let me first of all give you one thing about the waves. Let us call the wave, if we see a wave that is associated with increased mental activity, let us say this is a beta wave. So I ask you there, are you with me? You say you are with me. I say beta. That's good. You show you are awake. That's beta. Beta, you are awake. So this beta wave, they have this high frequency, low amplitude they don't really care about you characterizing them. Better is better. They just ask you a question and just, okay, which wave do you see? Just say better. That's fine. But you are tired. I can imagine me sitting down in the sitting room, my wife just trying to talk to me, and I'm tired. Maybe after the class, just trying to just give me one or two G's. I'm just looking. So let me assume that my name is Afa. That's what I used to explain it. So Afa. So just be like, so I'm tired. My eyes is closing small, small. Be like, are you listening to me, Alpha? Are you listening to me? Just say Alpha, like you are tapping someone, like you tap Alpha, you tap, and you're like, okay, are you with me? Be like, okay, I'm with you. Now, all those ones, the patient has not really started sleeping. The patient is about to sleep. That is what happens. So beta wave, alpha wave, they are not related to sleep. They are patients that has not started sleeping. The patient starts sleeping. So the wave you are going to see with respect to sleep, you won't be seeing something like alpha. And if I thought you are going to see beta, you are going to see in which condition do you see it. So the first stage of sleep the patient will get to is what we call the non-REM. The eyes will just, I just close my eyes now, the sleep is taking me away. And you just open my eye, you start seeing that my eyes, they are just moving. Something is wrong. Suddenly, what's going on with my eye? Some people will sleep and their eyes will be open. So you now imagine seeing the eye moving to and fro. So that's abnormal. So the first stage you will see is actually something like this non-REM sleep. So this non-REM sleep, you have the stage N1, N2, N3. N is just talking about non-REM. It's not a big word, non-REM. So N1 is the stage 1, N2 is the stage 2, N3 is stage 3. So what do you see in the question that will tell you that this patient is in non-REM 1, stage N1? What will you see? It's a light sleep, and the patient can have what you call sudden myoclonic jerk. Then you see it in something like obstructive sleep apnea. That's where you see it. So myoclonic jerk can give it out. If you write this myoclonic jerk, you will see this NI. You can look at that NI as N1 there. So the wave you are going to see there is theta. So that's what you are going to see there, theta. So note that theta wave. So you can look at it and be like, someone is sleeping, go and tilt your dad, go and tilt, go and do this, go and do that. So you are not shouting, you are not calling the name. You need to go and tap. You need to go and tilt the patient. So that's for the light sleep. If the patient is lightly asleep, the patient should wake up. So that is for the N1. What about the N2, deeper one, deeper sleep? So this one, you see something like that's what characterizes it is tooth grinding. Tooth grinding. So when you read the question, you just see something like tooth grinding. You just say that this patient is in N2. You say the patient is sleeping and it's grinding the thing. And just say that, okay, which stage of sleep do you think this patient is? Just say, okay, this is likely the N2. If they do not put the tooth grinding bruisism in the question, you are also going to see two things in the question. Two about the stage N2. What are those two things? Sleep spindle and the K complex. Okay. Now, what is it about the sleep spindle? This is sleep spindle. This is a wave. You just see something like this. That's the sleep spindle. Then it goes again, and you see the K complex. The thing will just come like this. So this is the K complex. So these are the two things you will see that characterize the N2. Either tooth grinding or sleep spindle and K complex. So no one cares about you, what's the significance of the sleep spindle or K complex. Don't bother yourself. So I just used to explain it before, but you don't need it. Just note those two things. In case they put them in question, you just know that, okay, this is actually about the stage. And two things, the sleep spindle, K complex, then tooth grinding. It should rhyme. So there shouldn't be any headache. And I will ask you a question when I'm done. Okay. That's the waveform, the EEG pattern you are going to see there. It's characterized that. What about the N3? Now, N3 is the deepest. No wonder they actually call the waveform you see there the delta. The patient is dealt with here. The patient is deeply asleep. So it's also non-REM. So in this sleep, the patient can sleepwalk, can sleep talk, can bedwet, can experience all manner of stuff in this N3. Do you get it? Because the patient is deeply asleep. The patient is deeply asleep. The patient is deeply asleep. All right. The patient is deeply asleep. N3. So if they ask you, what is the deepest, where is the deepest sleep stage that you know? The answer is N3. Some people don't get to N3 when they sleep. Occasionally, when you get to N3, your partner will tell you that, what were you now saying in your sleep? You say, I talk, me talk, me talk. That you even rose up and you were like, you want to go and write USMLE that night. Yesterday night. We are like, come on, you are still preparing. Doctor, okay. Come on, you are still preparing. How come suddenly you say you want to go and write USMLE? No, you can't do that. So that is deepest sleep, N3. So look at them again. When the patient is awake, you say, oh, better. They have better wave. When the patient is getting tired, you call them, Alpha, wake up, oh. So Alpha, you can look at it that way if you wish. When the patient is lightly asleep, if you call them, they will not answer, but you need to tap them. Theta, teeth in, tap them, theta. So when you now talk about the N2, you start talking about deeper sleep. Yeah, in that one, you talk about two things, either tooth grinding or sleep spindle and K complex. Then the N3, deepest one. So they sleepwalk, they sleep talk, they do them. Then they see there is a particular condition they also have there. We call it night terror. All right. USMLE will not spare your life if you don't understand the difference between the night terror and the nightmare. So before I'm going to talk about it, I will first of all talk about the REM sleep. Now let us look at the REM sleep. Now this patient has left the non-REM. It has now entered into the REM sleep. One thing characterizes the REM sleep, and that thing is, God is wonderful, is increase in the brain activity. So the brain activity can be high while you are sleeping. You say yes. Increase in the brain activity. It is in that place you start seeing things. Your brain, if you are going to write USMLE, you may start seeing questions because the activity of your brain is going to start bringing all these things here, and you start seeing things and different kind of things. Just be like, this is wonderful. And be like, yeah, I slept yesterday and I saw them asking me questions about this. How come your brain can remember stuff, USMLE related stuff, while you are sleeping? Because though you are sleeping, your brain was awake. We now look for a name to call that. We are like, let us call it paradoxical sleep. What's the meaning of paradoxical? That even though the patient is sleeping, the brain is awake. Now, look at the brain awake in all the totality of the brain awake. The oxygen consumption is going to be very high. Yes. When you check for the neurotransmitter that you can use to correlate the activity of the brain at that moment, it's also going to be high. Acetylcholine level will be high. Then, when you check for the wave that you are going to be seeing there, the wave will also be telling you that this patient is awake, beta wave. That's all what you are going to be seeing there. So everything about the patient will be telling you that this patient is awake, even though the eyes are closed and the eyes ball are moving. God now look at it, and God is like, the way this patient is awake, if we allow him to continue thinking like this, probably maybe while maybe this patient is an electrician, now thinking that is climbing climbing pole and adjusting wire, because that's what he does on daily basis. If we allow this patient to continue like this because the brain is awake, this patient may just move the body and be moving like he's moving in real life and start holding life wire too that is beside him on the bed. This patient will kill himself. Okay, we are going to add something to the REM sleep so that even though the brain is awake, the body will be paralyzed. And that is why you see something in them, loss of motor tone. That tone must not be there, because if it's there, the patient will die. The brain is awake. You imagine someone that is jumping into the swimming, now thinking that it's maybe in one Olympic and swimming. And before you know, this patient may jump and just jump thinking that it's jumping into the swimming pool and hit the head on the wall and die. So there must be loss of muscle tone. Even though the brain is awake, the patient feel like moving. The brain is telling the patient, ah, lift your hand, lift your leg, lift this, lift that. The patient will not be able to do that. And because the brain is actively awake, when they dream, they will remember it. Oh, really? They remember because the brain is awake, very, very awake. They are connecting all those information. So when they dream, they will remember. Okay, it is only that time too. You see penile clitoral tumescence. They will stand up. Other muscles are down, they will rise. So they may serve as, someone wants to ask a question. Revelations in dream. Yeah, you see all manner of revelations there. Most of the time, most of those revelations may come from things that probably you have been thinking about subconsciously. The brain will just bring them up because the activity of the brain is high at that moment. Okay, so extraocular movement that you see is because of this paramedian pointer reticular formation activity. It's also high paramedian pointer reticular formation activity. So you just see the eye just swinging to and fro. That is why they call it REM sleep. Okay, so that is all about the REM sleep that you want to note for the USMLE. So when you read the question, you don't need to start saying that, okay, I need to now sit down and cram this. You can easily say them out, think about them, integrate them into the real life activity, and don't make a big deal of science out of them. It will not make you to remember anything. So now let me differentiate night terror and nightmare for you. All what you look for in the question is that, do you remember? That's only time you look for. Do you remember? If you remember, let us call that remember REM. If the patient remember, you say this is REM, nightmare. M in the mare is talking about the fact that, okay, this is REM. You can look at it that way if you wish. Okay, that is nightmare. It has letter M in it, like REM. REM come out, REM. What of the non-REM, N? We can look at that one as N. That is night terror. So the night terror, they will just describe, because you might be finding it difficult to just know, is this a terror or this or that? What we give it out is that the patient will just scream and they ask, what happened? What happened? They can't remember. They just start sweating. They say, this is night terror. Which stage of sleep do you think the patient had that? It's the N3. Because the patient cannot remember. No remembrance. Non-REM. Night terror. Do you get it? You can see letter M there. REM is not there. Non-REM. You can look at it as letter N. N. Night terror. Then nightmare. M is there. You can look at this as REM. Okay. So that's how you are going to be differentiating them. They love to paint scenario about, there are some terms they want you to get used to. So when I'm done with these terms, I will, you can go for your break. And what are these terms? I hope you are getting me. Hey.
Yes.
Okay, Dr. Paulette is getting me. Dr. Chidima, are you sleeping? Are you in REM or non-REM?
I'm here. I'm getting you. I'm writing.
All right. So let's just be noting the important points so that this will help us. So you don't need to read much. So there are two conditions they love to put in question for us, and it's about the elderly patient and the depression. What is about elderly patient? What are the age-related changes that usually occur? The total length of time those elderly, you can think it out, no big deal there. The total length of time those people sleep is it's reduced. You see, they wake up by 4 a.m. You are like, they start ringing the bell, let us pray, let's pray. You don't understand what's going on. So just their total length of time for sleep is very short. So they don't sleep that much. As we age, The total length of time for sleep reduces. Then there is what we call sleep latency. Sleep latency is just talking about this region between N3 and REM. You can make reference to it like that. So sleep latency. So this total number of time they can spend around this region before they enter into the REM sleep is actually quite more. So they can spend more time. There is increase in nighttime sleep latency. They will just be at the entrance. They are not entering into the REM sleep. So they are not entering. So they sleep. They just sleep very well. They sleep like babies. And it's common to all those elderly people in one way or the other. Okay, so that's what you have there. So you see something like reduce entry. They don't spend much time. They're just going to be at the entrance to enter into the REM, but they are not entering. So reduce, then increase sleep latency. So just at the entrance before they enter into the REM. So because they are not entering into the REM easily, the total time they spend in REM will reduce. So you have reduced REM. They also have reduced entry. Even though they don't spend much time in N3, I wanted to say, even though they don't spend more time in N3, they spend more time, like they may just have something like, did I say deep sleep before? They don't have deep sleep, or light sleep, deeper sleep. That is where most of their sleep, all those elderly people, this is where majority of their sleep are. Just light sleep. That's how they used to have their sleep. So they have reduced REM. They can't enter into the REM easily. They have reduced N3. They can't come into the deepest sleep easily. Then they spend more time at the entrance to enter into the REM. Then early awakening. So they wake up as early as possible. That's one thing about the elderly. So you can easily close your eyes and just think about it. My grandma at home is asleep usually that deep. You say no. Then N3 is low in them. Today, usually, what are they going to be thinking about? Tell me, what are they going to be thinking about? And be like, I'm thinking about this. Okay, so they don't really go into the REM sleep as such. So they spend most of their time in something like N1, N2. Sometimes you may even study them, you see that they can have bruises in. All those elderly people, they'll be grinding their teeth as they are sleeping. You get? So it's something that is quite common. So you can easily reason it out. Now, the last one I want to talk about is Mr. Depression. What happens with depression? Now, people that are depressed, even though they do not really talk that much, their brain is super active. Whatsoever that push them into depression, they always want to continue to think about it. I hope you are getting my point. They always want to continue to think about it. So because they want to continue to think about it, you should think about it. Which stage do you think they will go and hide? They will go and hide in that stage of sleep where they can think, where they will continue to think about their problem. And that is how they continue to submerge themselves. They are not getting cured. Even though you are seeing the patient sleeping, the patient is just running to the REM sleep to go and stay there, and the brain will continue to analyze their life situation. Okay, look at it. What it means is that this patient with depression, they spend more time in the REM sleep, because it is only in the REM sleep the brain is very active. They will just be thinking in that REM sleep. How easy is it for them to enter into the REM sleep? They say God even made it very easy. The REM latency is very low. They don't spend more time at the entrance before they enter into the REM. Once they sleep, their brain will quickly take them into the REM, and they will just stay there. Their brain is active. They are overthinking about so many things. When you check their brain wave, you are seeing beta wave. Acetylcholine, very high. Everything very high. They spend less time in N3. So their sleep is never deep. Never deep. And this one will continue to worsen the situation for them. They even have early morning awakening, because repeated nighttime awakening, you can see them just wake up in the midnight. They look again, look at the nurse, look at the doctor, look at the other patient. Then they close their eyes back. They go back to REM to go and continue thinking. Then they wake up again. Many times they just wake up like that. Early morning, awakening, terminal insomnia. When they eventually wake up, sometimes they can't even sleep again. So that's what you have. So these are the two conditions. You just want to think about them. And when you see question on them, you are not carried away by there is increased REM latency, there is reduced REM latency. You already know, you've already integrated them into the routine, what happens in our environment, that, okay, someone with depression, they always want to go and hide in a place where their brain can think. Which part of the sleep is that? You say the REM. Then it must be very easy for them to enter into the REM. So they spend more time in REM, increase REM sleep time. It will be very easy for them to enter into REM, reduce REM latency. So then they don't have deep sleep. N3 will reduce. Then repeated night time awakening, shaking up. All right. The last thing I'm going to talk about is what we call Mr. Narcolepsy. I know you've heard about narcolepsy before. So, but what I want you to do here is just to get the gist around the narcolepsy so that you will not forget it. Narcolepsy. Just a gist around it. There is nothing, no stuff here. And in that gist, you will see the questions they are going to ask you. How do you make a diagnosis of this Mr. Narcolepsy? That's the first thing you need to note. They just have these recurrent lapses into sleep or naps. Just lapse into sleep easily. Then you can have one or more of the following, which is actually what you look for in the question, and that is cataplexy. What is cataplexy? Brief loss of muscle tone preceded by strong emotion. They will just tell you that may just be what you see in question, that will just tell you that this is narcolepsy. They might tell you that maybe someone is, I'm going to show you some questions, someone is holding something, then maybe someone crack a joke and the person laughed. Immediately the person laughed, like they just burst into laughter, or whatsoever the patient is holding just drop. Do you get it? That is cataplexy, loss of muscle tone. The patient may even fall down. So like laughter, excitement or something, that cataplexy. Then when you check their hypocretin 1 or a C in their CSF is usually very low. Say this out. Make a song out of it. Low ORC, low hypocretin 1. This is that. In the CSF, you will never forget narcolepsy. When they give you a question, these are the things you see them testing most of the time. Something related to this hypocretin 1, something related to cataplexy. They will just put it in question. Check for it. Once you see it, just pick narcolepsy easily. No stuff. There is no stuff here. Where is orexin produced? It's produced from the lateral nucleus of the lateral neuron of the hypothalamus. Don't bother yourself much. What are the associations you see? Hypnagogic, hypnapompic. Hypnagogic, hallucination. Hypnopompic, hallucination. So hypnagogic, while they are going to sleep, they hallucinate. That is hypnagogic, while going to sleep. Hypnapompic, while pumping out of the sleep, while waking up from sleep, while being pumped out of sleep. That is hypnopompic. In case I'll be saying hypnapompic, just forgive me. Hypnopompic, hallucination. Then the sleep paralysis. So that's just the hallucination. You may see the question that we talk about in narcolepsy. Then orexin level is very low, or hypocretin 1. Just these 3 points or 4 points. That's all you need. Just be checking the question. They put them in question. Just say narcolepsy, 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 narcolepsy. Easy. No issue. How do you treat it? And they are like, okay, there are 2 ways of treating this thing. Okay, how are we going to do so? We can give an agent that will promote wakefulness. Let this patient just be awake. Which agent is that? Psychostimulant. Let the brain just be stimulated. Okay, we can also give this sodium oxybate at night. So with respect to the psychostimulant, there are 2. Do you want the amphetamine base or the non-amphetamine base? They say non-amphetamine base. So what is it about this non-amphetamine base? So a sample of the drug you see there is modafinil. Modafinil, that is non-amphetamine stimulant. They want you to note the fact that modafinil is actually non-amphetamine. So it's the first line agent because it's very effective, well tolerated, and its misuse is very rare. So the mechanism of action is not well described, but modafinil may enhance dopaminergic signaling. What about the amphetamine? If at all you see it in question, it is the second line drug. So amphetamine, second line agent due to their sympathomimetic side effect because they are going to increase the release of norepinephrine and the likes. So before you know, and dopamine, all those stuff, before you know, the patient may start having hypertension. So someone that is already having hypertension, don't even go and try giving the patient something like amphetamine. So you just want to give them something like non-amphetamine. Then sodium oxybate, that's another last one. The one they are going to ask you is just modafinil. Don't bother yourself. Modafinil is the one they will ask you on the narcolepsy. Just which drug do you want to use to treat this patient? Modafinil. Which category of drug does it belong to? Non-amphetamine stimulant. So the patient, the risk of being dependent on it and misusing it is very rare because it's non-amphetamine. All right, so that's that about sleep. Let me just show you. I have a lot of questions on sleep, but I can't solve all with you. But just for you to have an idea of the way questions come in sleep. So see this. A 23-year-old, and majority of their question comes on narcolepsy. That's why you just want to pay attention to it. A 23-year-old man comes to the physician at his girlfriend's insistence. She said that the patient frequent snoring keeps her up at night and that in the last 4 months he has twice fallen asleep while they were talking. In this same period, the patient says that he has regularly fallen asleep in the afternoon while reading or watching TV, they typically feel refreshed after a brief nap. They just feel refreshed, they continue, they fall asleep again, they feel refreshed, they continue. So when asked whether he experienced any other symptom, the patient hesitantly revealed that he sometimes hears a voice call his name prior to falling asleep. You call that hypnagogic hallucination or a dream hallucination. So he also reports uncharacteristic episode of clumsiness in which he has suddenly dropped object or falling to his knee. That is cataplexy. They now say that which of the following is the most likely diagnosis? Narcolepsy. Shaking. No, don't drag it. You come down to this one. A 20-year-old college student comes to the office due to falling asleep at inappropriate time. He has an irresistible urge to sleep during the day, and these naps occur unpredictably. Sometimes at the start of class during examination, he sleeps 6 to 7 hours per night and feels refreshed when he awakes. When he awakens. He also experiences frightening or auditory hallucination before falling asleep. That is hypnagogic. So hallucination. He was recently in a motor vehicle collision after falling asleep at the wheel, which resulted in only a minor sprain of his wrist. He does not use tobacco, alcohol, illicit drug. Physical examination is unremarkable. Which of the following is the best treatment? This is narcolepsy until proven otherwise. The best treatment is modafinil. Shikena, pick your modafinil and go. Don't drag it. Revise that over and over again. This is another narcolepsy. So if measured, which of the following compound is most likely to be abnormal in this patient's cerebrospinal fluid? Hypocretin 1 or orexin. So that's what you choose. The same thing here. You see that the sleep state associated with this child. Okay, let us look at this. A 6-year-old boy is brought to the office due to frequent nighttime awakening. Why are you waking up at night? Several times a week over the past month, he has come to his parents' bed around 3 a.m., frequently crying, appearing frightened, and saying that he became lost in a crowd and couldn't find his parents. For this child to narrate this sleep, then the sleep is occurring in REM. I mean, the dream. To narrate the dream is occurring in REM. If the child cannot remember it, you'll be thinking about night terror. For this child to be able to recollect it, this is nightmare. Shikena. So now see, although he is comforted by their reassurance, he refuses to return to his room and eventually falls back asleep in their bed. The boy is about to start first grade at the new school. He is healthy and developmental milestones are normal. Now examination shows no abnormality. The sleep stage associated with this child's frightening experience is characterized by which of the following? Atonia, loss of muscle tone, because at that REM sleep, the brain activity is very high. If you are not very careful, this patient is going to be we do all manner of stuff. In which sleep stage do you see delta ECG? Where? N what? N3.
N3.
So where do you see sleep spindle and P
N3,
complex? N2.
N2.
N2,
This low amplitude theta ECG wave. Where do you see theta wave?
N1.
N1.
Wow.
Just something like this is just what you just look at them. Okay, that's that. Look at this question. Um, a 72-year-old man comes to the office due to poor sleep. He is concerned that he is sleeping less since he retired a year ago. He says, I used to sleep a solid 8 hours, but now I wake up several times. Earlier awakening, and I am up for the day between 5 a.m. and 6 a.m., which is a full hour before I want to get up. I am probably only getting about 6 or 7 hours of sleep total. I know as I'm talking now, some people will be like, you even get enough now. I don't even have up to 5. The patient typically falls asleep while watching TV at 10 p.m. He sometimes awakens to use the bedroom in the middle of the night, but typically falls back asleep within 15 minutes. The patient likes to do crossword and play golf in the morning, but occasionally takes 30-minute naps in the afternoon. The patient wife says that he snores softly, but she has not witnessed any breathing pause. Medical problems include hypertension and history of depression. Now, see, the patient does not use alcohol or illicit drug. Which of the following is the most likely cause of this patient's symptoms? This is an elderly patient that is having issue with sleep. The sleep hours has reduced. This is age-related sleep change, shaking. So don't be putting a lot of pathology in it and you start thinking about pathology. Just age-related. See this one. A 12-year-old girl is brought to the office by her mother due to unusual nighttime behavior. The mother reported that once or twice a month over the past year, she has found her daughter walking around. If this is related to sleep, this is likely to be what? Sleepwalking. So where do you see sleepwalking?
N3.
N3.
N3,
So which wave do you see in N3?
Delta wave.
Delta.
Just pick that and you go. So you can go back and solve as many questions as possible on sleep. You can see questions that are related to orexin A. You can see questions that are hypocretin and the likes. And that's all about the sleep. Go and re-ask some questions. There may be one or two questions that probably you don't even understand where the question is coming from. It's normal. Ignore it and just move on. You've tried. Let me give you 20 minutes break. We meet after the break. Thank you so much, everyone. Enjoy the break. Bye.
Thank you.
So when you go back, go and rehearse all what we talked about concerning sleep. This is hypothalamus. See, you just need to play around with words, with your pen, with your paper. That's for all you need here. There is no alternative way to look at it. So that's just hypothalamus for you. So these are the nuclei that you see them make reference to with respect to hypothalamus. You have the please give me 1 minute. So you just have all these nuclei that are there. So you must find a way to master all of them, rehearse them, practice them. There is no any other way about them. The first one is the lateral nucleus. What this one mediates is the hunger. Why are you hungry? Because you need to eat and grow. So you need to grow. That's why you need to eat. So you need to be hungry. So that shows that it will be stimulated by ghrelin. Ghrelin is like an hormone that will help you to grow. Do you get it? So you now eat. So then we have the ventral media. I don't call it ventral media. I just look at it and call it media. Media is the one that mediates satiety, your ability to say that I'm okay, I'm full, I don't want to eat. Okay, it shows that probably maybe you are actually okay. That's what it means. It just makes your body to be okay. I have a way of illustrating this. When you are hungry, you look laterally. You look around. You can be focused. We are doing tutorial now. Some people are looking sideways, laterally, all because they are hungry. So lateral nucleus mediate hunger. If you are okay, you are filled up, you will be focused, you will be glued. Your eyes will be glued to your screen. You will be looking medially to your screen because you know you are filled up. And that's how you look at it. So you now imagine that they tell you that the lateral nucleus is damaged, this patient will not be feeling hungry again. So the patient will not eat, and the patient will be appearing lean or thin. So you just start extrapolating them. If the ventromedial nucleus is damaged, then definitely the patient will not be feeling filled up again or full again. So the patient will just continue to eat. You have hyperphagia, and the patient will now be very massive and big. So this ventromedial nucleus is stimulated by leptin. You just want to know that. Where is leptin produced from? Leptin is produced by the adipose tissue, adipocyte. Adipose tissue. Now think about it. Leptin should stimulate the ventromedial nucleus and make the patient to feel okay. And you say this leptin is produced by the adipocyte. The thing is that people that are big, that have a lot of fat, that have higher BMI, they tend to produce a lot of leptin. So when they produce a lot of leptin, so their body weight, because you wonder why those people that are big, they actually eat more. They don't say they are okay. You just see them eating and eating. It's because the adipocytes in them produce a lot of leptin that the ventromedial nucleus has now become resistant to its effect. So it's now tolerating its effect. So the thing is no more causing any significant effect on the ventromedial nucleus again. So they won't be feeling satisfied. They continue to eat, and that's all. So never forget that. What about the anterior nucleus? I used to talk about something. If not for all these new generation cars, for the old ones, you ask, where do you usually have the AC of the car? The AC of the car, they are usually located at the front, and from the front is going to blow to the back. So anterior nucleus for cooling and for parasympathetic. Posterior nucleus, that is where you have the saliva and the likes. So they will be blowing it away. So, and that is for heating and sympathetic. So posterior nucleus for heating, sympathetic, anterior for cooling and parasympathetic. Then suprachiasmatic circadian rhythm. We just talked about sleep not quite long, so you shouldn't miss that up. Then we come to the supraoptic and paraventricular. All you need to remember is this sad box. Never forget it. Write it down, rehearse it, romance it very well till it becomes part of you. Sad box. What this means is that supraoptic will help in the production of the ADH, while the paraventricular nucleus will help in the production of oxytocin. It doesn't mean that supraoptic does not produce oxytocin or paraventricular does not produce ADH. It's just that supraoptic will produce more of ADH and paraventricular will produce more of oxytocin. Shekina. The last one is the preoptic nucleus. Preoptic helps in thermoregulation. All you want to remember is that thermoregulation and its relationship with the release of gonadotrophin releasing hormone. So they are more likely to link it to Kalman syndrome for you. You don't need to wonder how the question will come that you will know that, this is Kalman. There is one thing that you will see in question that will give out Kalman syndrome for you. They will give you reproductive features, and they will tell you that the patient has a nose smear. Just know that that is Kalman syndrome until proven otherwise. Shikena. So someone like me, I just want to remember a nose smear alone. On Kalman, it's related to reproduction and the likes. A nose smear. Just a nose smear. This patient is going to be you'll be seeing something like, okay, what do you call it? The FSH, LH, all those stuff, they are down and the likes, and they also link it to a nose smear. Just know you are dealing with Kalman syndrome, and that's all. So if I'm going to test you guys, I'm just going to mention the nucleus. You just tell me what it mediates. Lateral nucleus, what does it mediate?
Hunger.
The ventromedia.
Satiety.
Anterior nucleus.
Cooling.
Posterior nucleus.
Heating
and sympathetic.
Suprachiasmatic.
Secondary.
Preoptic.
Thermoregulation. And gonadotropin releasing hormone.
So which one is remaining that I've not mentioned?
All of them. Supraoptic, paraventricular.
ADH.
Supraoptic and paraventricular. So
Sad box.
sad box. So just remember that. Don't bother to give yourself headache. You can now start putting lesions on each of them, just for you to have an idea of how the patient will present. Now that's for the hypothalamus. Rehearse that very well. They will ask you either one of
Dr.
them.
Festus,
Yes.
sorry, please. I didn't get what you said about people who are obese and leptin not being able to inhibit their media nucleus.
Okay. The thing is that people that are obese, they have a lot of adipocytes, adipose tissue. So they produce a lot of leptin. Do you get it? Leptin is supposed to stimulate the ventromedia and make them to be like, okay, I'm satisfied. But when you stimulate it today, stimulate it tomorrow, stimulate it next tomorrow, after a while, the ventromedia nucleus will stop responding to leptin. So they become tolerant of it. Do you get it? So even if it's stimulating them, they are not responding. So they will just continue to eat. So you won't see the effect of leptin again. They will just stop.
Okay.
Yeah,
Thank you.
yeah, welcome. So that's here. Let's look at this thalamus. Now, the way I love to look at thalamus in a very simple diagram, and if you can draw it, it will make a lot of sense to you. So you just have a cycle like this. Doesn't mean that is how it is, but we are just looking for a way that you can remember things. Let me clean this. That. So you just have something like this. So this is the ventral. This is the dorsal. Okay, let us divide this ventral to. This is the ventral. Let us divide it into ventral anterior, ventral posterior. So the ventral anterior is this one. The ventral posterior is this behind. Two of them are ventral. This is dorsal. You can look at it that way, just this way. Let us take this ventral posterior and divide it into two. So this is the midline. So we call this ventral posterior media. This one will be called ventral posterior lateral. All right. Then we come to the anterior. We have what we call the ventral anterior and ventral lateral. Just something like this. Maybe this is, can just give you this kind of division. So this will be ventral anterior. Everything is about the ventral lateral. We now have like two other ones here. This one is medial geniculate nucleus, lateral geniculate nucleus, lateral geniculate nucleus, medial geniculate nucleus. So those are the nuclei that you see in the thalamus. If you can draw this diagram, you can just, this is not something like maybe a diagram I'm drawing somewhere. You can pick your pencil and draw your own. Just turn it to diagram, because that diagram will help you to remember them very well. This is the diagram I've been using to teach. Only God knows how many times I've taught this. And I will just devise it. I don't need to be correct. I just need to pass the information across to you. So when you are doing, you become a neurosurgeon, you can go and be learning the whole stuff. But that time you will have achieved some stuff. So they just want you to note what the ventral posterior, what they do. So this ventral posterior, what they do is for sensory. They just receive something like what do we call it? Sensation. It's actually for sensory stimuli. So something like that. So this the ventrolateral and ventral anterior, they are for motor. So this one is for sensory, like for vibration, the pain, the pressure, proprioception, light, touch, temperature. Everything is actually related to this ventral posterior. While the ventral lateral and anterior, they are related to motor. So that's that. Now, how are you going to differentiate ventral posterior lateral and ventral posterior media? Ventral posterior lateral is for this is the body. This is the body. Everything that is related to this body downward, that is ventral posterior lateral. Everything that is related to the face, that is ventral posterior media. So sensations that are related to the face will pass through ventral posterior media. Sensations that are related to the other part of the body will pass through ventral posterolateral. Now, that is for sensation. So, what about the motor? Motor is related to ventral lateral and ventral anterior. Then we now have the lateral geniculate, medial geniculate. All you just need to look is the lateral and the medial. The L in the lateral here is for light. You can use it just to look at light and just relate it to light, which is vision. So this one, you have something coming, stimulus, the stimuli coming from the eye will pass through this area. So lateral geniculate. Why for the medial geniculate is for music. This one deals with hearing. So this is just all you need to rehearse it over and over again, and you are okay. And that's all. So let me leave this diagram and just show you one or two questions in hypothalamus, just so that you have an idea of the way the question will come. Can you see that there are so many questions, but I can solve all of them with you. A 56-year-old male comes to the physician because of a 2-month history of excessive sleepiness. He reports that he has been sleeping for an average of 10 to 12 hours at night and needs to take multiple naps during the day. 6 months ago, he was diagnosed with small cell lung carcinoma and underwent prophylactic cranial irradiation. The patient's symptoms are most likely caused by damage to which of the following structure? So you just want to ask which structure is related to sleep. You start thinking of something like suprachiasmatic nucleus. So if the patient is having damage to suprachiasmatic nucleus, there will not be any regulation of sleep again. The circadian rhythm will be lost. The patient will just continue to sleep anyhow. That's all. Do you get it? So no too much story here. That's all. It's all about circadian rhythm. Look at this one. An investigator is studying the function of lateral nucleus of the hypothalamus. And I'll tell you that in an experimental animal using the viral vector, the gene encoding chloride conducting channel, rhodopsin, are injected. When you inject a chloride conducting channel or a gene encoding chloride conducting channel, so you are trying to put a chloride channel on that particular nucleus. So more chloride will enter into the nucleus. What do you think that will do to the nucleus, anyone?
Like
Relax.
Hyperpolarization. So just you are likely to have something like hyperpolarization because it's going to become more negative. And when it becomes more negative, they won't be able to do what they are supposed to do. It's like we are inducing inhibition of that nucleus. Now, say photostimulation of the channel causes complete inhibition of action potential generation. Persistent photostimulation is most likely to result in which of the following abnormality in this animal. So now this is someone that you've damaged. It's like you are stopping the lateral nucleus. Lateral nucleus should make this patient to be hungry to want to eat, right? So when the lateral nucleus is no more making them to be hungry to want to eat, they will be feeling satisfied. And that is what will lead to what you call anorexia in them. The patient will just become anorexic, will not eat again because the patient will be feeling satisfied. Lateral nucleus is not working, nothing to tell them to be hungry. So they become anorexic, they start losing weight, they start looking skinny, they start looking lean. And that's all. So they can relate it to any other nucleus. Just use the concept and you are okay. A 65-year-old woman with hypertension comes to the emergency department because of sudden onset of severe headache. 2 hours ago, her temperature is 34.7. This is, what kind of temperature is this?
hypothermia.
Hypothermia. So this patient is having hypothermia and the blood pressure is looking high. Physical examination shows a cold skin. A CT scan of the head shows a subarachnoid hemorrhage and she started on appropriate pharmacotherapy. Damage to which of the following region of the brain is most likely responsible? Which region of the brain should help with thermoregulation? Anyone?
Preoptic.
Preoptic. So this patient is having preoptic damage. Are you getting it? Are you getting it?
Yes. Yes.
So just something like that. You can see they are quite easy and straightforward. Look at this one. A 5-year-old boy has developed persistent food-seeking behavior. He was just seeking for food everywhere. Behavior over the past few months. His mother initially thought that the boy was undergoing a growth spurt, but despite how much she fed him, he never seemed satisfied. So that satiety is lost. Which part of the nucleus, hypothalamic nucleus, is damaged?
Media.
Media or media. Just pick that and that's all. So you can go and solve as many questions as you wish. Let me show you some questions under the thalamic nuclei. Can you see we are not sitting down and cramming anything? just illustrate it, pick the few things, you can easily reason them out. That's what USMLE is all about. So if you
Sorry,
see,
Dr. Festus.
yes,
Please, how can the anterior nucleus and the posterior nucleus be tested?
just the same way they were portraying the other. Anterior nucleus should actually help with the cooling. Do you get it? So you just realize that this patient is just having hyperthermia, no more cooling. Do you get it? Do you get my point?
Yeah.
Or
So
something related, or
if
something just related to, the loss of parasympathetic nervous system. That's actually more likely to be the way you need to test it. Do you get it?
because I was thinking for that last question where
That
we
it may look
chose
like this.
yes.
Yeah. So the reason why there may be some similarity, but I think that if you can get a question, you'll be able to throw them apart. Do you get it? You'll be able to,
Okay.
because there will be one or two other things they are likely to add to it. It won't give you a headache, trust me.
Okay.
It won't give you any headache when you see question on them. Okay, it's just that we are not seeing question on it, so we can't really predict how they will come. But since you already understand the concept, you should do well with it. Do you get it, Dr. Motara?
Yes, sir. Yes, sir. I do.
Okay,
Thank you.
so let's look at this one. A 58-year-old man is brought to the management department because of sudden onset right-sided body numbness for 1 hour. He reported that he has a 15-year history of hypertension treated with hydrochlorothiazide. He is alert and oriented to time, place, and person. Neurological examination shows decreased sensation to light, pinprick, and temperature on the right side of the face and the body. So sensation to the right side of the face is affected. The face sensation to the face is normally passed through which part of the thalamic nucleus?
Posterior.
Medium.
Ventral posterior.
Yeah.
Yeah, that's all. That's all
Yeah.
what you just want to. Oh, now let us look at it. They just say that motor strength is 5/5 and deep tendon reflexes are 2 plus bilateral. Perfusion of which of the following structure of the brain is most likely impaired here. So you are still going to be dealing with the ventral part of the thalamus, and that's all. Why ventral part of the thalamus? Because that's actually where you have both the if you remember the diagram, the ventral posterior and the ventral anterior. Do you get just ventral? Just pick it and you go your way. No headache here. So they are not even, in case you don't even remember, is it ventral posterior medial or ventral posterior lateral? They are like, is it ventral? It's ventral. At least I remember when that guy called Festus was drawing the diagram. Just say, let us put everything ventrally, and we start saying ventral posterior. We divide it into two: ventral posterior, the ventral anterior, the ventral lateral. We can now take the ventral posterior and divide it into two again: ventral posterior lateral, ventral posterior medial. And that's just how you will be thinking with respect to question. Let us solve this one. They say that a 62-year-old woman comes to the emergency department due to difficulty walking that started 3 hours ago. The patient also cannot feel anything on the right side of her body. She has a history of hypertension and diabetes mellitus and has smoked a pack of cigarette daily for the past 30 years. The patient's father had a myocardial infarction at age 16. Physical examination shows loss of touch, temperature, vibration, sensation affecting the entire right side of the body. Now say that sensation is also diminished over the right side of the face. Muscle strength is 5/5 throughout. Speech, vision, hearing, taste are normal. This patient most likely experienced a stroke affecting which of the following brain structure. Now, when you see something like this, when we get to stroke, although we've not done stroke, but don't worry, I will try my best to see how we can simplify it for ourselves. When you look at this question, you are seeing something related to tract. Are you getting it? You are seeing something related to tract. Look at this. You are seeing there is loss of touch, temperature, vibration, sensation affecting the entire right-sided body. That's all what you are seeing. No any other information you can see here. If you don't see any other information that is given to you, you start thinking, am I dealing with internal capsule lesion or I'm dealing with thalamic lesion? Am I dealing with internal capsule lesion or thalamic lesion? So don't bother yourself for now. We are still going to do it. When we do it, when you are solving this question, you will be able to answer it. So this is thalamic lesion because this is just all about those tracts. Do you get it? And you can see it affecting the whole one side of the body. Do you get it? The face and even the side of the body. So you are seeing it affecting this right side of the body, entire right side. Then it's also affecting the right side of the face. So you start thinking towards, okay, something like the thalamus. I can't see any cranial nerve there. You won't see any cranial nerve. Whereas if it's cortical stroke, you will be seeing other cortical lesions there. Either they talk about the fact that the patient cannot talk, or they talk about the fact that the patient is having, you will see. I will differentiate it for you. Don't let us waste our time. I will show you when we do it. So that's just how you will be seeing this thalamic nuclei. Certain question of them. Now we come down to the limbic system. What is it about the limbic system? The USMLE wants you to know story. Bring out your book and bring out your pen and paper. I want you to write something out. You must never forget this amaze. Don't be amazed when you get to the exam and you see them testing amaze for you. I brought this out. Amaze, HAMACE. Amaze lesion. These are the limbic system lesion you don't want to ever forget in your life. So amaze, HAMACE. If you master it now, you will not regret it later. So write it. Let's master it together so that I can show you. So amaze. So this H, these are the limbic structures. This H is the hippocampus, A is the amygdala, M is the mammillary bodies, A is the anterior thalamic nuclei, C is the cingulate gyrus, and the E is entorhinal cortex. Out of all these amaze, I just want you to arm yourself with this HAM so that you don't go and enjoy yourself in the exam. Never forget something like HAM. Never forget that at all. So when you have a lesion affecting the hippocampus, the only thing that the way the patient will present is anterograde amnesia. They won't be able to form new memory, and that's all. So they give you a question where the patient is finding it difficult to form new memory. You just say, which structure do you think is likely affected in this patient? The answer will be the hippocampus, Shikina. What about the amygdala? Amygdala, the patient will most especially the bilateral amygdala, when they are affected, the patient will develop a particular syndrome that they don't care whether you know the name or not. Is Clover-Buzy syndrome. Clover-Buzy syndrome. And the way the patient will present is hyperphagia, hyperorality, hypersexuality. If this is a patient that is married, they start having increased thirst for sex. They want to examine everything they see with their mouth. If you give them, don't let me talk. There are some people that practice, only God knows what they have. Anyway, practice oral sex. Maybe this is what they have. They have increased sexuality and they are examining everything with their mouth. Hyperorality. If you give them your phone, they will start putting the phone in their mouth. Hyperorality. Just want to put anything in their mouth. If they hold anything, they just put it in the mouth. Hyperorality. Then they eat a lot. Hyperphagia. So these are just the three. You say them out. Clover-Buzy syndrome. Make jokes out of them. Let them be part of the, at least they become, you can easily remember them. There is a particular infection they will test with you. And never forget, it's just one infection, just one, that they are going to put in question, or they trace someone having Clover-Buzy syndrome and just say that which of the following is likely to be the cause. The answer is HSV1 encephalitis affecting the bilateral amygdala. Shikina. HSV1. The HSV2, when you take a male,
Is there HSV1 affecting? I didn't hear
affecting the
you.
bilateral amygdala. Do you get my point?
Yes, please.
Yeah. So the thing is that you know that HSV, we have HSV1 and HSV2. I'm not aware of HSV3. So just 1 and 2. Both male and female, they have the same mouth. If I just show you the mouth of a male that doesn't have bear and the mouth of a female, you won't know the difference between the two. Do you get it? So that is for HSV1. HSV2, if they show you the private part of a male, the genitalia of a male, external genitalia of a male and that of female, you will surely see the difference. So that is more affected by HSV2. So HSV2 is for genitalia, HSV1 is for the hora. Do you get this? Herpes. So that's more logical. I mean, quite logical and straightforward. In a way, let me put straightforward. So when you are now seeing hyperorality, something related to the mouth, so you don't want to still mix it up and still be thinking towards HSV2 or something. So this is HSV1, encephalitis. Please don't forget. Okay, that's about the amygdala, bilateral one. The lesion must be bilateral before the manifestation will be seen. What of mammillary bodies? So mammillary bodies too must be bilateral. It won't be one, it must be the two. So, and what the patient will present is Wernicke-Korsakoff syndrome. And this is something you already know because we did it very well. I show you some questions in the biochemistry. So, the Wernicke is the, what do you call it? It's like the acute manifestation. They are confused. They are having ophthalmoplegia. They are having ataxia and the likes. Then when you give them thiamine, you correct it. The Korsakoff is when they start losing their memory. And because they are losing their memory, they start confabulating when you ask them questions. You can't remember. Tell people you can't remember. There's no harm in saying I don't know. Do you get it? I just don't know. I can't remember it. So just say I don't know. But they will not say that. They will start confabulating. Where were you working in 1993? You start saying in 1993, I was still in service. We know you were inside. Where were you working? And that time, the work was tight. Hey, you just start confabulating and beating around the bush. So that is what give it out as Wernicke-Korsakoff. When you now start seeing Korsakoff, that confabulation and loss of memory and permanent memory loss, like that, you start thinking towards mammillary body damage, Shikena. And that's all. These are the three. You will see them asking a lot of questions around, testing you on and on and on and on. So others, it's not that maybe they can ask you, but these are still quite highfalutin. But this one are the basic, they expect you not to ever forget. Is there anything with respect to cingulate gyrus? Yeah, it helps with emotion, feeding, mating, learning, and memory formation. So when there is a problem with it, will be problem with feeding, learning, and memory formation. But they won't ask you something related to this. Just keep your focus on these three guys. Practice around them over and over. You will not regret it. Let me show you one or two questions. A 67-year-old man is brought to the physician by his daughter because he frequently misplaces his personal belongings and becomes easily confused. His daughter mentioned that his symptoms have progressively worsened for the past 1 year. On a mental status examination, he is oriented to person, place, and time. He vividly recalls memory from his childhood but can only record one of 3 objects presented to him. So there is anterograde amnesia. They can't really form new memory. And I ask you that which structure do you think is likely damaged in this patient? The answer is hippocampus. Shikena. So no, don't drag it. Don't go and be looking for highfalutin. Neuro is quite straightforward. Once you analyze it, just pick your answer and go. So now, a 52-year-old man is brought to the physician because of a 2-week history of memory loss again. 3 weeks ago, he had a cardiac arrest that required cardiopulmonary resuscitation and intravenous epinephrine was given. On the mental status examination, he cannot recall objects shown to him 20 minutes earlier, but vividly recall memory from before the incident. This patient just had a cardiopulmonary cardiac arrest. Then after that, the patient cannot remember anything again. I love this question. The thing is that I'm going to get to a region where I'll be talking to you about ischemic stroke. I'll be talking about ischemic injury to the brain. The first area you want to put, I'll remember, for the purpose of USMLE Step 1 exam that you're about to write, is the pyramidal cells of the hippocampus. Just say hippocampal cells. Within 3 to 5 minutes, that area is already becoming damaged. So you just want to be very careful. So if this patient, after the ischemic stuff, injury, the patient is now having manifestation of memory loss, it's likely the hippocampal region is already damaged. Shikena, no issue, don't drag it. I will show you, I will remind you this point over and over again till it sticks, and that's all. So let me show you one more question. A 57-year-old man is brought to you by his wife because of abnormal behavior for the past 3 weeks. The symptoms started after he was released from the hospital, where he was treated for herpes simplex encephalitis. Yeah, no one can have that. But what happens is his wife. So his wife says that he has been eating increasing volume of food and recently started putting non-food items in his mouth and licking objects in the house. So I don't know the object the man is licking. Now, so when they are at home, they often rub his genitalia on furniture, hypersexuality, and he has also begun touching his genitalia and masturbating in public. So I laugh because when see people that are masturbating, like, just say that I hope you are not having a herpes simplex 1 encephalitis affecting your brain. Okay, sorry by the way. That's by the way. The patient appeared docile. He is 185 centimeter tall and weigh 132 kg. BMI is 38. He is oriented to person, but not to time and or place. That's just all you need in the question. They've already given you hypersexuality, hyperphagia, hyperorality. Neurology examination shows the ability to follow motor command, but an inability to name objects. The patient's symptoms are most likely caused by damage to which of the following? You start thinking towards bilateral amygdala, shikena. You need to rehearse it, say them, those three, hippocampus, amygdala, and mammillary body, so you don't go into the exam and start mixing them up. Let us see how the set question on mammillary body. A 68-year-old man with alcohol use disorder. You see them related to alcohol use. He's brought to the physician by his sister for frequent falls and unsteady gait over the past 2 months. He has not seen a physician in 10 years. He appears emaciated and inattentive. He is oriented to person only. Physical examination shows a wide-based gait with slow, short steps. Eye examination shows bilateral gaze paralysis and horizontal nystagmus. That's what you put under the canopy of ophthalmoplegia. Now, say 1 month later, he dies. Which of the following is the most likely finding on the autopsy? This is someone that has been taking alcohol. Do you get it? For them to say this person is having alcohol use disorder, it's already a disorder. It's already affecting everything about him. So, which part of the brain will alcohol go and damage? You start thinking towards something like bilateral mammillary body. So, and that's all. So the patient can have small facial hemorrhage in mammillary body, and that will just give it out. There is no any other mammillary body you will see in the question. That's just the one. You pick your answer and you go. And that's all about this limbic system. Let us come to what we call the dopaminergic pathway. What is it? Is there anything about this one? Yeah, I know you know it, but I just want to give you a glimpse into this area. You've all heard about dopaminergic pathway before, but we are going to define. We have pathways here: mesocortical, mesolimbic, nigrostriatal, tuberoinfundibular. I'm dividing them into 2 categories for you: the mesocortical and mesolimbic, one category; nigrostriatal, tuberoinfundibular, another category. Now, let's come down to which condition do we relate to this? Do we relate to this pathway? We relate to this pathway when we are talking about people with schizophrenia. Now, people with schizophrenia or psychotic disorder, they usually have what we call the positive symptoms and negative symptoms. So, positive symptoms, you peg it on something limbic. Okay, say, okay, mesolimbic. And it's positive because you just have increased activity of that pathway and they start having positive symptoms because it is increased. Activity is increased. The symptom will be positive. What are these positive symptoms? Hallucination. Everyone sees. You see, I see, but they are now seeing things other people are not seeing. They are hearing things other people are not hearing. They are just feeling something other people are not feeling. Hallucination. Delusion. Yeah, you can think, you can imagine things, but they just have this strong belief that they just hold on to, and they are just like, no, this is how it is. Someone is pursuing me, someone wants to kill me, this is this. And it's not true. There is no evidence that suggests that, but they just hold on to that. Delusion, disorganized speech. You ask them to talk. Oh, how are you? May we meet your house? What's your name? Oh, I am Shegun. I am Shegun, and I finished from University of maybe Kakalinko. Then from there, I started just spreading cassava on the rock. Then from the rock, my mother called me, and when she called me, I answered her. So in fact, immediately I answered her, I needed to go and sing in the church. You are just like, just from your name, where are we? What did we ask? That is just all manner of disorganized speech and the likes that they just have. Then unusual thoughts, then bizarre behavior. Bizarre behavior in the sense that you just see these people, they just go down the street, Imagine someone going on the street and the person is just bringing out the genitalia just to urinate. I'm like, Tapu, what's going on? People do it a lot in Africa just to show the level of craziness and increase mesolimbic activity, mesolimbic pathway activity in the head of the people. Because people can urinate anywhere and you don't care, nothing. So these are positive symptoms. What about the negative symptom? Flat or blunted affect. When you look at people, you should be able to tell whether they are happy or they are sad. But these people, you can't even categorize their mood, whether they are happy or you don't know. They just have this blunt or flat affect. You don't know whether it's high or it's below, whether it's below normal or above normal. You can't categorize it. Apathy, they just lack interest in things that lack of interest or concern in things that maybe previously interest them. You just have this apathy for it suddenly. Anhedonia, they don't feel pleasure again. Eulogia, poverty of speech, they don't really talk. These are things other people do. Everyone talks. We have affect. We have expression. We have apathy. We have so all these things that other people have is reduced in them. Then you call those ones negative symptoms. Everyone has it, but they just have it in a reduced way. So that is negative symptoms. So the negative symptoms is coming from mesocortical reduced activity. So reduced activity in mesocortical will now lead to these negative symptoms, while the increased activity of mesolimbic will lead to positive symptoms. You see in psychotic people with psychotic disorder. Now, that is just how you relate to these two pathways, just in terms of symptoms. So, just in terms of symptoms. So, when you want to treat, most of the time, someone with schizophrenia, for example, the drug you give them just most of the time target that mesolimbic, the one with positive symptoms. The negative symptoms are still there. So that's why no matter how you treat them, you still be seeing traces of the fact that this patient was once diagnosed with something. Do you get it? So the drugs you use to treat them target the mesolimbic. What are these drugs? You all know them, antipsychotic drug. So they mentioned haloperidol. Which pathway will the haloperidol affect? Mesolimbic. Do you get it? Antipsychotic have limited effect on the mesocortical pathway. So most of the time, the negative symptom will still persist after treatment. And that is all about these two pathways, just in terms of the symptoms. Then when you want to treat, which pathway is your drug targeting? That's all what they want you to rehearse. And you can easily just pick your pen and just write mesocortical, mesolimbic, positive symptoms, mesocortical, negative symptoms. When I give my drug, it will cancel the positive symptoms. So all those positive symptoms are no more there, but the patient will still have negative symptoms because the drug does not really affect the mesocortical shikena. Now, the two other pathways, they are related to the adverse effect of that drug you are now giving. You call them nigrostriatal, then tuberoinfundibular. Those are the two adverse effects. So anytime you want to think about these other two pathways, you want to think in line with adverse effects. That's all. Adverse effects. So nigrostriatal, they are related to motor manifestation. Tuberoinfundibular, they are related to hormonal manifestation. So they tell you that this patient was given haloperidol and the patient just start having some motor manifestation. What are they? I used to write something, I call it rat pan. Rat pan. You all know them. Rabies syndrome, akathisia, tardive dyskinesia, Parkinsonism, acute dystonic reaction, and neuroleptic malignant syndrome. So when you see any of these, you now ask you that which pathway is likely related to nigrostriatal. You just have reduced activity of nigrostriatal pathway will lead to extrapyramidal symptoms. So what of the tuberoinfundibular? Hormonal, someone that is taking haloperidol and just start having, I'm just giving an example, or antipsychotic drug, the patient just start having gynecomastia and start lactating, that they even need to go and bring pail and tie pail to it because the thing is so much. So just start, they ask you that which pathway do you think is likely affected? Here, the answer would be the tuberoinfundibular. At least hormonal secretion is related to a tube tuberoinfundibular. The tubero is related to the hypothalamus, infundibular is related to the infundibular. Do you get it? So not a big term, but you can link it to tubes. So Mona, most common one is the prolactin. So they just have this elevated level of prolactin in there. Shikina. Also, in
Dr.
endo,
Festus.
come in please. In endo, I link it for you in such a way that you won't forget. You are giving them this your antipsychotic drug. They actually, you are giving them to what do you call it? To like block the dopamine effect. So when you block the dopamine effect, it's going to end up increasing prolactin production. So prolactin production will increase when you are giving them the antipsychotic. All I want you to note here is not the stuff here. I just want you to pick. Please pick what I want you to pick. They give you a question that is related to negative symptoms. Mesocortical activity there is low. No wonder they call them negative. They give you a question that's related to positive symptoms. Activity of mesolimbic is high. That's one leading to positive symptoms. When you give them antipsychotic, which of these two pathways will be affected? You say mesolimbic. So what about the adverse effect of that antipsychotic you are giving? They will be related to something like nigrostriatal and tuberoinfundibular. So what is this? These two pathways, their activity reduced. The only one in all these four pathways, the activity is increasing is the one for the positive symptom. All the others, activity reduced. So for the nigrostriatal, if the activity is reducing, the patient will start developing extrapyramidal adverse effects like Rabbit syndrome, akathisia, tardive dyskinesia, Parkinsonism, acute dystonic reaction, neuroleptic malignant syndrome. With respect to the tuberoinfundibular pathway, the patient will develop something like increased prolactin secretion. So which they just start secreting start having milk discharge in their nipple, and from their breast, and that's all I want you to pick, please. Okay, any question?
Dr. Festus, please, can you mention the rat span again?
That's my question too. Thanks.
How come it's the rat that concerns you? Out of this rat, they won't ask you much there. Rabbit syndrome. Do you know the way rabbits used to do their mouth? They will just be moving it like this. Like they are just moving the lips. Just moving rabbit. That's why they call it rabbit syndrome. They also have akathisia. They just have this subjective feeling of restlessness, and tardive dyskinesia, Parkinsonism. This one act like Parkinson. Like they have Parkinson's disease. Then acute dystonic reaction. Then neuroleptic malignant syndrome. Shikina. We are still going to do it in psychiatry. Just relax yourself. You will get to know all of them.
Dr. Festus, sorry, please. I just wanted to click on the negative and positive. I want to see the negative symptoms.
We are still going to do them. Hey.
So hallucination, okay. What about the negative? Like the way you were explaining, I wasn't getting it because I didn't know what the positive symptoms are.
Okay, the positive symptoms are just those ones that normally we see things. If you just start seeing things that others are not seeing, hallucination, delusion, disorganized speech, unusual thoughts, bizarre behavior. We urinate now. Everyone urinates here. How many people go on bathroom and experience their genitalia to be urinating there? These are the negative symptoms.
Okay, but why are we now targeting primary and increased primary and positive symptoms?
That's what the drug. We are not the one targeting it. That's what the drug targets.
Okay.
So the patient will have most of those positive symptoms eliminated, but majority of this negative symptoms will still be there. Shikena. Do you get it?
Yes, thank you.
Okay, I will go. So let me just show you one or two questions just to internalize that. Now, one question I have for you, but this is more of psychiatry. Okay, a 22-year-old man is brought to you by his mother because of concern about his recent behavior. 3 months ago, the patient first reported hearing loud voice coming from the ceiling of his room. During this time, he also became increasingly worried that visitors to the house were placing secret surveillance cameras. So, the mental status examination showed tangential speech with paranoid thoughts. Treatment for this patient condition predominantly target which of the following dopaminergic pathway? The answer is what? Mesolimbic.
Mesolimbic.
Okay. So let me assume that now talk about negative symptoms. Just have
Dr. Festus, something comes to mind. I don't know if it helps. For mesolimbic, that's more of like, so that's like more of the had the positive symptoms. So mesolimbic is loud. So once you see L, so you can relate it to the fact that that's for the positive symptoms. And then another way is that when it came to mind, I can say that antipsychotics are limited to another L to mesolimbic pathway. So maybe if it helps to get you
Okay.
to remember.
So at least everyone you had him, so you can use anyone you wish if you wish. So anyone you like. So just make sure you remember how to solve questions on them. All right. So that's that one. Thank you so much, Dr. Sylvester. Thank you. Now we come to cerebellum. Wow. Probably you even think that cerebellum is a big issue for you. Just relax your mind, sit back, take a call and sip small. Sorry, I wanted to say take water before you damage your mammillary bodies. So just take water and sip small. Relax. You just one concept you just want to pick here. Nothing much. Just to pick just few things. This is the diagram I drew. This is the cerebellum you are all aware of. Permit me to still leave the diagram because it will help you. Okay, let me draw another one here just to illustrate that for you. This is the cerebellum. It has a medial portion. You call that medial portion the femmis. Femmis. Then you have the lateral hemispheres. These are the two lateral hemispheres. The first one, the second one. This is the central femmis. Now, God now picked what we call deep nuclei. In fact, why did we even call deep? See, God picked some nuclei and placed them deeply within the cerebral hemisphere, cerebellar hemisphere. So they now that changed their name to deep nuclei. How are you going to name those deep nuclei? You name those deep nuclei. If you write your letter A, B, C, D, E, F, G, H, A, B, please listen you. C, don't ask me that. I don't understand. Come again. C, D, E, F, G. So the way we label them is like we come, it's deep. It won't be at the periphery. They're actually deep. So you now come to like around this region. We start from D. Let me change the color. You come to something like D. Just write D. You write your E. Instead of now writing FG, we now come to the media. We start our F around the media and move towards the E again, F and G. So you see something like DEG F. So if you come to this one too, you start from peripheral, you go towards the media like D, E, then this will be F, G. You need to draw this thing and do it. That's how your brain will not forget because you are trying to create a connection between your hand and your brain. So that's one thing. So don't just stare at your screen. Also draw when I'm drawing on the sheet of paper. It will help you. So what is this D? These are the deep nuclei. What is this D? D is what we call the dentate. Maybe it look like teeth. E is embolivorm. G is the globus. F is the fastigia. So that is how you know them. Dentate, embolivorm, globus, fastigia. These are the deep nuclei. Now, the two lesions they are going to be giving you in questions, they divide them into two categories. Two basically. The lesion, the first one is what we call the medial lesion. So the medial lesion, you just come here. Is going to just pick one deep nucleus that is centrally located. So you see something like this area will be affected. So if they ask you that which structure is affected in the medial lesion, you say cerebellar femmis and the fastigial nucleus. Shikena. Cerebellar femmis, fastigial nucleus. Okay, let's come to lateral. With respect to the lateral, they ask you that which nucleus is affected in the lateral, or what is affected in the lateral lesion, lateral cerebellar lesion. You see something like this deep nucleus, DEG, dentate emboliform globus, dentate emboliform globus, then the other part of the cerebellar femmis. Cerebellar hemisphere rather. And that's all. So you already have an idea of your two types of lesions. Let me show you again. So this one will be our lateral. This is another lateral. So if they give you this kind of diagram in exam, just be jumping up and know that, no, I can analyze this. This is not cramming. No cramming at all here. You can take your pen and illustrate it. Now let us take human being and draw it. Look at this diagram. That's actually the diagram I drew and analyzed it is what I am trying to do here. So now take your human being, draw human being. When you draw human being, let me manage to draw it for you. Draw one human being for you using another color. So you have human being like this. So this is how the human being will. Okay, let me just use the diagram I drew before. Can you see this human being? You can see that the whole neck, if at all we draw it very well, the neck will look like it's around the center, the medial part. Are you agree? Do you agree with me, everyone? Neck.
Yeah.
Don't mind. Just look at the way I spread out the diagram. At least the neck is around the center. The whole trunk is around the center. Do you agree with me?
Yes.
Then we now have, take the limbs, spread the limbs out. The proximal part of the limbs will be around the media or the center, while the distal part of the limbs will be around the what? Around the what do you call it? The lateral. It won't be around the center. Do you get my point, everybody? Hey.
Yeah.
Yes, please.
Okay, you are getting it. Oh, that's lovely. I'm happy that you are getting it. But if I thought you are not getting it, you are just saying I'm getting it, just for us to move on. That's not good. Okay, so this is how you just spread out the body. So you don't need to pick your pen when you get into an exam to draw this. Close your eyes wherever you are. Close it and just imagine the cerebellum there. And put your femmis at the center. If you are, I am closing my eyes here as I'm saying it. And I'm telling you to do so. Close your eyes. Put the femmis at the center. Spread out the cerebellar hemisphere. Now arrange your deep nuclei from the outside inside. D, E, then go back to the inside outside. F, G. D, E, F, G. Then draw a cycle around the femmis that is also picking the medialmost or the most medial deep nucleus. You take it. Anything that will affect that region will give the patient medial lesion. So for the other side, other parts that you are not around that region, they will give the patient lateral lesion. Now imagine that a patient you are drawing a patient there. The center part of the patient will be around the femmis. The trunk will be around the femmis, around that central region. The proximal muscles, if you spread them out, at least they will span out from the center, from the media towards the lateral. So the proximal region will still be around the medial area. Do you get it? So how will this patient present with medial lesion? Just think about everything around the media. The neck, they will not be able to control their neck. You can open your eyes now if you are still closing them. So they will not be able to control their neck. They will lose control of their neck. They will not be able to control their trunk. They will lose control of their trunk. They start having proximal muscle weakness and the likes. So the tone around that region also may be affected. Do you get it? Proximal limb musculature bilaterally, all of them, they are going to be affected. And that's all. So when you see something related to that, now ask you that, which part of the cerebellum do you think this lesion is? You don't need to have sat down and cram anything here. You just say this is medial. Now, you read this question. Everything you are seeing in this question is just related to distal limbs, distal limbs, distal limbs. What are they? You ask the patient to use the leg. Please, can you do heel to shin test for me? They can't do it. Please, can you do finger to nose, that alternating movement? They can't do it. Pronation, supination, they can't do it. These are the distal limbs. These are the activity that they need their distal limbs to do. They can't do them. Just nail it. You're like, this patient is having lateral cerebellar lesion. Shikena. Don't need to sit down to cram anything here. Nothing. So if they give you the question and they are asking you that which nucleus is likely to be damaged in this patient, just check. Is this a medial lesion or lateral lesion? Hi. Do you get it, my people? Do you get it?
Yes,
Yeah.
yes, yes.
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 Dr. Adu got it. Dr. Chidima got it.
Yes, please.
Dr. Esther got it. So Dr. Joy also got it. I'm happy that you got it, not like Dr. Antonia. So that's lovely. So that's how you are going to be looking at. Let me now add Jara to it for you, that you see them mentioning. So you see something like what they call peduncle, peduncle, peduncle. Okay, I wrote something here. Lateral lesion, lateral structure affected, medial lesion, LTT, loss of neck control, truncal ataxia, motor deficit of proximal muscle, nystagmus. Now, there is a structure beneath this cerebellum that I have not mentioned. We call it flocculonodular lobe. Flocculonodular lobe. If this patient is having the flocculonodular lobe, it's usually affected in medial lesion anyways. So most of the time it is in medial lesion, you see, the patient will develop nystagmus. Nystagmus come from this flocculonodular lobe. And what kind of nystagmus? We have what we call horizontal nystagmus. We have vertical nystagmus. Horizontal just means that the eyes will just be moving horizontally. Vertical is vertical. Okay, this is cerebellar lesion. What the kind of nystagmus you see here is usually most of the time the vertical nystagmus. Do you get? You may see others, but don't forget the vertical nystagmus. So that's just by the way. When we get to the high, I may still talk about it again. So just for you to understand it, where the nystagmus is coming from. So now I mentioned the cerebellar peduncle. So we have the inferior cerebellar peduncle, middle cerebellar peduncle, superior cerebellar peduncle. Think about it. They are actually quite easy. Inferior and middle, they are bringing information to the cerebellum. The superior is taking it out. You are like, oh, how am I going to remember this? Very easy. No, nothing there. This is the brainstem. This is the cerebellum. This is the cerebrum. Information that is coming. This is how the information will come. They come from the lower, from the spinal cord. They enter into the cerebellum. And we look, we are like, how do we name this one? We say, okay, let us name it inferior cerebellar peduncle. Okay. Is there any other information again? The brain can also send information down, snaps on some structures, enter into the cerebellum by themselves. We are like, which name are we going to call this? You say, let us call this one middle cerebellar peduncle. Peduncle is like bunch of neurons. Okay. We are like, how will the cerebellum send its own information out? We now draw another thing like this. Information are now living like this. Where is it sending it to? To the brain. We call this superior cerebellar peduncle. And these are the three peduncles you see. So the superior one is taking it to the brain. The middle and inferior one, they are the one that bring information to the cerebellum. That's all. You can take this diagram and draw it by yourself. So you already have an idea of middle and cerebellar peduncle. Middle and inferior cerebellar peduncle. And that's all. So that's everything about the cerebellum. Let me just show you one or two questions. Probably that may help you. There is one more thing. For me, there's one more thing I need to tell you. The kind of lesion, anytime a lesion affects the cerebellum, it gives ipsilateral manifestation. Ipsilateral manifestation because there are two crossing you talk about with respect to the cerebellum neurons. I just want you to have an idea about it. All you need from me is just the manifestation that they give, ipsilateral manifestation. Do you get it? Ipsilateral. That's why they put ipsilateral here. So let me clean it so that you'll be able to see it. Ipsilateral manifestation. This is the ipsilateral. Ipsilateral. Do you get it? Ipsilateral manifestation. That is crossing, but the crossing you have with the cerebellum, we call them double crossing. They cross first time, they also cross again. So it's like I cross to the other side of the road, I also cross back. So it's like I'm still coming back to the other, to the side I was starting my crossing from. So that's why it's going to end up becoming ipsilateral. So it's ipsilateral manifestation. So don't forget that. So when we read the question, you'll be seeing something like ipsilateral this, ipsilateral that, and that's all. Now, question. I thought someone wanted to ask.
So, Doctor, yeah, so because of the input, so the lesions in cerebellum is mostly ipsilateral lesion.
It's
No crossing.
ipsilateral. It's ipsilateral.
No crossing.
Because, what do you say?
No, sorry, I didn't understand. That's why I'm asking.
But I just explained it now. You wanted to ask that question and I explained it. Okay, probably you were not listening. So what happened is this. The crossing you have, you don't need to bother yourself about where are they crossing from. Forget about that. The crossing is, you have two crossing. This is the road. You want to move from one side. This is the right side. This is the left side. Initially, I just want to use this as an illustration. Doesn't mean that's how it occurs. You now start from the right side. You cross first time here. You still cross back again. So that is what will make the lesion to be ipsilateral. Do you get it? So it's ipsilateral in manifestation. So if they tell you that maybe the right cerebellar hemisphere is affected, the lesion manifestation will also be on the right. That's how you are going to see it. Do you get it? So just ipsilateral, ipsilateral. Just remember the word ipsilateral. That's all. Any other question?
Yeah, Dr. Francis, this rapid alternate just for lateral
Most
cerebellum.
of the time, yes, most of the time they just give you an idea that this patient is having the lateral cerebellar lesion. That's what they manifest. But the way you are going to see it in your question is going to look like they are generalizing it, unless the question is specifically testing, what do you call it? It's specifically testing maybe medial or lateral lesion. But sometimes too, they may still mix them up. Brain is very complex. The manifestation is very complex. You just need to find a way to simplify it for yourself. Chicken. All right. Let's look at this. I have many questions. So, okay. Let us go through them. A 55-year-old man comes to the office due to progressive headache over the past 2 months. The headache are throbbing, often associated with nausea and worsening whenever the patient coughs or bear down during the bowel movement. Medical history is significant for episodic migraine without horror. MRI of the brain with gadolinium reveal a cystic mass as shown in the diagram. Let me show you the diagram. All you want to do is to tell me where the lesion is. I'm looking for the diagram. Sorry, I don't have the diagram. So when you are solving question, you will see it, but I think that's a U-word question. So just give you a diagram, and in that diagram, you are likely to see a lesion within the cerebellum. So they just ask you that which of the following findings is most likely to be seen in this patient. If you look at this, they just talk about right lower facial drop, right homonymous hemianopia, right hemisensory, right hemiparesis, photophobia, left oculomotor nerve, left ulnar syndrome, left disc diadochokinesia. So the answer will be something related to at least all those what do you call it, rapid alternating movements. Just pick it and you go. So these tests, they are more related to the lateral lesion, but it doesn't mean that they can put it unless, let's go through. I wish I see that diagram, but just for you to have an idea. Okay, this question is not about cerebellar. So this is another question just for you to note it. Sorry. A 72-year-old, is there any picture? No picture. A 72-year-old woman is brought to you in the emergency department because of sudden onset neck pain. Okay. Nausea, vomiting, and difficulty walking for the past hour. She cannot sit upright without propping herself up because you need your back muscle, your spine, spinal muscle or paraspinal muscle to sit up. The patient is just cannot just sit up. She has a history of hypertension type 2DM and an atrial fibrillation. She does not smoke. She drinks a glass of wine every other evening. Current medication include enalapril, hydrochlorothiazide, metformin, warfarin. She is 162 centimeter tall and weighs 68 kg. BMI is 27. Her temperature is 37. Pulse is 103. Blood pressure is 205, 148. Neurology examination shows downbeat in nystagmus. Downbeat is more like fatigue in nystagmus. Neck stiffness. Something is happening to the neck. Head bobbing. The head is also moving. Broad base gait. So related to the gait. She is unable to perform a balance test or Romberg test. The most likely cause of this patient. If you look at this, you can see that there is something related to the balance test, or you just call it Romberg test. What is that thing about the balance test or Romberg? You can browse it. Dr. Miriam can browse it and send the picture to the page. So it's just like you ask the patient to bring the 2 feet together in one way or the other and close the eyes or something like that. Just like, and see the way they are going to, and also they can also spread out their hands. So you can check the picture and see, just for you to have an idea of the way it look like. So that's for the Romberg test. So you just realize that they can't really perform it because when they open their eyes, they can do that because they use their vision to compensate for their deficit of balance. Immediately they close the eyes, the cerebellum will only be the one that will sense the joint angle and be like, okay, the joint angle is like this, I shouldn't fall, let me turn like this. But because of the cerebellar lesion, they can't do that. They end up falling. And that's something like Romberg test. Did you get the description I gave there? Hey, let me draw something for you. Dr. Miriam, have you gotten the picture? Is Dr. Miriam there? Wow. Can someone get the picture and just, okay. Let me get it and project it for you. Okay. All right, I want you to just look at this, just for you to have an idea, so that when you see them put it in question, you are not surprised, you have an idea of what is going on. So that's Romberg test, just to test for proprioception. See this patient here. So you just ask this patient and be like, this patient, bring your 2 legs closer. The 2 legs are closed, but the eyes are open. This patient is not falling. The patient can still stand, can't pay. You are like, wow, you are good. At this moment, 2 things are involved. The patient is balancing his gait with the eyes open. You just use a visual. There is a way the vision is connected to the brain and different can just help with the balance. Another pathway that is there that is helping, let us meet our mind, that is helping this patient is the cerebellum. Let us meet our mind, please. Cerebellum. Cerebellum is not seeing anything. That one just sense the joint position and just be like, okay, this patient is about to fall. Let me do it like this. Let me do it like that. That's for the cerebellum. That one just sense the joint position. You now ask this patient, Mr. Man, can you close your eyes? You are trying to cut off the visual pathway. Close your eyes. Immediately the patient close the eyes, the patient now start falling. It shows that initially cerebellum was even dysfunctional. It showed that it's dysfunctional, that the patient was just compensating for the deficit of the balancing from cerebellum by the visual pathway. So immediately you cut off the facial pathway, the patient will lose the balance and the patient falls. Shikena. That is a Rombeck test. You say it's positive. Do you get it, everybody?
Yes. Dr. Festus, my question with that test is like, if like in a normal person that doesn't have any like cerebellar lesion or any
If you close your eyes, you shouldn't fall.
no, but there'll be some swindling. That's what I want to
When
ask.
you are praying in church and you close eyes, do you fall?
No, you don't fall.
Why which swingling are you talking
No,
about?
I mean with the legs together. When you're in the church praying, your legs are up and down, moving sideways.
Dr. Antonia, where you are there, stand up, put your legs together and close the eyes. Will you fall?
I'm not falling.
You won't fall. So if you are falling, something is wrong. Do you get it? So you are not expected. I don't expect you to fall.
I don't fall, but I remember like doing on somebody, close your eyes, and there were some form of like swindling, but the
Don't
person is
mind
not
them. They are doing it intentionally just to pretend that they are under anointing. They used to do it a lot. People used to do it. Thank God you've gotten that. Let me move on. Let me remove this. Sorry that I needed to. But did you get it, everybody? Dr. Antonia got it. What about other people?
Yes.
Yeah.
Yes, we do. Yes, please.
Lovely. Okay. So when we now, as we read that question, they are telling us that the thing is actually, okay, see. It says she is unable to perform a balance test or Rombeck test. It shows that cerebellum is affected. Now, the most likely cause of this patient condition is an injury to which of the following area? You just realize that majority of the manifestation here, they are related to the midline, head bobbing, and neck stiffness, nystagmus, all those stuff. You start thinking towards something like cerebellar femmes, shikina, central lesion, medial lesion. That's all. All right, let me show you another question just for you to have an idea. A 29-year-old woman comes to the office due to right hand tremor for the past several weeks. The patient has difficulty performing daily activity and feels embarrassed in social gathering. She has a history of the remitting relapsing form of the multiple sclerosis. There is no family history of tremor. On physical examination, no abnormal hand movement is observed at rest. When patient is instructed to touch an object on the table, a coarse tremor is observed that gradually increases as the hand moves closer to the target. Dysfunction of which of the following structure is most likely cause of this patient tremor? This patient only have tremor when they have intention of doing something. Let us give it a name. Intention tremor. Only when they have intention of doing something, the tremor will just come. You peg it on something. Cerebellar lesion. Shikena. There is another tremor they rule out in this question. When I do tremor for you, when you read this question again, it will make a lot of sense for you. Family history of tremor. They tell you that there is no family history of tremor. It's only one tremor. You use that family history of tremor to rule out. You call it essential tremor. Any question you read that they start talking about, there is a family history of tremor, or one paternal person used to have tremor too. The patient is also having tremor. Until proven otherwise, likely you are dealing with essential tremor. I will tell you more about it when we get there. So thank God you've gotten this. That's just about the cerebellum. So let's come down to the basal ganglia. This basal ganglia, I'm not going to explain the pathway to you at all. I will just ignore it. And if I'm just going to say anything on the pathway, I'll just mention 1 or 2 points. But just to be tracing it for you, I count it as waste of time. If they will give you a question and you will miss it, that's fine. That's okay. I don't want to put a lot of stuff in your head that you start seeing difficulty in neuro. You don't need it. You don't need it. Basal ganglia, they are important in voluntary motion and adjusting posture. Wherever you are there, you just intend on, let me pick my pen from the table. You will think it, your basal ganglia should help you out and coordinate your muscle in such a way that as some muscles are contracting, another one are relaxing, then you can pick it, and it's not, your hands are not overshooting where they should get to pick that pen. Do you get it? So your hand is not overshooting that region where you want to pick the pen. So it shows that your basal ganglia are working. That's all. That's the summary of the function of basal ganglia. So if there is now abnormality with basal ganglia, you start seeing something like, the patient wants to pick something, maybe at his front, the hand is overshooting it. The patient is having all manner of manifestation that I'm going to show you. Now, what is important in this basal ganglia that USMLE wants you to know is this diagram. Never enter into that exam without mastering this diagram. This is all what they want you to know. Others are just the diagram stuff that you can just add to it. Where all these structures are located, your ability to locate them is what matters most, and how you can recognize the lesion in them. Now, this is the lateral ventricle. The immediate structure, can we mute all our mics? I'm hearing coughs of alcohol. So the immediate structure you see around the lateral ventricle, you call that structure caudate nucleus. Caudate, the way the thing look that is making them to call it caudate, please don't bother yourself. Caudate is caudate. You can start palming this diagram like that because there's no way I can illustrate it to you. You just need to master it. Caudate nucleus. Okay. You will now see a big mountain of a particular structure around this third ventricle. Here, this is the third ventricle here. You call those two structures, this big one, you call them thalami, the thalamus. Right and left thalamus, thalami. Okay. Underneath the thalamus, we have what we call subthalamic nucleus. That is, this one is under the thalamus. So this is subthalamic nucleus. You will find it directly under the thalamus, subthalamic nucleus. Then there is now another structure you will see around below the subthalamic nucleus. That structure look highly pigmented. It is the only one that will look pigmented amidst all of them. It's the only one. And that is what you call substantia nigra pars compacta. So this is substantia nigra pars compacta. We are going to solve question on this. So be ready. And it's all about diagram. So substantia nigra pars compacta, this is it. Okay. There is another structure that look lentiform in nature. We call it lentiform nucleus, and it's divided into two, the putamen and the globus pallidus. These two inner structures are the globus pallidus. This outer one is the putamen. Now, the space between the thalamus and the lentiform nucleus, you have a structure that passes through that space. You call that internal capsule. Internal capsule. So this is your internal capsule. So let us start again. Caudate nuclei, thalami, subthalamic nuclei, substantia nigra pars compacta, lentiform nuclei, putamen, globus pallidus, external and internal capsule, Shikena. That's all. 80% of your questions will just come in you identifying this structure and attaching a lesion to them. And you will see the way we will attach a lesion to them. Okay. I've brought out those structures that are important and the lesions that are associated with them. Let us be picking them one by one. Substantia nigra lesion. I call substantia nigra. I call it substantia nera. Why do I call it nera? In Yoruba land, nera, thank you so much, Dr. Miriam. Where have you been before? Where were you? You were sleeping. Okay.
I was checking.
Okay, you were chilling. You were in which stage? All right. So I call it substantia nera. In Yoruba land, nera means difficult. You know, they will say it's nera for you. That is, it won't be difficult for you. So anytime I read a question that the motion is difficult, the lesion is in substantia nigra. What kind of disease condition can you picture? You picture Parkinson's disease, where the motion is difficult. And that's all. That just give out. You don't need to know much about Parkinson's. When we get there, we just add one or two things to it. Just give it out on this Parkinson's disease. substantia nigra lesion. Okay, on the football field, we have striker. Strikers need to be very aggressive. If you are not aggressive enough, you can strike. You can't be a striker. I hope I'm not a fan of football. I don't watch football, but I hope I'm saying the right thing. There is a condition they love to peg on I love to peg on this aggressiveness. We call that condition Huntington disease. One thing characterized when you are reading that question and they just start seeing something like the patient is aggressive. You just see the term aggressive towards this is now becoming more aggressive, or the patient is just look at the option and pick your Huntington disease. It is when you are aggressive, you are like a striker, you can hunt down a dribbler. I hope I'm making sense. I hope I'm not saying rubbish. You can hunt down if you are like a striker, like you can hunt someone down on the field. So when you hear the word striatal lesion, the condition they are trying to test with you is Huntington disease. And what you will see in the question I will give it out is aggressiveness. Shikina. Just that one word that changed the diagnosis. Okay, that is striatal lesion, substantia nigra, difficult, Parkinson, striatal lesion, Huntington. What about the subthalamic nucleus? I only need a letter in amidst all of them. There is only one of them that has letter H in it. Others don't have letter H. I'm not talking about the thalamus, so I'm not talking about the hypothalamus. So just all these caudate nucleus putamen, subthalamic, and the substantia nigra, and just this one I listed out. It's only one of them that has letter H, and that is subthalamic nucleus. That's the only one, and that is the one that will manifest with hemibalismus. Ballistic is like you've heard about ballistic missile, where they launch it just go pew. Let me show you something like this. It's just going to go like this. Just launch it. Ballistic missile, ballistic pendulum in physics. So what happened is that they will just tell you that this patient is holding something. Then after a while, maybe the patient is holding a phone. Then after a while, that hand that is holding the phone just swing the phone away. Involuntarily, just swing it away. Just swing it away. You can't even control it. Now say, where do you think the lesion is? Subthalamic nucleus. Okay. What about the lentiform nucleus? Lentiform nucleus. There is a condition they love to peg on lentiform nucleus, and you all know it. And that condition is what we call Wilson disease. Wilson disease. They give it another name. You call it hepatolenticular degeneration. What it means is this. There are two structures that will be affected in this patient. The liver and the lentiform nucleus. Basically, other structures may also be there, but you don't want to joke with these guys. And it's related to copper abnormality with copper metabolism. Copper metabolism. So when the copper starts accumulating, it's going to damage the liver. It can also damage that lentiform nucleus. And the patient will come down with this hepatolenticular degeneration. Okay. So, and that one will help you out. Just seeing, because hemochromatosis too can also damage some structures. But hemochromatosis will not go to the lentiform nucleus and be damaging it. So that when you see the question, you won't be thinking, is it about copper? Is it about iron? This is about copper. Hepatolenticular degeneration. Internal capsule. One thing about the internal capsule is this. When we get to stroke, I'm going to talk about it more, likely tomorrow. So by tomorrow, we'll definitely get there. So I will talk about it more. So I'm likely to stop on this page. So I will talk about that one separately. But the patient can manifest with contralateral pure motor or pure sensory or combined sensory motor deficit. So I'm going to show you how the question will be coming for us to note it. So don't worry. So that's that about this region. So now the last point I will make for you is you noting the striatum. What comes together to form the striatum? What comes together to form the lentiform nucleus? And I will also talk about glutamate and GABA. Striatum, what is coming together to form the striatum is putamen and caudate nucleus. P and C, they form the striatum, like you say SPC, suprapubic catheter. Striatum, putamen, caudate nucleus. The caudate nucleus is the one that will give, if it's affected, it will give the patient cognitive dysfunction or symptoms. The putamen, if it's affected, it will give the patient motor symptoms. Now think about it. I mentioned a condition that you see when there is a striatal lesion. You call that Huntington disease, right? So the Huntington's disease may have motor manifestation and cognitive manifestation, depending on which nucleus is affected. So if it is all about the putamen, the patient will manifest more of motor symptoms. If it is more of caudate nucleus that is affected, the patient will manifest more of cognitive symptoms. But something will definitely give it out. That is what? Aggressiveness in question. It will give it out. What about the lentiform nucleus, putamen and globus pallidus, whether external and both external and internal? Two of them will come together and form the lentiform nucleus. Now, the last point is about the neurotransmitter we talk about. The two neurotransmitter, I'll just mention it briefly with respect to this pathway.
Dr. Festus, sorry, please. In that diagram, where is the striatum?
This is it now.
Oh, okay.
These two structure, caudate nucleus.
Okay.
All right.
Okay.
Apart from that, I hope you've got all the other story I was saying.
Yes, thank you.
Okay. So these are the pathway. We have the direct pathway, indirect pathway. I'm not going through the pathway for you. I just want to mention a point. So you want to note the excitatory neurotransmitter there. And the one you don't want to forget is the dopamine. Dopamine. If dopamine is not there, glutamate, shikina. Dopamine. If it's not there, glutamate. Dopamine. If it's not there, glutamate. Okay. The inhibitory neurotransmitter, GABA, and GABA. Okay. This patient, this is for direct pathway, this is indirect pathway. No one is going to ask you to be. Even if you see a question on the pathway, you just ignore it and move on. They won't ask you. So, but in case they tell you that, okay, this patient is having maybe Parkinson's disease, we want to treat, which area are you going to ablate or something like that? I think you should just ignore those questions. Don't bother yourself. I don't want to create, but in case you want to think globus pallidus internals and subthalamic nucleus. Anytime you want to think about, they want to ablate something or something in this pathway, just be thinking around these two guys. That's all. Whether you understand what they will do, which I don't want to be going through the pathway. Not that I don't know what to tell you, but I don't want to be creating unnecessary sin on this one. Just forget about it, because no matter what, it's still going to, you won't be happy with it. Even if you say you know it now, later you still forget it. So what's the essence? So just in case they say, which area do you want to ablate in the patient? Just be thinking towards this globus pallidus internals and subthalamic nucleus. Any of these two, just be checking for it in the question, and that's all. All right. So let us do small exercise before you go. Maybe tomorrow we can solve questions, because all of you are already sleeping there. You just tell me where the lesion is once I mention it. A patient that is having Parkinson's disease, where is the lesion?
Substantial nigra lesion.
Someone is having Huntington disease, where is the lesion?
Striatal lesion.
Striatum. Someone is having hemibalismus, what is the lesion? Where is the lesion?
Subthalamus.
Someone is having what again? Okay, I think those are the basic one I emphasized there. Is there any other one? Lentiform, yeah. Okay, please let me just I feel like solving few questions with you so that you can quickly internalize it. Give me 20 minutes. I'm done. A 72-year-old man is brought to the emergency department due to involuntary movement of his right arm that started several hours ago. He was watching TV when his arm threw the remote control across the room. His past medical history is significant for long-standing hypertension and diabetes mellitus. Please, what's the diagnosis there?
Hemibalismus.
Hemibalismus.
So which structure is affected?
Subthalamic nucleus.
Just pick your subthalamic nucleus and don't let us waste time. So see this question. Let me show you the basal ganglia here. It's good for you to solve questions now because you can some of you will still want to go and solve questions. No. Sorry. 1 minute, please. Yeah. So they just give you this diagram. This is the diagram they gave you. So this is just the diagram. It now asks you that just be looking at the diagram. A 62-year-old man comes to the office with left arm clumsiness. Physical examination reveals motor weakness involving the left arm and leg. Patient speech is slurred and there is drooping of the left lower face. On passive flexion of the left arm, there is initial resistance followed by sudden release of tension as flexion continues. A lesion affecting which of the following brain structure is most likely? So what do you think they are describing? There is resistance to motion.
Motor function is
motor, so putamen.
Motor function.
Okay, let me read the question again. Physical examination reveal motor weakness involving the left arm and leg. The patient's speech is slurred. There is drooping of the left lower face. On passive flexion of the left arm, there is initial resistance followed by sudden release of tension. Which condition do you think they are likely describing based on your past?
It's clasp knife. Clasp knife.
I don't care about whether clasp knife or knife clasp. So I just want you to mention something like
Parkinson's.
Yeah, I just want you to mention that there is a lot of resistance. Although we've not done it, we are still going to do it. Do you get it? But these are things that I feel you should know. They usually have what we call the shuffling gait. They have all manner of resistance when you want to flex or extend their hand. I mean, their upper limb. They have resistance. They have slow. They are very slow, and they also have resting tremor, something like that. So they can put all of them in question, and that's what they can just put them in question for you. Just be like, this Parkinson. And I ask you, where is the lesion? So where is the lesion for the Parkinson?
It's not labeled.
Substantial nigra.
No, where is the lesion? Option A or B? That's my.
Not labeled.
Option B.
Not labeled yet.
It's not labeled.
Am I even sure this is the diagram?
Just below the.
Okay.
It's not labeled.
Okay, this is what I'm going to do. So let me stop here. I will go through all those diagrams very well so that I don't waste your time. So enjoy the rest of the day. We are going to go through that question again. I just hope that it's the same diagram. I'll go through it just to be very sure. Okay, enjoy the rest of the day. We meet tomorrow. Be getting ready to solve a lot of questions.
Thank you so much.
Thank you. I will learn something today, everyone.
Thank you.
Yes.
All right.
Thank you.
Yeah, well done. Okay.
Thank you.